Join with computer audio. Hello. Hello.
Yes, ma'am.
Yeah. Am I audible?
Yes, ma'am. We'll start in webinar mode now.
Okay. No, I was just checking everything, so I just wanted to confirm. Am I audible?
Yes, ma'am. Yes, ma'am.
All right. Thank you.
Good afternoon, Dr. Aarti.
Hi, Dhara. How are you?
I'm fine. How are you?
I'm good. You look nice.
Thank you.
Hello, ma'am. Good afternoon. So now we are in webinar mode. Good afternoon, everyone. I am Nagraj on behalf of IIP Digital Media Team. Welcome you all to today's webinar, international virtual event led by WOW Group and organized by Khyati College of Physiotherapy and Khyati Institute of Physiotherapy in association with Association of Physiotherapy and IIP Women's Health, Gujarat State. And this event will be live on IIP India YouTube channel. Please subscribe and share on all social media platforms for recent updates. Now, without wasting time, I would like to hand over the session to today's event host, Dr. Diti Desai. Dr. Dhara ma'am, you can take over the session.
Thank you so much, IAP India team, for this wonderful platform that you have provided to us. I would hand it over to Dr. Diti Desai ma'am now.
Good afternoon, one and all. I welcome you all to Khyati Wow PreCon 2022. Let's end the silent suffering. It is an international event led by the WOW Group, organized by Khyati College of Physiotherapy in association with Khyati College of Physiotherapy and Khyati Institute of Physiotherapy in association with IAP and IAPWC, Gujarat. Khyati College of Physiotherapy was established in the year 2015 and Khyati Institute of Physiotherapy was established in the year 2014, are both flourishing branch of Khyati Foundation, led by pillars, Mr. Karthik Patel sir, Chairman Khyati Foundation, and Ms. Binita Panchal ma'am, Director Khyati Foundation. Both the colleges are affiliated with Gujarat University. Now, I would request Dr. Dhara Sharma ma'am, Principal of Khyati College of Physiotherapy and President of IAP Gujarat, to say a few words.
My heart is welled up with joy today. What a wonderful afternoon, a weekend before an International Women's Day, and we are here today addressing quite an important issue that goes on around women's health, the pelvic floor dysfunction and pelvic floor rehabilitation. What a better way to expand the scope of physiotherapy in addressing women's health and addressing the issue which is usually considered a taboo even to talk about. There is so much of cultural stigma on just talking about this topic, that is pelvic floor dysfunction, and we are going to spend these 2 consecutive days just addressing this issue and what is the role of physiotherapy in addressing the pelvic floor dysfunction. Along with pelvic floor dysfunction, there is going to be other aspects also, like musculoskeletal dysfunctions, then osteoporosis, there is male pelvic floor rehabilitation, and sacroiliac joint dysfunction, prenatal, postnatal. So there are wonderful topics that we are going to gain knowledge on over this weekend. Additionally, we are also, having the speakers who are across India. There are speakers who are so meticulously chosen, and they are going to share their expertise and experience on these relatively untouched topics of pelvic floor rehabilitation and women's health. When we planned this event, it took a lot of meticulous planning, and I must mention that the encouragement came from 3 different sources that I must mention here. First one that I want to mention is that the management, Khyati College of Physiotherapy, as well as Khyati Institute of Physiotherapy, Dr. Anju Akhtar sir, who is not, due to some circumstances, he was not able to join us today. But the help that was rendered by the management as well as from Khyati College and Khyati Institute was amazing. Second one is the coordination with all the speakers, choosing the topics and meticulously planning the entire event, and the lead that was done by WOW Group, Dr. Het Desai sir and Dr. Dhara Shah ma'am. They had relentless efforts putting, so much efforts making sure that this event turns out to be a grand one. And last, but definitely not the least, how can I forget my own family, IAP and IAPWC, and IAP and IAPWC Gujarat, because of whose constant efforts, support, and encouragement that we are here doing this event in association with IAP and IAPWC Gujarat. I must mention the ever-inspiring legends that who are with us today. Dr. Sanjeev Jha sir, Dr. Ruchi Varshne ma'am, and the entire CEC, who has constantly supported us, and their work inspire me so much, to be very frank. So I'm so grateful that we have so many senior physiotherapists, as well as Dr. Ruchi ma'am and Dr. Sanjeev Jha sir is here with us today. Not taking much of your time, now I would request Deepti ma'am again to take over the stage and introduce our chief guest as well as guest of honors and other dignitaries who are going to be with us for today's afternoon. Before I leave, I would just want to thank all the participants who are here that have, they have shown their commitment towards improving themselves and upgrading themselves, and thus broadening the horizon of physiotherapy. Thank you so much.
IAP is the largest and strongest association among India for the physiotherapists, and it represents the physiotherapy worldwide, as well as it does increase the awareness about the physiotherapy and is uplifting the professionalism continuously. It is also associated with, it is also part of World Physiotherapy. We are fortunate enough to have Professor Dr. Sanjeev Jha sir, our chief guest, and also the director of CCDR and director of SPS group of companies, and our guest of honor, Dr. Ruchi Varshne ma'am, treasurer IAP and IAP WC national head. I would like to say, Ruchi ma'am, please share some words with us.
Thank you, Diti ma'am. Thank you for the introduction, kind introduction. I think IAP India technical team can help our chief guest to join. There is some problem in the connection, so they can talk to Dr. Sanjeev Jha sir and help him to join. He's trying to do it. In the meanwhile, good afternoon. Good afternoon to all the group of institute, to the WOW group, Dr. Het Desai, Dr. Dhara ma'am is here, to the entire IAP Gujarat team, and to IAP Women's Cell Gujarat team. Thank you for this wonderful initiative taken. I must say, yes, as Dhara ma'am said, the weekend before International Women's Day, what better way to celebrate it? And what a grand way to celebrate it. I think reaching out to all the physios, not only in the country, but also across. The Indian Association of Physiotherapists has 52,000 plus members all across the world. And I proudly represent IAP Women's Cell as well, because this is a female dominated profession. And the theme of the conference absolutely justify our role, meaning let's end the silent suffering. The the line of speakers that you all have chosen, I must appreciate the organizers, that what a way of celebrating the International Women's Day. It's really tremendous. Great speakers, great topics. I think you are really expanding the scope of physiotherapy in this direction, which was actually a little behind than other streams. And we are sure that this will happen, and this will happen very soon, because now nobody is silent. If I am sitting here, I must say there is no silent suffering now. We all are vocal. The IIT selling in 120 plus districts all across, with team led by Dr. Bhavna ma'am, IIT President, strong women, Dr. Nehal ma'am, the seniors like Dr. Neeta Vyas ma'am, everybody here, all the seniors sitting here, my warm gratitude to all of you to make this possible, to actually raise our voices for for our professional rights. What the participants will be listening today is more about the physical, ending the suffering physically, emotionally, and other aspects of women health. But yes, it's high time that everybody should come together to end the suffering for the profession as well, because we together are the strength of the association. So let us all come together, let us all work together for the betterment. And thank you so much, ma'am, for inviting me as your guest of honor. I am really honored and obliged. Thank you so much.
Thank you so much, ma'am, for the wonderful words. IAP and IAPWC works hand in hand, and IAPWC is exclusively working for women empowerment. Today, we have State Head IAPWC Gujarat, Dr. Bhavna Ghadvi ma'am. Ma'am is Principal and Dean, Parul Institute of Physiotherapy, Parul University. I would request ma'am to say a few words.
So a wonderful good afternoon to everyone. I, Dr. Bhavna Ghadvi, IAPWC State Coordinator of Gujarat, is welcoming you on behalf of IAP and IAPWC whole Gujarat team onto this wonderful event, Pre-Women's Day, which is very auspicious occasion for all of us who are present here. And I must congratulate Khyati Foundation, WOW, IPRI, and IAP India for conducting such a great event, which is actually needed in these days, because we are speaking out with so much of things related to physiotherapy, but we actually need to be vocal for the women's health, for the pelvic floor health. And there are some taboos and there are some misconceptions about the pelvic floor rehabilitation, not into physios, but into non-physios and other medical professions. So by this kind of conferences, so many get motivated and so many get knowledge about how the pelvic floor rehabilitation is being carried forward in the field of physiotherapy. So I must congratulate both the teams of Khyati Foundation and WOW-I3 for arranging and organizing this conference, and my best wishes to the organizers. And I must thank Dr. Ruchi Vashna ma'am and Dr. Sanjeev Jasar on behalf of IAPWC Gujarat team to always inspire us and to always support us or motivate us to do so many things on the IAP platform. So thank you so much. I will use this platform to offer my gratitude to them.
So thank you so much for providing us such a vast platform so that we can do whatever is needed for upliftment of our profession. I must congratulate Dr. Dhara Sharma and Kate Desai for leading this conference. And my best wishes to all. Thank you.
Thank you so much, ma'am. Dhara ma'am, Jasar is joining in a while.
Let's wait for some time so that Jasar can join us, and then we can proceed further.
Yes, definitely. In the meanwhile, I would like to thank the entire IAP India digital team for your always ready support for the entire country, I must say, meaning more than 250 districts, and they all are operating, they all are professional physios. So I want to congratulate and thank them also to make this possible for the entire physios of the country. Thank you so much. I think Jasar has joined. Please check, ma'am.
We'll wait, ma'am, for by the time he can join.
Yes, ma'am. Sir has joined.
Yes. Welcome, Dr. Sanjeev Jha, sir. We are starting with the conference, pre-conference, and would like to hear from you. So can you please share a few words?
Hello.
Yes, sir.
Yeah. Somehow I joined now. I was actually driving and thank God somehow I could join. Thank you, Dhara madam. Thank you, Ruchi madam. And thank you, Desai sahab, for organizing this wonderful program, which is having a very different topic. And I feel that in this country, women health is something which needs to be more addressed to as far as physiotherapy is concerned. And I wish all the best from the side of IAP and IAPWC also. And I wish all the best to IAPWC Gujarat particularly and IAP Gujarat State. I feel these type of programs will give a new dimension to this profession. And the topics what you are taking in this pre-con is, I feel this should be properly addressed to the people, and it should go to the root level of the participants, because unless and until we talk a lot about gynae physiotherapy, women's health and all this, but still it is not there in the real blood of physiotherapist. So I feel there is a lot of responsibility, particularly to those people who are working in this field, to put it into the real blood or RBC of the human of physios in India. And this is a very good job, and we need to explore the field more and more. And from the side of Central CEC and from the side of Central IAP, I wish all the best to all of you. and particularly everyone, all the senior people who have joined from the Gujarat state and Gujarat state IAPWC. Thank you, Dhara madam. Thank you, Ruchi madam. And thanks everyone who are directly or indirectly related with this program. All the best from my side. Thank you.
Thank you, sir.
Thank you so much, Jha sir, for these wonderful words and blessings from you. It means a lot when Jha sir and Ruchi ma'am and so many senior physios like Bhavna ma'am, Aarti ma'am, all of the other senior physios who have joined with us today. We are really grateful to have your blessings with us. Thank you. Thank you so much.
Thank you. All the best. Thank you.
Thank you.
Thank you so much. With all the world silently suffering from intimate health issues, is even taboo to talk about, as ma'am said. To break this taboo, Dr. Hed Desai sir have started and are the founder of WOW Group. And as a chief assistant, as a lead assistant to Dr. Hed Desai sir is Dr. Dhara Shah ma'am, MPT PhD scholar. Ma'am is clinical instructor, WOW IPRI, and is contributing in designing and developing the pelvic floor rehabilitation workshops. Now, I would hand over to Dr. Dhara Shah ma'am to say a few words and then proceed with the event.
Good afternoon, everyone. First of all, I would like to thank all the attendees for joining in this wonderful educational celebration. As rightly said by Dr. Dhara ma'am, Bhavna ma'am, Ruchi ma'am, and Sanjeev Jha sir, that it is a need of an hour to talk about silent suffering, pelvic floor, and women's health. So I'm really very thankful to each and every speaker for your valuable contribution. Yes, it was a meticulous work, but the speakers whom we have chosen, they were so prompt in responding, and they took they didn't give us any hard time to come back and go forth again and again, and it was a wonderful thing. It is a wonderful event which we will be going ahead with. Thanks a lot to Khyati College of Physiotherapy and Khyati Institute of Physiotherapy. And my special thanks to Dr. Dhara Sharma ma'am, who is also my lecturer, for organizing such a wonderful and fruitful event for all the professionals. A heartfelt thank to our chief guest, Dr. Sanjeev Jha sir, and our guest of honor, Dr. Ruchi Varshne ma'am, for her valuable presence. I would like to take this opportunity to introduce all of you to Dr. Hed Desai sir. Many of you might already be knowing, but it is always a great pleasure for me to introduce him, as it is always an inspirational part for all of us. So sir is the first serial innovator with multiple government recognized pelvic floor innovative technologies, and he is the author of Amazon's bestseller #1. It is his vision that is to courageously break the cultural taboo and to make the pelvic floor rehab accessible to every single woman and every single man on the globe through innovative technologies and services. To his academic contributions, sir has HITS MMT, HITS FMT, HITS ring clock assessment, HITS surf assessment, HITS providers protection guidelines, HITS reflexive result scale, HITS female sexual function scale, and HITS male sexual function scale. To his innovations and intellectual properties, his WOW PF360, WOW Women, WOW Men, WOW Group mobile application, and Easy PFM exerciser, We Fit and We Ease. I would also like to, even though sir couldn't be present here, but it is my privilege and humble pride to keep his presence in his absence. Hed sir has specially conveyed big thanks to Dr. Sanjeev Jha, Dr. Ruchi Varshne, Dr. Dhara Sharma, Dr. Anjum Khatri, Khyati Foundation, IAP, IAPWC, and IAP Digital and Technical team, to all our licensed clinical instructors and WOW IP, all the speakers, participants, delegates, and everyone who has supported this event in one or the other way. We sincerely appreciate all of your solid support for pelvic floor rehab and women's health. Let's get together with innovative concept with a great vision to end this silent suffering. With this, I would like to welcome our first speaker. She's none other than Dr. Aarti Mahishale. She is the professor and HOD of Obstetrics and Gynecology Physiotherapy, KLE University, Belgavi, Karnataka. She's also serving as an additional post of Assistant Coordinator, IQAC. She is also the member and council member of BOS. She has almost 32 national and international publications. She has also given more than 40 talks in national forum and around 3 international forum. Dr. Aarti is also associate editor of Indian Journal of Physiotherapy and Research, and also an editorial member in Indian Journal of Health Science, KLE University. Let's welcome our first speaker, whose credentials, experience, authenticity, and great work in the field of women's health will be beautifully reflected in every single word of her talk on scientific comparison of transvaginal transrectal pelvic floor assessment techniques. Over to you, Dr. Aarti, ma'am. Dr. Aarti Mahishale.
Yes. Good afternoon, everyone. Thank you, Dr. Dhara, for that warm introduction. Shall I share my screen?
Yes, please.
All right. Before I start my talk, I would like to thank Dr. Het Desai and Dr. Dhara for giving me an opportunity to be on this wonderful platform and sharing my expertise in this field, so it can help us grow together, because it's not a change at one geographical area. It should involve the entire nation. So to begin with, my topic is scientific comparison of transvaginal and transrectal pelvic floor muscle assessment techniques. Now, to begin with, I will not go much in detail about the anatomy of the pelvic floor muscles, because I think these all we are acquainted to from our undergraduate level. So we would like to know that, yes, pelvic floor muscles, a knowledge of this pelvic floor muscles forms the basis of our assessment. So to know that we have the floor in which we have a superficial layer, a deep layer, we have the urogenital triangle, we have the 2 canals where we will be going in details of assessment would be the vaginal canal and the rectal canal. So I would be talking in specific to these assessment techniques. And broadly speaking, the pelvic floor functions to support all the organs of the pelvis. It helps in control of the bladder and bowel. It helps us pass urine and feces in a coordinated manner. A very wonderful function is its sexual activity or sexual function, where we have tried to analyze a lot of sexual dysfunctions for which we know that where the pelvic floor dysfunctions are contributing to. Yes, it is a part of breathing, where we know that with every breathing, the pelvic floor functions in accordance. And pregnancy and childbirth is again a very important part of a female's life, where a strong pelvic floor muscles is a must for these normal functions. Now, to talk about broadly the pelvic floor dysfunctions, we would put it into 2 categories. I would put it into first is a supportive dysfunction, where there is laxity of the whole pelvic floor. And because of this reduction in the laxity, there is increased risk of all these what I have listed, like there's increased risk of prolapse, incontinence, it could be mixed stress, urge, increase in the frequency, it could be fecal incontinence, it can lead to cystocele, rectocele, and the whole uterine can get prolapsed. So this would be under the domain of a supportive dysfunction. And the second, where we usually miss on when we are in our clinical settings, is the hypotonous dysfunction, where these are the symptoms which include the back, perivaginal, rectal, lower abdomen, could be the posterior thigh, coccyx, or any burning in the clitoral or the vulvar area. Now, there are a list of conditions also listed in the hypotonous dysfunctions, like piriformis syndrome, levator ani syndrome, vulvodynia, I think Dhara would be the best person to talk on vaginismus, how to go in for assessment. And they have derived and come up with a lot many options and inventions in these conditions. But this forum is not for me to go in detail of each of the conditions. So I would rather request the organizers to have more workshops on this. So putting on all these dysfunctions into hypertonus and supportive dysfunctions, I would go about with saying what is actually needed in the pelvic floor muscle assessment. Now we know that a detailed history taking and a physical examination which definitely underpins the diagnosis and the treatment of pelvic floor dysfunctions. I would rather say that in clinical setting, if you take the detailed history, your 40% of diagnosis is already done and 60% remains on the physical examination. Now, in the 60%, I would contribute to 80% of pelvic floor assessment is reliable or relying on pelvic examination. And this is a must to investigate any pelvic pain, chronic, acute, and usually we start with a single digit and a double digit palpation. So pelvic examination forms the basis of any pelvic floor dysfunction. Now we know we have a variety of conditions. It could be a joint condition, it could be a muscle condition, or it could be a myofascial pain, which we say is widely a recognized source of chronic pelvic pain now. And studies have estimated it to be around 90%. And these are the ones which will help us to rule out the trigger point palpation. And this is again one of a very important aspects in clinical examination of pelvic floor. Now, when we go in for digital palpation, because this becomes a mainstay, I cannot introduce all the instruments at a start because instrument is not going to give me the feel of the muscle. It is not going to give me the comparison between the right and left. So palpation remains the mainstay and the basis of pelvic examination. So palpation of the perineals, the levator ani muscles, piriformis, the obturator internus muscle are in isolation, where we can do these muscle palpation in isolation can be done only with digital palpation. Now, this is a picture where I'm just showing you how we go about with palpating the muscles. Now, if I teach my students or someone in a workshop that you should start palpating the obturator internus this way and levator ani this way, I hope none of you all would sense and would be clear about what is happening, right? So to ease this examination, a very good innovation by Dr. Haidt is his ring clock assessment technique. So when we say that if we are visualizing this pelvic floor in crook lying position as a clock, right? The symphysis pubis is at the 12 o'clock and the sacrum is at the 6 o'clock, whereas the two transverse the sides are the 3 o'clock and the 9 o'clock. So Sir has wonderfully come up with Haidt's ring clock assessment, where a therapist should imagine a clock in this whole oval circle of both area, vaginal and rectal. So separately a clock is visualized in the vaginal canal and separately a clock is visualized in the rectal canal as well. Now, till now, even before I underwent this transvaginal rehabilitation and getting associated with the WOW group, I had a fair idea about the assessment of the pelvic floor muscle as a superficial layer and a deep layer. So it is by this ring clock assessment where Sir has wonderfully put up the first layer, which is externally palpated, and a second layer, which is internally palpated, should be identified. So when in per vaginal examination, we insert either a single finger or a bidigital finger. The therapist should imagine an oval area of the first layer of the pelvic floor muscle, and somewhere around 2 centimeters deeper, if we go for per vaginal examination, there would be a second layer of the pelvic floor muscles. So this is very beautifully put forth in Haidt's book as well. So this is a vaginal canal where the ring clock is set up like 12 and 6 and 3 and 9 at the transverse perineum. And the whole anal canal also is viewed as a ring clock where we have to go in for a per rectal examination. Now this becomes very easy for us to palpate. Like if I get back to this image and now I say that palpate the obturator internus on the right side and the left side from a direction from 12 to 9 and 12 to 3 to compare on either sides. And if I say you have to palpate for the levator ani from 9 to 6 and 3 to 6. Now this makes it very easy for one to understand the concept and go about with a clinical assessment, which our instruments will not do. Which our instruments will not find trigger points, only the digital examination, which is much eased by this ring clock assessment, would give us a better idea about the myofascial pain. As I said, this would be the superficial ring clock, what Heath sir has put up. And there is a deep ring clock as well, where the same, as I said, 2 centimeters inside. When we go from superficial, we have a deep ring as well. And again, this is can be assisted in the form of 12, 3, 6, and 9 fashion, both at the vaginal canal and the rectal canal. Now, palpating the pelvic floor muscle according to this ring clock assessment, as I said, the muscles should be palpated individually from a specific direction. I would suggest to go from 12 to 3, 12 to 9, because I want to compare the uniformity between the right and the left side. And similarly, from 3 to 6 and 9 to 6 to see any differences between the sides of the pelvic floor. So we then ask the patient to do pelvic floor exercises or contraction to measure the hypertonicity or the hypotonicity of the pelvic floor muscles in these areas. Now, what we should be noticing is, as I said, there can be a difference in the sides. So there could be an asymmetrical presentation of the muscle feel that we are doing with digital palpation. And it might be due to the inability to contract and relax as well. It could be a hypertonous, asymmetrical scenario in this pelvic floor muscles. We could palpate for trigger points and we could diagnose whether the pelvic floor is hypertonous or hypotonous. Now, this detailed examination will help us to create a plan of care, because I know that how much ever I keep giving exercises or with instruments, unless until we release these points, there is no further go. So a planned treatment includes these basic assessment as well. So it's a very good innovation by Dr. Heath Desai sir to put up this ring clock assessment and to make it more precise for diagnosis and therapeutic measures. Now, how do we start? Like from superficial, I'm starting with the hymenal remnant. It has to be examined very gently. And below this hymenal remnant is the bulbospongiosis. Often it is tender at 3 o'clock and 9 o'clock. So it is at the transverse, right? So internally, when you examine a little more further, we will find the muscle pubococcygeus. And this is palpated at the 4 and 8 o'clock directions on either side. Now, this is the muscle which is more commonly having the trigger points, and releasing these trigger points becomes our therapeutic goal. Now, a detail of these would be taught in the workshops which are held by WOW IPRE. Again, as I said, I'm giving you an overview about the comparison of the scales. So I would go in detail about what scales we use for pelvic floor dysfunctions. Now, everybody know that we have the Oxford grade scale. Initially, this pelvic floor muscle word was not termed or was not included in the older one, but the modified Oxford scale has now included precisely some more broader terminologies like no discernible pelvic floor muscle contraction. However, the grade is done on a 0 to 5 scale, where we say 0 has no contraction and 5 has a very strong contraction. But there are limitations when you go to use this modified Oxford scale, because it looks at only the contractile part of the pelvic floor muscle and not the relaxation part of the pelvic floor muscles. I think way back till last 4 or 5 years, you ask anybody, what do you know in pelvic floor rehabilitation? So everybody used to say that Kegel nor had assessment, nor had a specified protocol of therapy. But all that, okay, we do credit to him because he initiated the terminologies, but he worked, or he put forth that it's all about contraction, and that also was not quantified. Now, the two major limitations with this Oxford scale is it cannot assess the relaxation, as I told. And in other words, we cannot check the grade of hypertonic pelvic floor muscles. Like, for example, if a lady comes with vaginismus, she would have had a tight pelvic floor. So it would become very difficult for us to even do a pelvic floor per vaginal examination also. So in that scale, do we do assessment? Do we grade her, or do we just stop because we don't know what to be done for this kind of condition? Because our Oxford scale does not give us the grading of relaxation. It only takes up with the dysfunctions of supportive structures, where there is laxity and the female can contract, how far she can contract, whether it is good, moderate, zero. That is the one limitation of the scale. The second limitation of modified Oxford MMT is the strength is measured as weak, fair, moderate, good, strong. And these terminologies, yes, they are subjective, and they would definitely vary from one person to person. Pretty many examples where our students assess and we assess, the grading becomes different. So these are subjected to bias. It can over or underrate the patient's condition also, and it can give us a false way of structuring the therapy. So how would you differentiate gray versus black versus white? So this is not clear with the Oxford modified scale. Now, I found few studies where these are studies which have been published in BMC and PubMed, where they have tried to evaluate the inter-rater reliability of this modified Oxford grading scale. And they found that the inter-rater reliability for vaginal palpation was fair, which is coming to very less kappa score. And they concluded that vaginal palpation, though is an important clinical assessment technique, the study does not support the use of modified Oxford grading scale as a reliable and valid method to measure and differentiate the pelvic floor muscle strength. So when this is put forth in PubMed, we had another article in BMC Urology, where the aim of this study was to find the reliability of pelvic floor muscle strength assessment in healthy continent women. And they also found that though there was good intra-rater concordance between the anterior and posterior pelvic floor assessment, though we see the percentage are slightly lesser than what we grade as acceptable. However, they concluded saying that the inter-rater reliability of the two examiners did vary from moderate to good. So there are subjective bias in the scales, what we have come forth with. But with the scale, what Dr. Hayes sir has come up, you can see that this scale gives a grading of contraction as well as relaxation. So grade 0 is a baseline tone where we have to measure, and this is with, again, per vaginal examination. And we can grade it on a scale of 1, 2, 3, that is plus 1, 2, 3, or minus 1, 2, 3. So if I have to tell you what is the scale, if per vaginally, how well is the contraction of the pelvic floor of a woman? With per vaginal, I may start with single digit or with bidigital. Usually when it is laxity, we should start with bidigital, because single digit, it's very difficult to feel the contraction on. So with bidigital examination, if the female, we have inserted it, say, for the superficial ring and then with the deep ring, so both assessment can be graded on the scale. So if the female circumferentially is exerting a contraction, mild is graded as 1. The complete vaginal canal is gripping the fingers that I inserted, right, is graded as 2. And with this grip, she is able to pull the vaginal canal upward with the resistance offered, is grade 3. So we can see that the circumferential complete measurement, these words are very important for someone to understand how you should use the assessment. Now the reverse is the relaxation part, where grade minus, I'll go from here, grade -3. A female has such a tight vaginal canal where per vaginal single digit palpation should be done for tightness. So -3 would be asymptomatic penetration of the finger. -2 would be there is some penetration, but the female has pain. And grade -1 would be the female is not allowing the finger to palpate per vaginally. So no penetration is, say -1 is no penetration, grade -2 is symptomatic penetration, and -3 is, yes, the per vaginal insertion is comfortably and she is not symptomatic. So this scale of Head-Sir does classify or differentiate between the contraction and the relaxation part, where both can be seen in a pelvic floor dysfunction. So a study on Head's pelvic floor MMT was done on 92 females who had normal pelvic floor, who had hypertonus and hypotonus. So all these types of females were assessed using the Head's pelvic floor muscle testing and grading. And the study found out that the retest reliability to be high, as good as 0.91 to 0.96. Also, the inter and intra-rater reliability was found to be higher, where the intra-rater reliability was more than 75%, which is an acceptable score for a scale. So this paper has already been prepared, and we are in the process of submitting this and getting it published, for which I would suggest or request everybody working in the field of women's health should take the reference of the scale and the reliability, validity of the scale, and can start using it in their research to have more precise data. Now, coming to the perfect scale, though, yes, they have given more than what only the contraction part of the Oxford scale. They have given how fast is it, how every contraction is timed, the repetition, endurance, performance. Yes, it is a good scale, but he still uses the Oxford MMT, and more it is again concentrating on the contraction part, as we have seen. So the limitation of the perfect scale, again, there are two. Performance is what is measured in perfect scale is again using the modified Oxford scale itself. We just saw the limitation is a little less accurate. Measuring, when they say that, when you see the scale, they say that muscle strength assist falls to 50% of the maximum voluntary contraction. So how do we derive to this 50% reduction in MVC? This becomes very difficult. It is again subjective and vague for assessment. So to overcome these two limitations, the scale put forth by Dr. Head would make it more simple, precise, easy to calculate. I'm not saying that don't use perfect scale, but where I have used in practice this scale, I use it in clinical practice, and we have seen that yes, we are able to measure, differentiate. I also suggest that you can go in for comparison of these two scale in future. That could be one of its own research study where we can pick it up. And we saw that SURF scale has the strength and relaxation component, like what we saw in the +3 and +-3 grading. The endurance is also given due weightage, where the hold for 10 seconds is being calculated, repetition 10 on 10, where we'll have to see that how many times the female can contract, and the total score should be 10 on 10. So we can put her into what's a weak, fair, moderate pelvic floor strength, depending upon all these. And again, the fast muscle twitch, which we have left behind, when we do a Oxford scale or when we do a per vaginal examination, the female is very much aware how much to contract, and it is the slow twitch muscles which are contracting where you are assessing the strength. But when we sneeze, when there is an intra-abdominal sudden increase in pressure, where we lose urine and incontinence, the first muscle to come into action are the fast twitch fibers. And these also have taken into the scale where we can grade these fast twitch fibers. So I feel the SURF scale gives us a complete overview where relaxation, fast twitch muscles are also given due credit to. Now the reflexive result scale, also you can see that the patients are able to read it, understand it, a detailed way of scoring the pelvic floor in case of reflexive results. So this scale also is a very good scale which sir has put forth. I'm not talking in detail of the female sexual scale or function scale and male sexual function scale, because they are again on its own a very unique scale which sir has come up with. Now, to summarize my talk, because I was given 20 minutes, I would say that Haig's pelvic floor muscle testing scale are valid. We have proven the reliability, they are more accurate. It is more objective because we have tested it in between our students and therapists, where it is more objective and having a good inter-rater reliability. The clinical diagnosis is complete with whatever variety of scales, and we are not sticking on to only one scale what we had earlier. So we have a scale to grade contraction, relaxation. We have the more detailed assessment of the pelvic floor in terms of SERF, right? Reflexive, the RR scale and grading also is helping us to know the other functions as well. The scales which are more precise to female function, sexual function and male sexual functions have again give us an upper hand to take these scales and do research, where we earlier did studies on sexual dysfunction. We didn't have much scales to administer and take and we always used a scale which was being formulated by a person who is outside our country. We have always been adopting the scales which others have been using. So these scales can be used extensively in research with multiple parameters testing and not sticking on to only contraction and grading one. So if we have multiple parameters, we know that our studies will have multiple data and it can be published in a larger way. So I would say that these are scientifically better than what we were adopting the other scales previously, because these are the scales which are constituted and contributed by an Indian pelvic floor muscle specialist. So I would thank Dr. Haig Desai sir for constantly involving me in whatever talks he has, or he's made me his team member, and very proud of it. Thank you very much, Dhara. Thank you, Dr. Haig sir. And thank you, Khyati Physiotherapy College, for giving me an opportunity to be on your platform. If any questions, I would like to take it. Thank you.
Thank you, Dr. Aarti Vaishali ma'am. As such, we are not going to have question answers round here, but they can then drop their questions into the chat box and we can address them later, because we are having some time constraints. So that's why. But thank you very much for your presentation and valuable presence.
Thank you.
Thank you so much, Aarti ma'am. It was a wonderful session on assessment of pelvic floor, and quite insightful on which scale to choose from to assess the pelvic floor and what techniques to use. Thank you very much.
Thank you.
Next, we are going to have a session on technological transvaginal transrectal assessment of pelvic floor muscles, which will be taken up by Dr. Dharasha ma'am. So I request ma'am to start the session now. And there's one request to all the speakers. I please request you to stick to your timeline. We have 20 minutes allotted for each session, and we would also want to stick to our total timeline of the event as well. So if you overshoot, that would be injustice to other speakers who are going to follow up. So I once again request you very gently that please stick to your time only. And yes, now I hand it over to Dr. Dharasha.
So let me start with my screen sharing. And today the topic which I would be taking, that is on technological transvaginal transrectal assessment of pelvic floor muscles. So we just now had talked about the importance of assessing the pelvic floor muscles. So it is to evaluate the relaxation and the contraction of the pelvic floor muscles, to have a more functional goal, to plan a better management, and to document the progress. But as Dr. Aarti rightly said, that 80% of your pelvic floor exam, of your assessment, can be your manual assessment and other assessments. But just why we have to focus, like today's topic for me is why we have to focus on the objective assessment. The manual assessment, what we are doing, it is perfectly fine and it is most required, because the pelvic floor rehab which you are going to give would be through your through a transvaginal or a transrectal approach. But when we talk about the objective assessments, it can be a case, like just a small case for all of you, that a 25-year-old female presented with urinary incontinence of stress. So she had a stress urinary incontinence, whenever she used to laugh, she used to jump, she used to do exercises, she used to leak. But when we did the manual assessment, she had a very good static pelvic floor muscle strength. In the sense, she was good on MMT, HITS MMT, she was good on HITS of assessment, she was good for all other dynamics on the static scale. But then why urinary incontinence? Ever wondered the reason why? Because pelvic floor muscles, those are the postural muscles, those are the supportive muscles, those are the stabilizing muscles, and those are the muscles which should constantly work against gravity and during the functional activity. So here comes the word functional activity, and so is the other word associated is functional strength. No matter how good is your static strength, if you do not have a proper functional strength or you proper coordination between the muscles, the pelvic floor muscles and the other muscles, you might not be able to perform better, right? So Head sir, he always say that our goal for our patients is to have a functional output. It's not just to have a static output. So then what are the other objective measures or technological tools which can be used to check the pelvic floor, the pelvic floor muscles objectively? Okay, or so the first one in the line is the perinometer. I don't have to give you all about the information of perinometer. It is the most commonly used tool so far. But if we try to understand the functioning of perinometer in depth, it is measuring the pressure of your pelvic floor muscles, or you can say the intravaginal pressure is being measured, but it is not measuring the strength of your pelvic floor. There is a difference when we talk about the strength component and the pressure component. Yes, the pressure which is generated is considered to be a reflection of the strength, but then it's not giving you an idea of the functional strength. Okay, so the perinometer, as you can see into the screen, you can see here, there would be a vaginal probe which you have to insert transvaginally inside, and then on the screen you will see that how much pressure the female is trying to generate, and that is all you are monitoring. And there is no baseline tone. Every female can have different vaginal pressures. The only thing you have to think is, like, if your pressure is like 30 mmHg when you started, how good or how far are you reaching in your rehab? So that is the whole game of perinometer. Nowadays the perinometers are also, another thing is, it might be difficult to use the perinometer when you are checking the functional strength. So you can think that how difficult it would be for a female to use a perinometer and then to jump, then to cough, then to laugh, then to squeeze, just to see that what is the reflection. So the other thing which is commonly used is the EMG biofeedback or the electromyography. Now we all know the electromyography component, that is the electrical, it activates or it catches the motor amplitude of the muscles which are being assessed. But the major drawback to electromyography is the cost. The cost which is involved, it can be around, it is not in thousands, it is in lakhs. I'm really sorry, but if you can mute yourself, that would be better. It's creating some disturbance. Please mute yourself. So when we talk about the costing, the EMG can be, it is not in thousands, it can be in lakhs. Okay. Second thing is it has an extremely high sensitivity. High, what do you mean by extremely high sensitivity of crosstalk? If you're assessing the pelvic floor muscles, but if your other muscles work, like surrounding muscles, adductors or glutes, even if they work, very minutely, that can be registered by the EMG. And so there can be an false interpretation or a misinterpretation if you are not a trained professional to do that. Okay, so the second limitation you can see, or the second understanding we can have, is if you want to have an accurate EMG reading, you need to have a very much experienced professional to do it. Okay, and it can be very much difficult for the patient to do it on her own. Fine. So I just have the I'm just showing you a demo of, this is how there can be various EMG devices which are available. If you want to purchase, you can contact the dealers and they can give you the ideas. But this is one instrument which is like, you can see, I'm not starting it. I'm just giving, these are the, you can see the surface electrodes, and this is the screen. And another thing is these are the transvaginal electrode. So you can see the transvaginal electrode. These are this big, and there would be the metal rods which are inserted. And this is a single patient use. So if one patient A is using, patient B cannot, because you cannot have condom over it, as there is a metal surface or a metal interface which will be collecting the signals. So every patient needs to have separate. It can be an additional cost for your patients as well. And third thing, as I said, that it is difficult for the patient to do it alone. Fine. The next thing which is there, I'm not saying that you cannot use this. If you have, you can definitely use it, but there can be more simpler yet efficient ways. As we are evolving, we need to evolve in all the directions. So the next comes in the list is the ultrasound. Now, when we talk about the ultrasound, it can be a real-time ultrasound. What it is done is you can keep the transducer suprapubically to see the activity of the pelvic floor muscles. But again, it is not giving you an accurate idea about the strength. It will just give you an idea about how much the lift the pelvic floor is able to generate and how much the pelvic floor is relaxing. So you can just see the lift at the neck of the bladder, the movement of the bladder, and I can assume that how much would be the capacity or the strength. It is too costly, and more than cost, it is liability, because if you want to have an ultrasound machine, you need to have all the PNDT formalities to be taken care of. All the legalities should be taken care of. The PNDT rules in India are quite strict. So you need to have license, you need to have proper idea and understanding of the ultrasonic machines. But the major limitation is it cannot give you an idea of the functional strength. Okay, so maybe it will be really difficult to accurately measure the functional strength of the patients. And again, it cannot be done independently by the patient. Okay, so you cannot use all these technologies or tools to check the pelvic floor muscle functional strength at home, or if you're giving a home exercise plan, the patient will have to come back to you for an for a functional assessment though. So in order to bridge this limitation, one of the limitation which I missed in pereniometer is that you cannot check the hypertonous pelvic floor. As Dr. Aarti rightly mentioned, vaginismus, dyspareunia, chronic pelvic pain, penetrative dysfunctions, it is a wide list of constipation. interstitial cystitis patient, it is a wide range of conditions which can fall under the broad term of hypertonous pelvic floor. And if that is the case, like if you see, if you are seeing a patient who cannot just even relax her orifice, who cannot relax, then there is no point. How are you going to insert the transvaginal probe for the assessment? Okay, so you need to first understand that how can you objectively grade even the relaxation component of pelvic floor muscles. So when we are talking about the relaxation component of pelvic floor muscles, so you can use VEs. This is wow, VEs. It is again an intellectual property of Dr. Desai sir, and it is unpatented. And you can see this wow is which is developed. It is developed with a vision to train as well as treat the patients who are suffering from penetrative dysfunctions, or you can say the hypertonous patients. So we have to start with the narrower end and you have to progress to the broader end. Now, if suppose you are seeing a patient of hypertonous pelvic floor and you want to know that how much is the relaxation component, the functional relaxation. Why do we need to talk about the functional relaxation in case of hypertonus? Because when you will go into clinical practice, you can come across a lot of patients who can have a presentation like they would allow you maybe for a pelvic floor examination, but when it comes to the sexual activity, they might not be able to perform it in an appropriate way, or they might have pain during the activity. Okay, so in order to find out that what is how is their functional behavior and how much can they contribute, that pelvic floor tightness is contributing into the sexual life, you need to find out the functional relaxation also. Right. So the first is like, if the patient is, I'm just going through the grades. So grade C means an inability to penetrate even the narrow end. So if this, considering this as the vaginal orifice, if the patient is unable to have even a narrow end penetration, she is in so much of pain, she is in so much of tightness, she is in so much of discomfort that she is not allowing you to penetrate even the narrow end, that is a grade C. Extremely tight pelvic floor muscles. If the patient is allowing you to penetrate either the narrow or the broad end, but with symptoms. So you can read here, symptomatic penetration of narrow or broad end, pain, tightness, or discomfort. Any of these symptoms are present. So she is allowing you for the penetration of the narrow end, but that is with symptoms, even the broader end, but that is with symptoms. So that means it is a grade B, tight pelvic floor muscles. If the patient is able to have a easy and pain-free penetration of broad end, okay, you can see the structure. This would be more of a functional shape for the sexual activity. So if the patient is able to have a complete and easy and pain-free penetration of the broad end, the broad end can easily penetrate without any discomfort. That means it is a completely relaxed pelvic floor muscles. And the next would be to check the strength component of the pelvic floor muscles. So the strength component of the pelvic floor muscles, you can see this is the head, this is V-fit. You can say this is the head of the V-fit. These are the ridges of the V-fit, and this is the rod of the V-fit. Now, when you have to use this V-fit, what you have to do is, assuming this as the vaginal canal, you can assume this as the vaginal canal. This, if the patient is standing in this, like this, in standing position, she has to be in the standing position. And then in standing position with condom, we need to check both the V-fit and V is with condom on. So you can then simply insert the V-fit. The patient has to go for self-insertion. She can insert the V-fit inside in standing position, and then she can go for 3 functional activities to check what is the strength of the pelvic floor muscles. Now, as soon as she insert, without even starting the functional activity, if like the moment she has inserted in, if this falls down, it falls out before either immediately or before completion of any of these activities, that would be a grade C, that is extremely weak pelvic floor muscles. Okay, if the patient is able to do all the functional activities, 3 calf, 3 squats and 3 jumps with V-fit inside, but it is just sliding out a bit, in the sense once you inserted it inside and you are cuffing it's just sliding down a bit, but it is staying there, it's not falling out. That means it is B, it is still a mild level of pelvic floor muscle weakness or weak pelvic floor muscles. And if the patient is able to complete all the 3 activities, like 10 calf, 10 squats and 10 jumps, keeping this inside, that shows a strong pelvic floor muscles. In order to understand better, I have kept a video, and for this the consent is already been taken from the patient. I will just run this video so you can understand it better, and then you will be able to understand the whole concept of pelvic floor objective assessment. So this is a page, you can just go through the video. I hope it is running for you. Now the patient has started cuffing, and you can see that the moment she is cuffing, the V-fit is sliding down, and now as soon as she started to squat, it fell out. So once again, I'm playing it. So now she's cuffing, she's doing 10 cuff, and you can see the sliding of the V-fit down. And the moment she is starting her squat, it is falling out. So this means it is a weak pelvic floor. It is a extremely weak pelvic floor muscle, a grade C. So this objective testing, when you do, what is the importance of this objective testing? So when you do these types of objective testing, it will help you to understand that the pelvic floor muscles need to function into the functional activities as well, and it will be a better perception for the patients to understand that yes, their muscles are weak. So at what level they are weak, how shall they progress? If at all, if she is able to do all the 3 activities with V-fit, the next thing which you can do is you can increase the level of resistance, and you can add the resistant ball, and then you can ask her to do all the activities. So the goal should be that the patient should be able to be as strong as +3 on HMMT and as completely relaxed as -3 on HMMT. So yes, this was all from my side. Thank you very much once again for joining us into this educational celebration. Khyati, wow, PreCon 2022, and I hope this 2 days event is going to be wonderful for all of you. Thank you. I would like to stop my presentation here.
Thank you, Dr. Dharasha, for this wonderful presentation on objective assessment of pelvic floor. Once again, I would hand it over to you only to proceed further with the other speakers and their sessions. Thank you.
Thank you very much, ma'am. And yeah, so the next speaker whom we have on board, I'm so happy to announce her name. She is Dr. Bhavna Gadvi, ma'am. She was my lecturer, and for those who don't know, I will always be grateful for her because she was the one who referred me to HSR. Thank you, ma'am, for everything you have done so far. And ma'am is the Dean and Principal of Parul Institute of Physiotherapy in Parul University, Baroda. Ma'am is also the State Head of IAPWC Gujarat. She also has presented talk in more than 50 national and state level conferences. Ma'am also has 12 research publications in national and international journals. She's also the member of editorial board of Journal of Society of Indian Physiotherapists. Ma'am will deliver the speech on physiotherapy management for osteoporotic women. Over to you, ma'am. Thank you once again for joining all of us.
Once again, thank you so much for inviting me on this platform conference, which is the great for especially for pelvic floor rehab.
Ma'am, sorry to interrupt, but your voice is very low. If you can.
Is it audible now? Is it audible now?
Yes, a bit, ma'am.
Okay, is it audible now?
It's audible, ma'am, but now there is an echo.
Yeah, now it would be audible.
It's audible.
Yes. Okay. So once again, thank you so much, Dr. Dhara Sharma, Dr. Rahid Desai. Is it still echoing?
Yes, ma'am, it's echoing.
Now tell me, is it still echoing?
No, it is better now, ma'am.
Fine. So because I have joined from two devices, just for the cautious measures, so that if I lose internet from one device, then I can continue with the other. That's it. Okay. So thank you so much once again, Dr. Dhara Sharma, Dr. Het Desai, WOW-I3, Khyati Foundation, IAP India, IAP Gujarat, everyone for inviting me to take a small short session in this pre-con of WOW-I3 and Khyati Foundation. Let me start with my screen share. You will have to give me 1 minute for it. Is my screen visible now?
Yes, ma'am, it is visible.
Okay, fine. So thank you once again, Khyati Foundation and Dr. Dhara Sharma for arranging such innovative conference, because this is very important nowadays to have awareness, not just the awareness, but multiple things related to women's health. And on the occasion of Women's Day, we are very pleased to share the knowledge which is very important to be done on the Women's Day, right? So my topic for today is physiotherapy management for osteoporotic women. As I have considered the mixed audience of clinicians, UG students and PG students and the other academicians, I have made my presentation very short and sweet because of the time limit also. So as everybody know that what is osteoporosis is, it is a metabolic disorder characterized by low bone mineral density and deterioration in the microarchitecture of the bone tissues. By definition or by parameters, if we say, then the osteoporosis by WHO has been defined as whenever the bone mineral density is been reduced from 2 peak bone mass is the important factor in osteoporosis. So whenever we ask the patients about osteoporosis, we first of all feel that let us see about the bone mineral density. But bone mineral density is not just the parameter for which we need to focus on. We will have to even check for the peak bone mass also, because they go hands in hand whenever the symptoms arises or whenever the clinical condition arises. So peak bone mass is the maximum mass of bone which is usually achieved at the age of 25 to 35 in every adult. So whenever, if you check it below 25, then it could be less, and if it is more than 35, then it is less physiologically, but due to as a process of aging, if we call it as, right? 15 to 20% of men and 30 to 50% of women suffers from fracture, which is related to osteoporosis in their lifetime. So whenever we see the patients of fracture, we first of all ask them for their age, and when we correlate their age, and we don't if we correlate it with the bone mineral density, then maybe the predisposing factor to have that fracture, maybe traumatic or something like that, to have that fracture, maybe the osteopenia or osteoporosis. Now let's see about the generalized classification of osteoporosis. So there are two types of classification of osteoporosis. One is Nording, which has classified osteoporosis as a generalized osteoporosis and a localized osteoporosis. Means there are some bones or some conditions which causes a local bone less in the bone mineral BMD, whereas generalized is overall the body composition of BMD is reduced. Whereas the Riggs and Melton have classified it into primary osteoporosis and secondary osteoporosis. Now, what is that? In primary, it is type 1 and type 2. When type 1 is there, which usually considers the postmenopausal phase. So when we talk about postmenopausal condition or postmenopausal osteoporosis, it is a type 1 primary osteoporosis. And type 2 is a senile osteoporosis, where the other conditions which is from the either the congenital or acquired from the childhood or a pediatric condition, which also have many other predisposing factor, not just the menopause and the hormonal imbalance. Now the other one is secondary osteoporosis, which also have the predisposing or underlying systemic condition which actually disturbs the bone mineral density or the or maybe the blood calcium level. So it's like not the bone mineral is reduced and then the blood calcium is reduced. It may be the condition which causes the disturbance in the blood calcium level, which causes the bone mineral density or bone calcium level, and which causes the osteoporosis. Now, if we see the normal bone remodeling in the adult age, it gradually increases in the bone mass until the 30s. But after 30s, as the age increases, the peak bone mass gradually decreases. So what are the causes of osteoporosis, or how are the three main hormones which works for the calcium balance in the body? So there are two types of calcium in the body. One is the calcium which is deposited into the bone, and the other one which is there into the blood. Now the blood calcium has its own functions, like it has functions with the nerve conduction, it has functions with the muscle contractions, and it has other functions also. But the calcium has only one function, and that is, first is deposition of calcium, which is there extra in the body, and second is to give the skeletal stability or to give the strength to the skeleton where the weight bearing is being loaded, right? So these three hormones which maintains these two types of calcium, or these two parts of calcium into the body. First is calcitonin, which is the thyroid hormone. Calcitonin, which inhibits the bone reabsorption and promotes the bone formation. So calcitonin actually works for the calcium deposition into the bone. So whenever the calcitonin gets reduced, maybe with the aging or maybe some systemic condition, the bone mineral density reduces, or there are chances of osteoporosis. Now second one is estrogen. Estrogen has its own function, or estrogen is the hormone which actually regularize which inhibits the bone breakdowns, osteoclastic activity. So when the estrogen levels goes down, there are more amount of osteoclastic activity, which actually causes, or which in turn causes the osteoporosis. And then the third one is parathyroid hormone. The parathyroid hormone actually increases the calcium amount of calcium or calcium level into the blood. So when there is some conditions which reduces the blood calcium, maybe the absorption of intestine, maybe the intake, maybe some vitamin D deficiency or some other deficiencies which actually reduces the blood level calcium, then the parathyroid hormone gets activated, and which extract the calcium from which extracts calcium from bone and deposit it into or increases the level of it into blood. So when the parathyroid hormone increases, there are chances of osteoporosis, right? So you need to understand these three hormones and its function. So if we see calcitonin and PTH has exactly opposite functioning. Okay, now let's see the risk factor and causes of the osteoporosis. As we all know, and the title of my topic is osteoporosis in postmenopausal women. Why it is so, as I have already explained about the estrogen level, which is very important factor for maintenance of calcium into bone. But when there is menopause, like premenopausal, perimenopausal, and postmenopausal, mainly the estrogen level got reduced, and due to that there are osteoporosis, or there are chances of reduction in BMD. So the risk factor for females are more prone than males. The risk factor is low peak bone mass is reduced at the age after 35. So when after 35 itself, the body has reduced peak bone mass, and again on top of that there is a estrogen level or reduction in the estrogen level, which again causes the more prevalence or more risk factor for the osteoporosis to develop. Now, due to lack of estrogen, calcium incorporation into the bone decreases with the increasing age, as I have already explained about. Now, with increasing age, it's not just about the peak bone mass, but it is also with increasing age, there are chances of multiple systemic as well as degenerative conditions into the body. Due to that, there are pains. Due to that, there are limitations of activity. Due to limitations of activity, there are chances of reduction in the vitamin D3 also, as the person is less explored to sunlight. And second thing is, due to the less physical activity, there are less chances of bone mineral density, reabsorption of calcium into the bone. So again, increasing age does not only affects with the by the hormones, but also affects by the low physical activity also. Inadequate calcium or vitamin D. So in the conditions where there are inadequate calcium or inadequate vitamin D3 or vitamin D3 deficiencies, right? So in this conditions, or in this type of systemic conditions, there are chances of osteoporosis. Estrogen deficiency, as it is not just during the menopause, there are multiple conditions where there are estrogen deficiencies also. So these are the risk factors where the chances for osteoporosis increases. Now the causes of osteoporosis, as we have already discussed multiple things into this, so I'll just list it out. Metabolic conditions like calcium deficiency, vitamin D3 deficiency, malnutrition, or scurvy, where actually the calcium level is reduced. Endocrine conditions where there are hyperthyroidism, hyperparathyroidism, or hypothyroidism. So again, when the calcitonin reduces or when the PTH increases, there are chances of these are the causes of osteoporosis. GIT or liver diseases. As I said, the absorption of calcium from the GIT due to some liver conditions or due to some GIT conditions, which in turn, or due to some conditions, there are D3 deficiency, which in turn leads to low calcium level into the blood and low calcium level into the bones. Bone marrow infiltration. So there are conditions where there are bone marrow infiltration happens due to some carcinogenic conditions or some other systemic disorders. These are the causes of osteoporosis. And lifestyle, as I said, excessive caffeine, alcohol, smoking, immobilization, the sedentary lifestyle. Nowadays, the sedentary lifestyle causes more amount of reduction into the vitamin D3 and calcium level. So that is also more, the primary or the prominent predisposing factor. Now, whenever we see osteoporotic women, or whenever we see the woman with menopause and patients is having any pain or anything related to osteoporotic symptoms, then we need to go for examination. First of all, we will have to see BMI, whether the person is overweight or normal. So height, whether there is any height loss. So why height loss is there? Because of the less amount of BMD, bone mineral density. The the disc the body of the spine gets reduced into the size, or there are chances of compression of the vertebral bodies, which causes the height loss or body weight. We also consider the obesity and overweight. Next is posture. Again, whenever there is osteoporosis, a severe osteoporosis may lead to, as I said, compression of the vertebral body, which in turn lead to the deformities like kyphosis, humpback, or the spinal deformities. The flexion deformity mainly basically because as the center of gravity is anterior to the thoracic spine, there are chances of flexion deformities into the thoracic spine, and that is why there is a kyphosis. Now, skin fold. We need to check about the skin examination also. So we need to check the skin fold thickness and grip strength. As with the age or with the decreased amount of calcium level into the body, there are chances of less amount of muscle strength also, or the muscle strength also reduces. So skin fold thickness, grip strength also needs to be checked along with the other examination. Tooth has to be examined primarily along with the other musculoskeletal examination, because there are chances of tooth pain, that is toothache, tooth bleeding, or gum bleeding, we call it as. So gum bleeding and toothache are the prominent symptoms along with the musculoskeletal conditions, symptoms, sorry. Now, let's talk about the physiotherapy management. So, physiotherapy management are into two forms. One is the preventive physiotherapy, and second one is the curative physiotherapy or symptomatic physiotherapy, when the patient comes with some of the symptoms along with the osteoporosis. So, we need to treat them, right? So, first is preventive physiotherapy, where we need to educate the patient for proper posture. So, when patient has a low it's not just osteoporosis, but the patient is in a stage of osteopenia, or even not in a osteopenia, but they are into the stage of menopause, where there are less where the hormonal imbalance is there. Then we need to educate them for the prevention, because we don't have to wait till the estrogen level goes down and till the BMD goes down. Right. So preventive is more important than the curative things, because curative we can't go much into once a deformity has been developed or once the fracture has been occurred, right? So to educate the patient for proper posture, so sitting posture, standing posture, weight bearing, lifting, handling, everything has to be properly taken care of or educated to the patient. Teach safe way of moving and lifting. Why? Because whenever there are osteoporosis, there are chances of compression fracture or stress fracture. So you need to take, as a physiotherapist, it is our role to teach them the preventive ergonomic modifications, so that there are less chances of stress fractures. To prevent a decline in bone mass and prevent fractures. So again, whenever we are educating the patients, the more part of preventive is education and exercises also, but more part is education. So whenever we are educating the patient about the bone mineral density and the risk factor and the chances of getting fractures or some other symptoms, we need to actually motivate, or we need to actually educate them about the proper intake of the food with the calcium, proper sunlight exposure, proper weight bearing exercise, proper activities of daily living. Then the next goal is, or next preventive measure is, to increase the strength in the bones. Increase in the strength in the bones can be done by two ways. One is taking a good amount of calcium, so intake of calcium. But second is intake of calcium should reach from blood to bone. So whenever we want to enhance the bone strength, we need to go for exercises of weight bearing, but not that much. That we will discuss into later part. Now, improve flexibilities. As I said, whenever there is osteoporosis, there are chances of deformity development, and due to that, there are chances of the muscles flexibility, or there are muscles who are tight, or there are chances of tightness, deformity, and contractures. Also, later part. To help to decrease the stress placed on the bone by tight muscles, as I said, for example, when the patient is having kyphotic posture, there are more stresses on the back extensors and anterior musculatures or anterior structures. So we need to even prevent it and educate the patients about it. To improve overall mobility, as I said, mobility will actually produces the weight bearing and increases the absorption of bone mineral. So first and foremost thing which you need to educate the patient is, if you don't make time for exercises for prevention, you will probably have to make time for illness. So that is the main motive of prevention, and it has to be educated to the patient. Now, physiotherapy management when patient comes with the symptoms, right? So the goals for physiotherapy management when the patient comes with osteoporosis, with the deformities, with some amount of illnesses, not illnesses, but some amount of physical deficits. So the goals would be to prevent the development of osteoporosis and to stabilize the remaining bone. So whenever one part is affected, you will have to maintain that part and you will have to prevent the injuries to the next part, because biomechanical disarrangement will produce the risk of developing the injuries to the next part also, or the connecting segments also. To control pain and gradually returning to the regular activity. So how could we control pain? We can control pain by any means, because these pains are basically originated from musculoskeletal conditions. So by examining properly for the musculoskeletal conditions like pain, swelling, deformities, range of motion, muscle strength, everything. So here, due to time constraint, I am not going much into detail about this, but you all know how to relieve pain. So whenever you find the symptoms which are of acute inflammation or acute injuries to the bone or nearby soft tissues, you will have to relieve the pain by giving the non-thermal modalities. And if it is chronic pain, chronic conditions, then you can relieve it by thermal modalities. Also, improve self-care. As I said, improve self-care in the means of they will have to maintain the activity. Self-care also includes the skin care and tooth care, right? So that is also been educated to patient, as the physiotherapist is the one point of contact for the patients who can educate or who can actually initiate this all things, because when they go to the physician or the orthopedicians or the endocrinologist, they just go them and get the treatment or get the consultation for half an hour once in 15 months or once in a month. But as a physiotherapist, they can be in contact with you every day. So that is your part also. Improve nutritional status, improve physical mobility. Again, as I said, you will have to stimulate the patient to go for physical mobility. So for example, when the patient has stress fracture or when the patient has fear of fracture, reduced like altered balance, so patient will have the fear of fall, and due to that fear of fall, a vicious cycle will be established. So patient would be less physically mobile. So again, you will have to improve the physical mobility of the patient, prevent injuries to patients, like preventing injuries into strengthening the muscles, preventing the joints, improving the balance, like that. So by improving the balance and strength and improving the mobility, you can actually prevent the further injuries and improving the lifestyle, right? Now, benefits of regular exercise for patients is it controls the body weight. These are the factors which you will have to educate to patient. This, as a physiotherapist, you all know, but what are the key points which you need to consider for or pick up for the patient's education is, you can control body weight by doing regular exercise, you can enhance your energy level, you can reduce the risk of diseases and needed for bone mineral. So education, because usually I have seen patients who have osteoporosis or who have less bone mineral or have been passed through any stress fracture, they are feared for doing exercise because they feel that if I do exercise, I will be having risk of injuries. So type of exercises, I'll not go much into detail about type of exercises, but the basic exercise is divided into 4 parts. One is strengthening, second is stretching, third is aerobic, and fourth is balance training. So if we consider strengthening, then strengthening should follow the specificity principles so that the specific non-weight bearing exercise are more preferable for osteoporosis Then the weight bearing exercise. So you will have to maintain, or you will have to control the exercise, or make it tailor made, so that there are less chances of further injuries, or patients that are low risk of injuries, along with the strengthening, right? Stretching exercise, as I said, there are postural deformities, or there are deformities into the spinal vertebral column. So you can go for stretching along with strengthening exercise. So stretch the shorten muscles, strengthen the lengthen muscles, and maintain the posture. Aerobic exercise, again, aerobic exercise should be based on the FITS protocol, because when the patient is having or osteoporosis, and when you ask patient to go for aerobic exercise or weight bearing exercise, there are chances again for having more injuries. So low intensity exercise is must for all, and better to prefer than the general body exercise. Better to prefer the segmental exercise than the general body exercise. Again, balance training, make sure that you are giving a proper preventive measures when you are giving balance exercise. Go for the low level of balance exercise, like static on static, and then dynamic on static platform, and then go for the dynamic on dynamic type of progressive exercise. But books or evidences really prefer that balance exercise should be done with a proper precaution, because it has chances for having reoccurrence of fractures. Principles of exercise, like minimal loading, we have already discussed about this. Minimal loading, that is non-weight bearing exercise, are more preferable. Segmental exercise are more preferable, like upper limb strengthening with weights and all. So strengthening exercise should be done in non-weight bearing position rather than weight bearing, using body weight as a weight, as a resistance, because when you use body weight as a resistance, there are chances of stress fracture. A low intensity exercise, as I said, aerobic exercise considering the FITS protocol, but it should be low in intensity so that it reduces the risk of fall, and it should be tailor-made progressive exercises. Exercises for the spine, very importantly, because spine has the vertebral body, which is cancellous bone, and which are more prone for the compression fractures. So that is why all the exercises which causes extension, or which produces extension of the spine or vertebral column, should be incorporated, like chin tuck, scapular retraction, thoracic extension exercise, hip extension exercise, because extension exercise is a key to prevention, as the flexion exercises are contraindicated, as the anterior compression or anterior loading will be there. Non-strenuous exercises for the patient with osteoporosis, severe osteoporosis, has to be done. So the exercise should not be strenuous for the patient, and exercise should be carried out with some orthosis if required, because it will produce, or it will prevent the further injuries, and even the patients will feel somewhat support from the outside, so that they are confident enough to do exercises. So as I said, all extension exercises. Strengthening exercise, as I said, gentle weight bearing exercise using elastics or weight of for the upper limb and lower extremity, non-weight bearing position, isolated segmental exercises. This exercises are as the protocol is as per ACSM guideline. So as they say that the strengthening exercise should be segmental exercise, not the overall body's exercise or body as a whole. Exercise will improve the strength of lumbar extensors, to improve the strength of lumbar extensors and gluteus maximus. Weight bearing exercise can be done like walking or gentle walking on treadmill, again protective, low intensity, not much loading, right? Jumping exercise, single limb stance exercise, ballistic exercise should be avoided. Gentle non-pounding form of dancing even can be done, or a mild form of aerobic dancing without pounding of the feet can be done. High impact activity should be avoided. Exercise training should be, as I said, should follow the FITS protocol, but there has to be two things which is very important while you frame the exercise protocol. That is specificity, as we said, the major impact of exercise activity should be at the site of BMB. So you will have to specify the exercise for the segments where are less chances of stress fractures and overload. The effect of change in the bone mass, the training stimulates. So you will have to go for the overload principles for the aerobic exercise, but starting with the low intensity, and then gradually you will have to go for the high intensity exercise. Flexibility exercise improves the by improving the flexibility, it reduces the stress on the bones and decreases as we are stretching the tight muscles, and decreases the ability to practice good and increases the ability to practice good posture and body mechanics, improves mobility, and it will improve the balance and thus reduces the risk of fall. Stretching of the upper back and chest, as I said, the flexed, the slouched posture is more common in the osteoporotic women. So you will have to go for the extension exercise. So frequent prone lying, frequent prone position, and in prone position, the extension exercises are more important and more preferable. Stretch calves, hips, and neck for elongation of the spine and elongation of the body. Cardiovascular exercise or endurance exercises, we already discussed about. Physical activity level is reduced due to osteoporosis. So it needs both cardiorespiratory endurance training also, not just the muscle training. So muscle training should be high intensity training with the muscular fitness, as I said, segmental exercise and resistance training. Do's and don'ts for osteoporotic women is important not to rush into an accustomed exercise, because this is the prime role for physiotherapists to educate here how to start and how to progress. Exercise must be done regularly. Avoid flexion and rotation, combining the flexion and rotation position for lifting, handling, and activities of daily living. Think and do activities. So they will have to be cautious about the activities, even the daily routine activities also, because sometimes the females are not that more casual about doing the activities of daily living, like kitchen activities or daily work, right? So it is very important to educate them about this and maintain upright posture wherever and whatever they are doing. Outdoor activities and indoor activities, as we all know, this is just to educate the patient. So that's all from my side, and I hope this short lecture would have given a sense of how to.
Thank you very much, ma'am. Thank you very much, ma'am, for your wonderful insight on osteoporotic. It is always a pleasure to listen to you. And I would really like to, we are not taking the question answers here, ma'am. Once again, thanks from Khyati, Bao, and IAP and IAPWC. I would now like to introduce our next speaker. That is Dr. Shweta Pradhan. She is from United Kingdom. She's working as a senior specialist in Hertfordshire Community NHS Trust. She's specialized in pain and sexual dysfunction and also in pregnancy massage. She's also awarded as Outstanding Women's Health Service Provider in Hertfordshire County. She's a clinical educator, a mentor to many midwives, nursing professional, physiotherapists, and junior doctors of UGs and PGs. She will give an insightful talk on pelvic floor prolapse and Pessary. So over to you, Dr. Shweta Pradhan, ma'am. And
hello, good morning, Dr. Zara.
Very good.
You have my slides, so I would appreciate it.
Yes.
Thank you very much.
I will just start your slides for you.
Thank you very much.
I'll do that.
Okay, thank you. So I would like to thank Dr. Heath, Dr. Dhara Shah, and Khyati Institute for inviting me for such a wonderful conference. And I'm very thankful for all the speakers and participants who are listening me today. So without wasting enough time, my topic is vaginal pessary in the management of prolapse.
It is here. I have started that.
Yes, please. Yeah. So the reason of choosing this topic, like we know that, I hope you all know what is vaginal prolapse, and The physiotherapy is the first treatment in which we advise for pelvic floor exercises. But what if physiotherapy is not successful, if pelvic floor exercises are not successful 100%, or there are many ladies who mention that, okay, we have noticed improvement, but not completely, but still we have some symptoms of prolapse and affecting their day-to-day life. And they are not also very keen for having surgery at the same time. So this vaginal pessary is the second option after, like, between physiotherapy and surgery in order to treat vaginal prolapse. Now, as a physiotherapist, like, we can do vaginal pessaries, but we need to have a certified specialized course. You need to have training, a degree in that, a certified training in that. And so if you have that training, if you have that course done somewhere in the university or anywhere else, then yes, absolutely, in India, you can treat your patient having vaginal prolapse or stress incontinence by using this vaginal pessaries. So my first slide is, what is vaginal prolapse? So as we all know, it's defined as a herniation or descent of one or more anterior vaginal wall, posterior vaginal wall, uterus, vaginal apex into the vagina. So vaginal prolapse, it's a very common condition. It's affecting approximately 30% of women attending gynecological outpatient clinic and up to 50% of women over 50 years of age. It has been estimated that 50% of Paris women have some degree of vaginal prolapse, but only 20% of these are symptomatic. The prevalence of pelvic organ prolapse increased with age until a peak of 5% in 60 to 69-year-old women. So some degree of prolapse is present in 41% to 50% of women on physical examination, but only 3% of patients report symptoms. So there are many patients who have prolapse, but they have no symptoms and they live forever without having any problem, without realizing they have the prolapse. The number of women who have pelvic organ prolapse is expected to increase by 46% to 4.9 million by 2050. And it is therefore, it's a major cause of morbidity in women. Next slide, please. Now, what are the risk factors? So we know that the cause of, or the risk factor of prolapse is multifactorial, but it's primarily associated with pregnancy and vaginal delivery, which lead to direct pelvic floor muscle and connective tissue injury. Like hysterectomy, other factors apart from delivery and all, hysterectomy, pelvic surgery, or condition associated with increased intra-abdominal pressure, including like obesity, chronic cough, constipation, and repeated heavy lifting also contribute to prolapse. So ethnicity or race, like Hispanic or white or Asian community, or advancing age, parity, elevated body mass index, connective tissue disorder like Antenatal syndrome, genetics, like if somebody has family history of prolapse, like if mother, daughter, like it's more prone to have. Increased intra-abdominal, the same slide, please. Yeah, thank you. Increased intra-abdominal pressure like chronic cough, constipation, as I already mentioned, repetitive heavy lifting, obstetric like operative vaginal delivery, any instrumental delivery like forceps delivery has more chances of having vaginal prolapse as compared to normal delivery. And previous surgery, hysterectomy, most of the time ladies do get some complication in the form of incontinence, but mainly prolapse, especially vaginal vault prolapse. It's very common after hysterectomy, or any type of other pelvic surgery can lead to vaginal prolapse. Next slide, please. Classification. Now, what are the classifications? So classification is on the basis of compartments. So if it's anterior vaginal wall or anterior compartment involved, then there can be a prolapse of the bladder, that is known as cystocele. There can be a prolapse of the bladder and the urethra, that is known as cystourethrocoele, and there can be a prolapse of only of urethra, that is the urethrocoele. If it's apical vaginal wall, which is the middle compartment of the vagina is involved, in that case, you can have uterine prolapse or you can have vaginal wall prolapse, which I mentioned after hysterectomy. It's very common. And if it's posterior vaginal wall involved, posterior compartment involved, then we can expect prolapse rectocele, which is the prolapse of the rectum, or enterocele as well. Yeah, now symptoms. Now, pelvic organ prolapse, it's a very common and very distressing condition, as we all know. However, it's not life-threatening. People don't die with this if they are having prolapse. However, it's often associated with deterioration in the quality of life, and it can contribute to various bladder and bowel and sexual dysfunction. So the most commonly symptoms of anterior vaginal wall. So if somebody is having like bladder prolapse or urethrocoele or cystourethrocoele, they will usually complain of urinary frequency, like going very often for the toilet, urinary incontinence, urgency, intermittent flow, straining to void, feeling of incomplete bladder emptying, and poor stream, recurrent urinary tract infection, vaginal pressure, heaviness, or dragging sensation. Now, people who have posterior vaginal wall prolapse, like rectum prolapse, rectocele, they will mostly complain of difficulty in defecation, like difficulty emptying their bowels completely. They have to excessively strain or push in order to open the bowel, or feeling of, as I said already, bowel emptying, constipation, and most of the time they have to put their finger in order to open their number 2, their bowels. That is manual evacuation with digital assistant. Vaginal pressure, heaviness, vaginal or perineal pain, sensation or awareness of tissue protrusion from the vagina, low back pain, it's very common, abdominal pressure or abdominal pain. So these are some common symptoms which most of the time, I would say approximately 96% of patients will complain of if they have any type of prolapse, whether it is bladder or back passage. Next slide, please. Now, what are the grading? How you will grade the prolapse? So the most common grading system that we use by the all professional, which is POPQ, which is Pelvic Organ Prolapse Quantification System. It is an standardized, my apologies, standardized tool for documenting, comparing, and communicating clinical findings. And it is an objective, site-specific system for describing, quantifying, and staging the pelvic organ or pelvic support in women. It provides a standardized tool for documenting, comparing, and communicating clinical finding, and it has good inter-observer and intra-observer reliability. The POPQ system is being approved by the International Continence Society, the American Urogynecological Society, and the Society of Gynecological Surgeons for the description of female pelvic organ prolapse. So that we most commonly use. Now, next slide, please. The next slide, the next grading system that we use is Baden-Walker halfway scoring system, which is most commonly used, and I personally also use in my clinic for examination of the prolapse. So it's a very simple scoring system, which is starting from grade or staging grade 0 to grade 4. So grade 0 means like no prolapse, everything is normal. Grade 1 means like descent halfway to the hymen, which is greater than 1 centimeter above the hymen. Grade 2 means descent to the hymen, like 1 centimeter or less proximal to distal to the plane of the hymen. Grade 3 means descent halfway past the hymen, which means greater than 1 centimeter below the plane of hymen, but farther than 2 centimeter less than the total vaginal length. And 4 means maximal possible descent or complete procedentia or complete protrusion of the prolapse, like eversion of the lower genital tract is complete, like maximum, it is completely hanging outside. Now treatment. So we know that physiotherapy is pelvic floor exercises is the first line of treatment, as we all know, and you know all how to do pelvic floor exercises. So I'm not going in the depth of pelvic floor exercise and physiotherapy treatment, but physiotherapy, vaginal pessary, and surgery are the 3 options available in order to treat vaginal prolapse. Now vaginal pessaries. Now what are vaginal pessaries? So the word, the pessary, it's an effective tool in the management of prolapse, but it also useful device for the non-surgical management of number of gynecological conditions. So vaginal pessary is not only used for vaginal prolapse, but we can also treat other conditions as well. And the second most common condition that we treat with vaginal pessary is stress urinary incontinence, like ladies who leak while coughing, sneezing. And especially we use for ladies who are very sporty in nature, then we use different varieties of pessary, which I will discuss with you. So pessaries, the word pessary is derived from the Greek word pesso, an oval stone, and pessary has been used to treat women with pelvic organ prolapse since the beginning of recorded history. Recognition of the condition can be traced back to Egypt in 1500 BC. And the treatment with pessary use was first demonstrated by the Hippocrates in 400 BC. Hippocrates described the reduction of vaginal prolapse by placing a half pomegranate soaked in wine into the vagina. The pessary, it's an effective tool in the management of prolapse. And however, it remains a very useful device for the non-surgical management of number of conditions, as we have already mentioned. They are primarily made from medical grade silicone, and 2/3 of patients with pelvic organ prolapse initially choose management with the pessary, and up to 77% will continue pessary even after one or a few of the usage. Pessary are an option for all stages of prolapse, and they may prevent progression of prolapse and avert or delay the need for surgery. So many physicians there are still many health professional doctors who are not aware of this option. So many physicians are very unfamiliar with this pessary. However, 75% of specialized clinicians, either in UK or United States, use as a first line of therapy in the management of vaginal prolapse. Next slide, please. Next slide, please. Hello.
I'm really sorry, there was some issue. I'm just telling.
No, it's okay.
Yeah, you can continue.
Okay, next slide, which is categories of pessary, please. Thank you very much. So categories of pessary. So there are two categories of pessaries. The first one is support pessary, and the second one is space filling pessary. Now, what is support pessary? So support pessaries were defined as those that use a spring mechanism that rest in the posterior fornix and against the posterior aspect of symphysis pubic. In support pessaries, such as the ring pessary, the example is ring pessary, the vaginal support results from elevation of the superior vagina by the spring that is supported by the symphysis pubic. Support pessary can be inserted and removed by the patient, and it also allows for sexual intercourse. So ladies who are sexually active, they can go for ring pessary, which is support pessary, and are associated with less vaginal discharge and irritation compared with space occupying pessary. Support pessaries were more common for anterior and apical defect. Next slide, please. Space filling pessaries. So space filling pessaries are defined as those that maintain their position by creating a suction between the pessary and vaginal walls, like cube pessary, by providing a diameter larger than the genital hiatus, like donut, or for both mechanism, like gel horn pessary. So space, so common for posterior defect, like we use donut pessary, and for complete procedentia, we use different varieties, but most commonly we use for gel horn pessary as well. Now, types of pessary. So the most commonly that we use is ring pessary. So there are approximately 120 available pessaries for use, with 20 in most commonly used worldwide. It's a very important conservative treatment option that is recommended first line of treatment by 77% of the member of American Urological Association. So ring pessary have been used for the treatment of prolapse since 15th century BC. And the ring model is most widely used because it is easier to insert and has better acceptance because of better fit in the vagina. It is useful for mild uterine prolapse and if it's associated with the cystocele, bladder prolapse. So if anyone is having bladder prolapse or uterus prolapse, this is one of the very good option, ring pessary we can go for. And it's also if the prolapse is grade 1 or grade 2. So this model allow for sexual activity without removing the device, and it is the device with fewest complication. So ring pessary are the supporting type. The diameter, it's available in different, sorry, same slide please. So it's available in the different sizes. So the diameter of the ring pessary include 57, 64, 70, 76, and 83 millimeter. Next slide, please. So another one is introl. You can see on the, I've put small, like, how they look like. The introl ring is a shape like a traditional ring, but it has two prongs which rest underneath the urethra. So mixed prolapse and urinary incontinence symptoms were fitted with an introl. So because of the retropubic prongs, the introl device may be retained more successfully in women with large prolapse. So ladies who have leaking and prolapse both, then you can try this option as well. Another type of pessary is ring with support. So the ring with support can be successfully used in patients with stage 3 and stage 4 prolapse. The next one is donut pessary. It's like a donut we eat, it just looks like that. So donut pessary is useful in the treatment of grade 1 and 2, but most commonly we use as a grade 3, grade 4 uterine and rectile prolapse. The disadvantage is like people can't do sexual relation. It's very difficult to do sexual relation and very difficult for insertion and removal. It's not very easy to take it, insert and take it out at the same time. Another pessary is the shelf pessary. So shelf pessary was placed in patient with an apical descent and extensive prolapse or lack of support of the ring pessary like uterine prolapse or any prolapse, especially vault after hysterectomy. So, so ladies who have uterine prolapse or after hysterectomy vault prolapse, or even at the same time, if it's grade 3, then you will go for shelf pessary. And shelf pessary is harder and less flexible pessary. However, it's still very comfortable to wear, and it can help with an uncomfortable, heavy dragging sensation, often associated with pelvic organ prolapse. The next one is incontinence with ring. So ladies who have incontinence issues, you can go for this type of pessary. So this pessary compresses the urethra against the upper posterior portion of symphysis pubic, and it elevates the bladder neck. This causes an increase in outflow resistance, and it corrects the angle between the bladder and the urethra, so that the Valsalva maneuver alone are not strong enough to cause leakage of the urine. Any style of pessary that can accomplish this will help in the management of stress urinary incontinence. And incontinence, a ring pessary usually help with stress incontinence, but if patient has some degree of cystocele, then we can also use Hodge with support or gel hung pessary, which will be more effective. The incontinence, it's quite easy for insertion and removal, and there is a possibility of doing sex as well. Now, incontinence with dish and support, so we use it for stress incontinence, cystocele like bladder prolapse, and it is quite easy again, like incontinence incontinence ring. It can easy for insertion and removal. The possibility of doing sex, yes, it's you can do sex. You can remove it, so you can do sexual relation as well, but it is less helpful for a severe form of prolapse. Now, another type is cube pessary. Now, so the cube pessary is designed to manage third-degree uterine prolapse. Because the cube is held in place by suction, removal can be somewhat difficult for some patients. Now, this type of pessary we use for people have all 3 types of prolapse: bladder, uterus, and rectum. And we also use for stress incontinence, and it is quite easy to insert and to take it out. So there are ladies who are very highly sporty. They like to do high impact exercises, but they can't do because of the vaginal prolapse, because they feel a lot of dragging, or they feel that prolapse is literally coming outside. So in that case, like when they are, and if they're not happy to have pessary all the time, so in that case, they can put it in the vagina before they start doing high impact. They can do their high impact, they can finish it, and once they finish, they can take it out as well. So this type of pessary can support the uterus even with the lack of vaginal tone. So the cube pessary should be removed and cleaned daily. And because it has no drainage capability for women who have urinary incontinence during strenuous activities such as jogging. So as I said, any lady having prolapse and stress incontinence who don't want to have pessary all the time and who's very sporty, you can advise this cube pessary as well. So ladies who are very keen for jogging, aerobics, tennis, or any other high impact, cube pessary can be inserted before exercise, maybe all is needed. So cube is the least frequently used because it adheres more than mucus vaginal wall, thus facilitating the development of ulcer. So there are some disadvantages. So if you're not cleaning it, if you're not removing it properly, then people can get some infection, or you have to clean it regularly. Sometimes if you're not competent how to put it in or take it out, sometimes ladies do get bleeding or ulceration. But the advantage is, as I said, you can remove it before the sex as well. So if you, the specialized nurse or the doctor or the physiotherapist should teach the patient how to put it in and how to take it out. So training is very important. So another type of pessary is cortiform pessary. This is purely used for stress incontinence, and the same reason patients who are highly sporty or high impact exercises, they can insert in the vagina before they are doing high impact, and once they finish, they can take it out as well. So cortiform pessary helps women suffering from stress incontinence, and when it insert into the vagina in a similar way to a period Tempex, so it just go like a Tempex. Cortiform support the urethra and restore the body natural anatomy, and it stop the urine from leaking. So cortiform work instantly to prevent or reduce urinary leakage, putting you in control and giving confidence to live without any restriction. Cortiform is available in 3 sizes: small, medium, and large. Now, another type of pessary is gel horn pessary. So gel horn pessary have the function of both supporting and space occupying. Gel horn pessary can be used in patients with 3rd and 4th degree uterine prolapse. Gel horn often support, but difficult for the, but it is also difficult for the patient to remove. Gel horn pessary can offer excellent support for uterine prolapse as long as the perineal body is intact. And it comes in different sizes: 44, 51, 57, 64, 70, and 76 millimeter. Now, there are other types of pessaries as well, which I'm not going into the depth. Hodge pessary, Schartz, Hodge with knob, incontinence with support, Hodge with support, Jehrung, Smith, riser, and inflatable, which you can see on Google, on the YouTube as well, or in the images section. Next slide, please. So you can see the images. There are different varieties of pessaries. Now, what are the conditions that can be managed with pessaries? The condition that can be managed with different types of pessaries are cystocele, as you know, that is the prolapse of the bladder, enterocele, rectocele, uterine prolapse, vaginal vault prolapse, urinary and fecal incontinence, urinary tract infections, antenatal prolapse. So it can also be used during pregnancy, ladies having vaginal prolapse while pregnancy, delaying or avoiding surgery. So ladies who are not keen for surgery, who are very fit, who are very young, they don't want to go for surgery, we can offer vaginal pessaries. Voiding and evacuation difficulties, urinary retention, complete procedentia, or somebody has any psychological or mental or physical impairment. So these are the conditions where you can offer vaginal pessaries. Now, what are the advantages? So pessaries are widely used to treat pelvic organ prolapse. As we know, it is minimally invasive, it appears to be safe, and it is very patient friendly. It is effective in alleviating symptoms, and the satisfaction rate is very, very high. And the follow-up appointments in many published paper is very short. You don't need long follow-up appointments in the clinic in order to change the pessary. You can, if it's going in the right direction, then you can have a follow-up appointment just for 10-15 minutes and you can send the patient back home. And it seems to have a positive effect on sexual functioning. Now, what are the positive outcomes after having pessary? So there may be a decrease in the size of genital hiatus with continued pessary use. So what are the advantages or benefits you can see after having pessary? So you can see there is a reduction in the size of genital hiatus. There may also an improvement in POPQ stage after 1 year of pessary treatment. Improvement in the bulge symptom. There is an improvement. There will be an improvement in bladder and bowel symptoms like leaking from both front and back, or regular emptying. Patient will say that, okay, I'm going more regularly after having the pessary, or I'm not getting that strong urge, or I'm not leaking while doing strenuous activity. There will be an improvement in perception of body image. Like ladies who have vaginal prolapse, they often complain, oh, I look ugly, or I don't look very good, or I don't feel like I'm a female again, I can't do sex, feeling very low. So it gives a lot of confidence. It reports satisfaction rate of 70 to 92%, and comparison with surgery, similar outcome after 1 year. So you cannot have exactly the same result, but 95% ladies have mentioned that they, after having pessary, they don't feel any dragging or heaviness, or they don't have any symptoms of prolapse, which give pretty much the same effect or benefits of surgery. Now, what are the complications? So complication, like the most common is foul smelling, vaginal discharge, bleeding, pain, constipation, fecal impaction, urinary incontinence, inability to self-replace or insert, erosion, vaginitis, ulceration, material allergy, and bowel obstruction. What are the less common complications? So acute pyelonephritis, vesicovaginal, rectovaginal fistula, ureteric obstruction, retained pessary requiring surgical removal, decubitus ulceration of the uterus, hydronephrosis, unilateral and bilateral, vaginal fibrosis, cervical cancer, incarceration, obstructive uropathy, urosepsis, hydronephrosis, vaginal malignancies, vaginal ulceration, and pelvic cellulitis. So these are some common complications. Now, what are the risk factors where you cannot use, or risk factors for vaginal pessaries? So risk factors that are reported to be the responsible for unsuccessful pessary fitting are short vaginal length, large genital hiatus, prior history of hysterectomy, prior surgical repair of POPQ, pelvic organ prolapse, my apologies, large vaginal introitus, severe vaginal atrophy, and prolapse of all the compartment. Now, in brief, how to fit the pessary. So pessaries are fit by trial and error. Proper fitting of the pessary often require the patient to try several sizes and different styles. A variety of style and sizes should be made available during the patient fitting session. So it's a type of trial and error game. You have to try different pessary and you have to see how the patient is responding, and then you will send the patient back home by the best one if patient is happy with it. So before fitting pessary, a complete and proper examination should be performed, which includes recording of type, grading, and degree of prolapse by using either Bed-Walker classification, POPQ staging. You can use any of them, and then you can fit the pessary. The presence of vaginal atrophy, perineal and pelvic floor muscle strength, and deficiency of perineum is very important to document. The physician, clinician, nurse, or physiotherapist should start with an average size pessary. In a very simplest way, when the pessary has been put into place, the fit and effectiveness should be checked. The examiner finger should pass easily between the pessary. I'm just explaining in very brief. So should be passed easily between the pessary and the vaginal wall. The physician should ask or should check the pessary to be sure that the intended function is met. When the indication of pessary is for stress incontinence, then patient should be asked to cuff to test whether the patient leak or not. So if any patient is having pessary for stress incontinence, then after fitting pessary, you will ask the patient whether she is leaking or not. And if patient is not leaking, it means that the pessary what you have put is successful. So finally, the examiner or the physiotherapist should ask the patient to stand or sit or squat or perform any Valsalva maneuver to be sure that the device will not become dislodged. And it's not only you have to check whether patient is leaking or not, you have to also check if the pessary is not dislodging. Because sometimes we have patient mentioning that, okay, I have the pessary and after 2 hours or after 1 day, it just fell out. It just come out from the vagina. So you have to check whether it is sitting in the normal position or not exactly. It is also recommended that patient void before leaving the office. So if the patient is unable to void with pessary in position, the device should be removed and the patient should be fitted with the next smaller size. So that's very, very important thing you have to keep an eye that patient should empty bowel, and especially when you are sending the patient back home after fitting the pessary, you have to tell the patient to pass urine. If patient is struggling to void urine or they can't empty the bladder, you have to take that pessary out. And also you have to ask the patient to keep an eye on their bladder and bowel for 2 days. So if patient is not emptying their bladder or bowel for 2 days, it's a case of extreme emergency. They have to go any doctor or nurse or any specialist to take it out. Otherwise, it can be life-threatening sometimes. So the patient should be instructed to immediately report any discomfort or difficulty with urination or defecation while wearing the pessary. Follow-up appointments. I'm almost done because I think I'm going beyond the time. So follow-up appointments. So after the initial fitting of pessary, the patient should be followed within a few days so that the physician or any clinician can recheck the fit. At each follow-up examination, the pessary should be removed and cleaned with soap and water while the vagina is inspected for erosion, pressure necrosis or allergic reaction, irritation or pressure sores. If infection of the pessary reveals cracking or other defects, it should be replaced. The patient should then be instructed to follow within 1 or 2 weeks for another examination. After which the time the examination can be spaced to every 2 to 3 months. So ideally, you have to give few days appointment, then after a few weeks, and if everything is going in the right direction, then you have to call the patient after 3 to 4 months. So in theory, pessary should be changed every minimum 3 to 4 months to 6 months. If the motivated patient who is able to demonstrate effective removal, insertion and care of the pessary, these examinations may be spaced further at the discretion of the physician. Now, what are the recommendations? The next slide, recommendation for successful pessary. So pelvic floor exercises are very, very important. So pelvic floor is not only for prolapse, it is very important for pessary. So in order to keep the pessary in proper place, or if you don't want pessary to fall out from the vagina, patients should be very religious and diligent and determined doing their pelvic floor exercises. Then avoiding constipation, straining or pushing. So the bowel should be quite good. Patient should not have any constipation issues. They have to drink a lot of fluid and healthy diet. They have to avoid heavy lifting. They have to use bracing technique. They have to avoid increased cough. They have to reduce their body weight, so reduction of the body weight. They have to wear supportive garments. And they have to change their lifestyle, like if they are doing anything on their feet for a prolonged period of time, then you have to just tell them to sit and relax. So they have to avoid, or they have to change their lifestyle, like heavy lifting, change the manner of lifting, or change the way they are doing household chores or day-to-day activities, and lifestyle modification. And sometimes we advise to use the creams as well. So people after having pessaries, if they're having any irritation and all, then you can advise some creams like silk, vaginal gel, or yes. And that's all about, in very brief, different types of pessaries and how to use and for different purposes. Thank you very much.
Thank you very much, Dr. Shweta. And you have really given an insight of what is pelvic organ prolapse and how to use the pessaries into it.
Thank you, Dr.
I would now like to call upon the next speaker. As we are running short of time, I would really request all the speakers to kindly stick to their timeline. And the next speaker whom we have with us is Dr. Neha Arora Verma. And just a minute. The next speaker which we have with us is Dr. Neha Arora Verma, and she is going to give an insightful talk on obesity management from a physiotherapist point of view. She is a pioneer in non-surgical liposuction in India, and she is a certified Sigma certified spine therapist from USA. She has done her PG diploma in cosmetic laser and acupuncture. I would really like to welcome Dr. Neha on board. Kindly start your presentation.
Thank you, Dr. Dhara, for inviting me on the platform. Sorry, my screen is a bit blurred, but I'm just gonna quickly start so that we don't lose time. How to share the screen? Dr. Dhara, how to share my presentation from the laptop?
If you will just scroll on your screen, on the bottom you will get the buttons for mute, stop, and in the same there will be a green colored button of screen sharing. As you will press the screen sharing button, yes.
Share, but it's on my desktop. How to share it?
So you can press the screen sharing, and in that you can select your desktop. The file which is open on the desktop, that would be opened. So you can open that file on your desktop and then you press the screen sharing.
Yeah, got it. Thank you. So thank you very much everyone for having me today. And this topic has been, you know, a very keen interest topic for me, because being a physiotherapist, we all have access to people who are looking for options for weight loss and, you know, weight management. And we do have, you know, something, we know muscles better. We know the thing that how we can manage somebody's weight, how can we, you know, assess them for the visceral fat and subcutaneous fat. So I'm just going to briefly explain. So the topic would be obesity management. Is it visible, Dr. Dhara, my screen?
Your screen is visible. You can just keep it on slide sharing. Otherwise, this is also visible.
Yeah. Okay. So I'll just keep on like flipping around. Yeah. Talking and flipping. Yeah. Okay. So as we all know that obesity can lead to a lot many chronic problems like a heart attack even. It can increase the cholesterol. And, you know, we are into the field where we should work and we should let people know that how it is important to be active. Why, you know, it is very important to be fit. And, you know, we come from a field where we understand the muscles better. So let me go forward. Why we? So because we have the access to people who already have issues with weight gain. So it's like only upgrading. We are upgrading the weight management technique in this field. So we help getting more access, you know, and we are kind of upgrading the clinical environment and therapeutic environment where we work. And people already look on us for health and wellness goals. So, you know, they already know that we can help them gaining muscle or losing fat. We understand the muscle better. And as we all know, we can do MMT, we can do, you know, core stability exercises, we can do many things with the body where we understand the muscle function much more better than any other, you know, medical fraternity. And we help them achieve better muscle strength and shape. So that's why we all should upgrade the practice in obesity management. And that's how like we did the same thing. And fortunately, we got a lot of love and blessings from all the patients, what we seen around. And it's like, you know, once you learn the art of weight management, then the practice goes, you know, really high. So let me go forward. So what do we have in the body? It's usually the subcutaneous fat. So we all have it, and it's the deepest layer of the skin, as we all know. It can be found in arm and leg and on top of abdominal muscles. So what's the function of subcutaneous fat? It stores the energy and it regulates the body temperature. But it is like, once you get that, it is not difficult. It is not impossible to get rid of this fat, but yes, you have to work harder. Once you have got the subcutaneous fat, you have to work to get rid of it. So how do we measure it? So in women, if we have the waist size 35 inches or longer, then that's the warning signal. We should all, you know, we should all check when somebody is approaching you for obesity management. We all do our workup, we all do the measurements and everything. Women above 35 inches is at the, you know, red zone. Men above 40 inches. So visceral fat is something we all be talking about, and we all, you know, somewhere we have learned about visceral massages and organ massages. And even I have heard Dr. Dhara talking so much about gut mobility. So it's all connected. And as we all know that gut is our second brain. So whatever happens, you know, inside your digestive system is directly attached to the brain function as well sometimes. So, we should understand the concept of gut cleaning or gut detox, or how we can regulate this metabolism, and we can help our patients getting rid of pain and getting the mobility back as well, along with the weight loss. So what exactly happens in the body is subcutaneous fat is there to store the excess of energy. So normally when the things are okay, so the fat helps in storing the energy, so that we all can if we are exercising or we are working out, so we should have that storage of energy inside. But when this function is impaired, then we have ectopic fat deposition. Then the visceral fat comes into picture. So there are basically two types: apple shape and pear shape. I would be just briefing it around because I've just given 20 minutes to talk. So apple shape and pear shape are presentations we usually used to see before, but now there are different type of presentation which are seen in various kind of patients. We do have kind of obesity have been classified into 4 different types depending upon the pathology of the obesity has come from. Okay, so this is when we talk about a perspective to assess a patient. Usually when you see someone, you see apple or pear, but when you assess someone, you see 4 kind of obesity, and that I would be discussing further. So this is the 1 kg of fat you lose. We all heard our patients saying that, oh, I just lost 1 kg of fat. So this is that 1 kg of fat what you have lost. Look at the size. It's just like, when you put 1 kg of butter in a bowl. This is how 1 kg of fat look like. So it's not easy to lose even that 1 kg of visceral fat. But yes, with right technique, with right, right proper guidance, it is really possible. And we are there to support in the system because we know the core stability, we know the muscle better, like I said before. So again, this is a picture where it says skin with cellulite. So you can see it's like all baffled up, and skin without cellulite is flat. So when the cellulite is there, it's obviously you feel like sagginess and looseness on the skin. And there, the important role of us coming up for toning up of the skin tissues, and we are helping them, getting that kind of firmness in the muscles. So one more perspective, what we all can help our patients with would be the pelvic tilt. The pelvic tilt definitely affects organ mechanics. It definitely affects the size, the core stability. And when the core stability is poor, definitely the visceral fat is going to accumulate more. So it's all connected to the biomechanical part of the body. So we have to work on the pelvic, proper pelvic tilt as well. Then we have to work on the core stability. Then we have to work on the organ mechanics. For organ mechanics, we can give them a visceral massage, and we can help. Basically, what happens when somebody is obese? So we say that liver metabolism is slowed down, because when you're eating something, when it is not getting digested, it starts accumulating inside your gut or small intestine. So if something is wrong there, when somebody touches the upper abdomen, you can feel that kind of tenderness there. So with physical finding as well, sometimes even if you don't have the test, you can make out that what can be wrong with that person. And then you can still make out how to assess and palpate the abdominal area, and how you can just, give them a proper visceral massage to relieve that kind of tenderness. So all these things can be a very positive point for all of us who are working in a clinical area or even in a hospitalized area. So we all should know how to do a proper abdominal examination to see the tenderness and to check for liver mobility. So what are the different types of weight management?
Ma'am, sorry to bother you, but can you please do the full screen for the slideshow?
It's a full screen, ma'am.
If you can press F5.
Okay. I'm not getting the option. Am I not visible?
No, you are visible, but then the presentation is in just the presentation format, and we are not able to see the full screen of the presentation.
Oh, I'm not getting the option for full screen. Where do I check?
Dr. Neha.
Yeah.
Dr. Neha, you can simply just press the shift button and F5 button on your keypad. Just press shift and F5 together.
Okay. Is it okay now? I'm done.
No, your all presentation is visible and not the screen sharing. Okay, or the other thing, if you can just do it, like you can go for the slide sharing option.
Like this?
Yes.
Okay.
Yes. Yeah.
Is it okay? Can I continue? Should I continue?
Yes, ma'am, please continue. It is fine.
Yeah. So what are the options available for all of us to work in this era, which is the new branch of our practice? Basically, we can work as a gut health detox person, and we can help with lean body mechanism because we understand that the muscle weigh more than fat, and we know how to shape up and tone up the muscles. We can help our clients with diet management, and we can help our clients with home exercise. So what does all these mean? So gut health management would be something which is in trend right now. And when somebody has issue with digestion, so most of the females, especially when they come after delivery or maybe, adolescent age, they all have something or the other to do with their hormones. So in that case, if we know the assessment of abdominal area, if we know how to check for the gut motility, then we can definitely help, in the pre-stages of the problem happening in advance. So we all should know that gut management is something which we all should learn working in the field of physiotherapy. And we all should know that gut motility is something which can help, body to regain the immunity, getting getting rid of all the complications the girl or female can have after, probably say if they have come before pre-delivery to you. So you can tell them the management, how you can, how soon they can start their weight loss management after delivery. So all these things, really matter. If we learn all these things, it really matters, and it has really helped, especially me and all the physios who are working with me in my team, to get this kind of patients who are looking for weight loss options in the advanced level. So second one is lean body system. Lean body system is like whenever you introduce something in the body which is helping them to burn fat. So fat is something where we have loose pouches in the body. So when you help somebody to burn fat and gain the muscles, so there are chances that the person would not increase weight or again go to the obesity level from where he started from, because there is no loose pouches left there. So this is a very important topic, lean body, which are really important for our field, where we can help our clients with it. Third would be diet management. As we are not dietitians, but we know that certain dietary management we should know when we are working in the field of obesity. We should know how to deal with various kind of medical conditions when person is coming from. So it's like a simple, just a review of diet and dietary mechanics, which you should learn. And home exercise, definitely when somebody is opting for any kind of fitness program, they should know what they can do at home to, really increase the result of the program. So all these four things we can help them, and we can really upgrade our practice teaching these to our clients. So it's just a slide that which shows what is unhealthy gut. So how can we help? If you read the symptoms, we can help our clients with fatigue. We can help them with anxiety. We can help them in joint pain. We can help them in headaches. We can help them in digestive problems. We can really help them in like losing weight. So all these things fall into the paradigm of our practice, and we really help people with all these conditions some way or the other. But just promoting a way of obesity management can, really enhance the practice of all of us. So, okay. So I explained what is lean body system. So fat burning, we are putting our body from fat storing mode to fat burning mode. We are just, increasing the metabolism naturally of the body, and just showing them the way that where the fat can turn into muscle. Once that process has been done in the body, and the loose pouches has been gone, like I explained earlier. So the person can have toned up and firmed up body for longer time. It is not like once the session is complete with us, they don't have to follow the diet, they don't have to follow the program for longer time. So once the session is done, say for example, 45 days, 2 months, 3 months, whatever the tenure we give to our patients, then after that, they can keep that kind of firmness, toneness in the body for longer time. And body sculpting is very much required. So this could be a blessing for all of us, because one thing we know that when a person come to you, they don't have just one problem. They just don't come from knee issues, or they just don't come from spine problems. They come from various issues, and one of the common factor nowadays seen is obesity. So combining all this together with your practice can really give you wings. So it's a blessing for all of us. So like visceral massage, I was explaining earlier, then when we have a different tilt or we have an altered tilt, we all should know how to, really improve that tilt, how to improve the muscle power, and then how to, there are various types of methods where you can actually check for the organ function, and then you can check for how to improve the mobility of those organs. And this is a very huge topic. I'm not going to go into detail with it, but it's like one topic we all should learn and upgrade ourselves to improve and increase our clinical practice. A must thing to add on. So these are some results, because especially when some male clients approaches you, so this was a client with spine problem, and if you can see that spine posture was really altered with because of the tummy. So when we corrected, obviously we helped him with the spine issue as well. But when we corrected the tilt, when we have got rid of the abdominal fat, visceral fat, you can see how the posture has changed for him, and definitely he's looking more fitter and younger. So these are the systems which really give you, a lot of scope into the practice, and the results are seen like probably within 6 to 8 weeks. So it's an amazing program for all of us to learn. Another transformation. So again, this fellow was a slip disc client, and with slip disc, you can see if he has a big belly, pot belly like that, even if you're working with slip disc, you cannot help him for longer time. But once the belly fat is gone and the slip disc, obviously we got rid of the problem as well, because the muscles was very weak. But again, if I would have just worked on the muscle and spinal part and would have left the abdominal belly like that, unfortunately, the client would not have got the 100% of satisfaction. So again, this is just, one thought I would like to, say to all of you who are listening today, that it's not something what you do with your body. So it's not the diet which is taking you, the diet is not wrong, okay? When the diet is correct, the medicine is not required. So this one philosophy we all should have. Being a physio, we all should learn that if you know what to give, and if you know what to eat, and if you tell the client the same thing, they might not require any kind of medicine in future. And this we have done with thousands of patients across the world now. And if you just teach them nutrition, if you just teach them, diet, which you have to take from your home, it's in your kitchen, just tell them that. So medicine would not be required for longer time, or might be not at all required. And another result which would be helpful for us, that for every 1 kg you lose, takes 3.6 kgs of pressure off your knees. So another blessing for all of us who are working in, especially in musculoskeletal, that knee problem can be solved when the weight loss can be done. And various kind of, results are there with spine issue, somebody with migraine, somebody with knee, somebody was advised for knee surgery. So all these could be possible when you combine the approach. It's integrative therapy. You have to combine with your own specialty, some modalities, definitely some home advices, and obviously obesity management. So with this note, I would like to end my presentation, and thank you so much for having me today. Thank you so much. Hello.
Thank you very much, Dr. Neha. You can pause your screen sharing. So if you will just again hover over your screen, there you will get an option of stop screen sharing. Yeah. Thank you very much for a lovely presentation and giving us a different insight to work upon obesity. And yes, obesity is a very leading major cause of maybe all the non-communicable diseases. So with this, I would really like to call upon our next speaker, who is Dr. Jayashree Jayakrishnan, and she's a clinical physiotherapist and a women's health practitioner. She's a women's health physiotherapist. She is the first one in India to receive prestigious IBCLC Breastfeeding Care Award. She is also a IBCLC certified since 2010, and she is in charge in lactation management at Dr. Mehta, Prashantha, Bloom, INH, Kaveri, Fortis, and other hospitals. She is the founder and director of Happy Mom. She is in the advisory board of BPNI, and she's a pioneer in presenting in ILCA International Conference. She has also done multiple research papers related to lactation management in Lancet International and National Journals. So let's have Dr. Jayashree to explain us, to give us an insight or to give a talk on role of physiotherapy for postnatal care. Yes, Dr. Jayashree, you can kindly unmute and you can keep your video on, and can you start your presentation? Please kindly try to follow the timeline of 20 minutes. Thank you.
Yeah, thank you. I hope you can see my slides.
You can see your slides. You can just keep them on the slideshow.
Slideshow.
We are just seeing the slide listing. You can keep them on the slideshow.
Okay, thank you, Wow Pri, and thank you, Dr. Dara and Dr. Head and Khyati for giving this opportunity to present in your wonderful conference. It was awesome to see all experts from various places being presenting the scope of practice of physio and how far it can excel. So going to my topic for today. So role of postpartum physiotherapy care, it is quite an extensive topic. I've made to my possibilities some justice and given some gist of what and all could be done, and have presented my way of practice, which has been doing it here in my community. So the postpartum, what it meant to be, it begins immediately after childbirth. Okay. As the mother just delivers a baby, and it includes the hormone level, the size, returns to normal.
Hello, Dr. Jayashree, I think you have some net connectivity issue.
Yes, I'll just go ahead. Okay. So I was talking about the postpartum period, that is which begins immediately after childbirth. So the amount of changes a women's body goes through, the physiological and anatomical changes after birth, the reproductive system changes, where the maternal physiology returns to pre-pregnant state following birth, and uterine involution, the perineum, which is be painful and it will be inflamed for the first 1 to 3 weeks following vaginal birth, and even the menstruation, ovulation. Women who are not breastfeeding tend to have the menstrual cycle by 55 to 60 days compared to mothers who are breastfeeding. Changes in the breast changing in size.
I just tried to connect with Dr. Jayashree.
Can you hear me?
Yes, now we can hear you.
I'm sorry, net is going on and off. So it's already your time is running. I'll just make sure I'll finish on time. So I'm going to talk about the postpartum physio. So I've just divided into two aspects: immediate postpartum physio, which we do it for an inpatient stay, and outpatient stay. So here, what we see is that the normal vaginal birth, natural vaginal birth. The natural vaginal birth is the mothers are being allowed to deliver to the position she wants. It will be mostly on the floor we deliver. It will be on like a cat and camel pose, or the Vajrasanam pose, or it will be like a squat, any position without any episiotomy will let the mother to have a birth without a care happening. And in case of instrument births, epidural, analgesic births, water births, delivering inside the water itself, so C-section. So these are the various section of mothers we tend to see in our organizations. And postpartum, the outpatient follow-up which we have. So the why so much important is postpartum physio is obviously the pregnancy gives a lot of changes, the increase in elasticity in ligaments, the separation of abdomen muscles and weakening of pelvic floor muscles, and the further weakening of levator ani, and getting into a lot of pelvic organ prolapse, urinary incontinence, and even incontinence of stools, and they have flatus. Many things, many women tend to like keep it within themselves. When someone starts to talk with it, they find, okay, fine, this is a person I should talk with it. So that being a start point for us when we start the postpartum physio inpatient. So what are the things we need to remember when we start the postpartum physio inpatient? We have to be very clear with the condition of the mother, with getting the medical clearance from the medical team on going with the interventions, and we have to be very sure on the pre-medical conditions and having a discussion with the medical team and BMO, and on a regular basis we need to get updated. And we have to not only see the client, we have to make sure the attenders and also the aspect what the mother had went through to a labor and pre-labor, all the things we have to be considered when we are treating a client in the IP visits. And this includes the exercises. It's not like all exercises has been taught in the IP. We've been saying to the static and slowly going with the dynamic and the coordination with the clinic. And the strengthening exercises, pelvic floor exercises are being started, and gradual increase of pain is being done. Has given us
I think Dr. Jayashree is facing some network connectivity issue. Can we shift to the next speaker, ma'am? Dara ma'am?
Yes, ma'am. Please do that.
Yeah. Can we? So our next speaker is Dr. Simranjeet, and she is going to give us an insight on cupping therapy for reproductive health. So cupping therapy is a new adjunct to conventional physiotherapy, and to deliver this talk, we have Dr. Simranjeet Kaur with us, who is the director and HOD of Sukhija's Physiotherapy Clinic, and she's also a women's health physiotherapist, certified yoga and Pilates instructor. She is a physiotherapist to many renowned football players, singers, and Bollywood stars. She has also done her fellowship in osteopathy and manual therapy, and she is a certified dry needling therapist and also a certified kinesiotaping therapist. I would like Dr. Simranjeet Kaur to kindly start your presentation and go ahead. Do we have Dr. Simranjeet?
I'm sorry. I'm sorry, Dara got.
Dr. Jayashree, can we just connect with you again? Like after some time, once you just stabilize your network connectivity, we can meanwhile shift to the next speaker.
Yes, sure.
Thank you.
I'll stop sharing.
Dr. Simranjeet, I would request you to kindly go for screen sharing and start your audio video presentation. Dr. Simranjeet, can you, hello?
Sir got disconnected, I guess.
Okay. Dr. Simranjit Kaur is not here with us. I guess let her connect back to us. Meantime, Dr. Sumant is with us.
Yeah, I'm here.
Yes, sir. So can we start with your session?
Kapil is my friend.
Kapil is your friend. He knows that you are reducing experiments.
Yes.
That's I just want to know that.
Yeah, he knows.
So later
He knows. Hello.
Hello. Yes, sir.
Sumant,
sir, session, can you please start?
Hello.
Yes, Dr. Sumant, you are audible. Can you please start your session?
Yeah, we can start.
Yes, please.
Yeah. Dara will be sharing my slides.
Yes. Dr. Dharasha, requesting you to share the slide. Yes.
Yeah. So pelvic girdle dysfunction, it's very common in male and female, and it's too common in female. Dara, can we go for next slide? Yeah. So as we all know, the pelvic girdle is made up of two sacroiliac joints and one pubic symphysis joint. So in between three joints, we'll be getting some dysfunctions. So here, all put together, we call it as an pelvic girdle dysfunction. So when we see individually, we should differentiate whether it is an sacroiliac dysfunction or iliosacral dysfunction. Or next is your pelvic girdle dysfunction. Next slide. Next slide. See here, the most of the time we'll get a stability in the sacroiliac joint because of your sacroiliac ligaments and a joint. And next is we'll get a stability because of coefficient friction that is existing between the sacrum and innominate. So in here we have got short axial ligament, sacrotuberous ligament, sacrospinous ligament, anterior plane of sacroiliac ligaments, posterior plane of sacroiliac ligaments. All ligaments put together, they tend to bring stability to your sacroiliac joint. Next slide. So here, there is the statement given by the AT Still. What he said is the anatomy that we are studying, that is nothing but a Gray's anatomy, is one of the standard anatomies in the world. And it states that sacroiliac joint is an immobile joint. I stand here and expect you to support me that sacroiliac joint is a movable joint. And all the anatomies in the world will be changed before the many years. I may not live to see it. This is the statement given by the AT Still, Andrew Taylor Still, in 18th century. Okay, so that time it was strongly believed that the sacroiliac joint is an immobile joint. Of late, in 1940s and 1960s, the many research have been done, okay, in University of Zurich and in other universities, and they have found that there is a mobility there is a minimal mobility that is present in the sacroiliac joint, and that minimal mobility it's enough to create a dysfunction. Next slide. Yeah. So osteopaths after they understood that the sacroiliac joint will be best corrected with the pain and with the pain management, that is the mobilization and manipulations. Next. Okay, see here, the Fretti is one of the biomechanists. He has given a successful model how the sacroiliac joint moves. And he said that the sacrum can translate up, sternum can translate down, sacrum can tilt anterior, can tilt posterior, can move in oblique direction. So the sacrum has got 6 types of movements. In the same way, your innominate can also move up, can move out, can rotate anterior, can rotate posterior, can move out, can move in. So this can happen individually or this can happen in combined. The sacrum and innominate can move combined. Next slide. Next slide, please. When you see that this lumbopelvic rhythm, when you tend to bend forward, first the sacrum tends to move anteriorly, that is the base of your sacrum. That is called nucleated dysfunction. When you tend to move further, the tension in the sacrotuberous ligament will be created. Instead of sacrum moving anterior, it tends to move posterior. That is your counter rotation. Next slide. So when you see the sacroiliac symptoms, signs and symptoms, mostly it mimics with your discogenic pain. So one thing we need to do a proper differential diagnosis, whether the pain is coming from the sacroiliac joint or your sacroiliac joint or your disc from your disc. Here the same, like the pain will be, the patient will be complaining of low back pain will be radiating down, and sometimes the patient may complain of pins and needles or the like, and sometimes the weakness in the lower limb, and sometimes the patient may complain of buttock pain. Sitting to standing will be the painful, standing to sitting will be the painful. Sometimes the SLR will be the positive. So almost 90% of the symptoms will look alike. We need to do proper assessment and proper differential diagnosis, whether the pain, to identify the source of pain. Next slide. Next slide. So here, they have given some provocative tests. So the University of South Australia has given the validatory test for few tests. That is your joint compression test, distraction test, hip thrust test, sacral thrust test, Gesland's test. We need to perform these tests. Suppose if you are choosing among four tests, okay, you should able to do 2 tests should be the positive. When the 2 tests are positive, then definitely the pathology is from the sacroiliac joint. If you're able to do the 6 tests, among 6 tests, 3 tests should show the positive. If the 3 tests is positive, then the pathology is from sacroiliac joint. Suppose in our examination, if these tests are negative and we are having other symptoms, the sacroiliac joint is not the source of pain. Next slide. So here we'll be having an innominate dysfunction, sacral dysfunctions, and pubic dysfunctions. If the innominate dysfunctions are dominant, we say it is an iliosacral dysfunctions. If sacral dysfunctions are dominant, we say it is a sacroiliac dysfunctions. And you'll be having a pubic symphysis dysfunctions. The differential diagnosis is a big challenge. Next slide. See, when you see the anatomy, the 2 ASIS should be in same line. In between 2 ASIS, your umbilicus should be there. Posteriorly, you should take a landmark of PSIS. In between 2 PSIS, you should take a landmark of S2 spinous process. And laterally, you should take a landmark of iliac crust. Next, when you see the innominate dysfunctions, you'll be having an anti-innominate rotation dysfunction. You'll be having a posterior innominate rotation dysfunction. You'll be having an upslip, downslip, outflare, and inflare. Okay, anterior innominate rotation dysfunction, ASIS will be down, PSIS will be up. Okay, and innominate will be rotated anterior. In posterior innominate rotation dysfunction, PSIS will be down, ASIS will be up, and your innominate will be rotated posterior. So both your ASIS and PSIS, they both move up. It's called as an upslip. Downslip, ASIS and PSIS both will move down. It's called as downslip. Next slide. Okay, next is your inflare and outflare. In inflare, ASIS will start moving close to umbilicus and PSIS will move away from S2. In outflare, your ASIS will move away from umbilicus and PSIS will come close to S2 spinous process. Next slide, please. So when it comes to sacral dysfunctions, you'll be having a counter. So you see the first slide. So superior superior part is called the base of sacrum, and tip is called anterior apex of the sacrum. So in first slide, it is a counter-rotated sacrum. It means the posterior aspect of the sacrum has moved posterior. Base of the sacrum has moved posterior. In next page, the posterior base of the sacrum has moved anteriorly. It is called as rotated dysfunction. And next slide, in third page, so left base of the sacrum has moved posteriorly. It is called sacral torsion to left, posterior sacral torsion to left. And finally, and fourth slide is anterior sacral torsion to left. Next. So here, this is an oblique, fifth and sixth is an oblique dysfunctions, right? Oblique sacral dysfunction and left, right anterior sacral dysfunction, and last page is left posterior oblique sacral dysfunction. Next. So here, for example, we need to do a proper differential diagnosis because of among all these dysfunctions. Because of time constraints, I could not tell each and every dysfunction differential diagnosis. For example, for between the PAR and AAR, for PAR, you could see a deep sulcus in posterior aspect, whereas in AAR, you don't see a deep sulcus. In PAR, you see a short leg. In AR, you see a long leg at an affected side. Okay, and PAR, you can bend affected side easily, and when it comes to AAR, you can't bend. Side flexion will be limited. The sacrum moves inferior in PAR. Sacrum inferior in AAR.
reflection screen.
Okay, and you tend to see the hamstring tightness, multiform tightness, and tightness in PAR. Okay, and in AAR, you tend to see rectus femoris tightness. You tend to see the rectus femoris tightness and affected side clear tightness. Next slide. Next slide. So this slide, no need to talk about this slide. And next slide, we go for next slide. Next slide. So here we need to talk about the two concepts. What is force closure concept and force closure concept? Here the force closure concept means the muscles that are surrounding your sacroiliac joint are responsible for creating the dysfunction. If your muscles are weak, your dysfunction, you're more prone for getting a dysfunctions. So if you get a dysfunction because of muscular weakness or muscular tightness, along with the manipulations and mobilizations, you need to really work on your muscles, either to strengthen or relax your muscles. Or when it comes to your form closure dysfunction, here the muscle integrity will be good, because you'll get a dysfunction because of slight malposition of your joint. Suppose, for example, if you jump from a certain height, keeping one leg, for example, if your right leg comes in contact first to the ground, okay, because of that extra forces, you tend to get some dysfunctions in the joint, though you are having a strong muscles. So in those cases, if you are having a good muscular integrity, you know to work on the muscles, just your manipulations and mobilizations will work good. Next slide. Next slide. So yeah, I think I'm done with form closure also. Next slide. Okay, so here we have got muscular sling systems in our body. One is posterior sling system. One is anterior oblique sling system. One is a posterior oblique sling system. In posterior, in longitudinal sling system, posterior longitudinal sling system, multifidus is attached to your sacrum through the deep layers of thoracolumbar fascia. Okay, here we need to really work on multifidus for keeping, because we all know the multifidus is rich in proprioceptors. If your multifidus is weak, because deep layers are attached to the sacroiliac joint, you're more prone for developing the dysfunctions in the sacroiliac joint. So the multifidus training, when it comes to your core training, it's very important to target your transverse abdominis and multifidus to improve your sacroiliac joint stability. Next slide. Next slide, please. So next is your posterior oblique. So back in posterior oblique, in these your posterior oblique muscles, here your gluteus maximus is connected with your tensor fascia lata, and sacrotuberous ligament, and it runs oblique and it's get connected to your latissimus dorsi. There is a relationship between your latissimus dorsi of right side and the gluteus medius of left side. It's being connected through your sacroiliac ligaments and thoracolumbar fascia. So it's very important to check these oblique chain also. Why, if you get a case of forced closure dysfunctions. Next slide, please. Next is your anterior oblique dysfunctions. In anterior oblique dysfunctions, here your external obliques, internal obliques will be interconnected through your transverse abdominis. In case of forced closure dysfunction, usually this happens not because of tightening, because of weakening, anterior oblique. So here it's very important to retrain your external obliques, internal obliques, and thoracolumbar fascia. Next slide. So here it's very important to integrate your dynamic neural stabilization concepts. Dynamic neural stabilization concepts means, so you'll be having a pelvis. In pelvis, you'll be having a pelvic floor muscles. On top of that, you have got a diaphragm. In between the diaphragm and the pelvic floor muscles, you have got an obliques, and back your paraspinal muscles. And laterally, you have got a thoracolumbar fascia and a QL. These are all interlinked, and exactly in the middle, you have got a pelvic, means you have got a pelvic girdle. So here it's very, very important to check the relationship between your pelvic floor and your diaphragm. So the both should be parallel to each other. And whenever you are training these four muscles, it's very important. It's very important to activate your pelvic floor along with the diaphragm so that there will be an effective activation of your external obliques and internal obliques. Okay, this DNS concepts also we can integrate for getting a very good outcomes. Next slide. So here we'll get sometimes tricky case. If you see this MRI, sometimes we'll be having an L4 or L5 posterior lateral disc bulges. So if this posterior herniated disc, suppose this disc is asymptomatic. So if you are not checking your sacroiliac joint thoroughly, okay. So here the patient symptomology will be same like as in PIVD. Okay, here if you go and take a MRI, if you ask for an MRI, in the MRI, if you find there is an L4, L5, there is a L4, L5, L5, S1, means evident disc bulge is there. Okay, and your treatment will change. The doctor will think that this is the case where we should operate because the symptomology is exactly similarly same, 90% mimics your PIVD, and most of the doctors will think we need to operate to reduce the symptoms or forget about the operation. And next, when it comes to a pain management, most of anesthetists, they try to intervene to block that exciting nerve roots or to give some epidurals over that area. Forget about that. When it comes to a physiotherapist, when you see that evident disc, when you are not doing a proper evaluation of sacroiliac joint, so when you see that that is, and first thing that strikes to our mind is we need to decompress that disc. We will be going for tractions. We'll be starting with McKenzie protocols, but action problem is in sacroiliac joint. So it's though you see an MRI, though you see an evident disc bulge, you should confirm whether the source of pain is that the disc or not. But the disc or not. If the disc is the source, treat the disc. If the disc is not the source, examine your sacroiliac joint thoroughly, examine your pelvic girdle thoroughly, and start doing your pelvic girdle treatments. Next slide. Suppose here sometimes alternate mechanics happens. If you see a case of piriformis syndromes, we all know the piriformis will take an organ directly from your sacrum and it gets inserted over the greater trochanter of the hip. Okay, if the piriformis is tight, it has a capability to alter the position of the sacrum, Here, it's a tricky whether to stabilize the sacrum first or first to release the piriformis. So we need to do proper evaluation. Whichever is more irritable, we should not target that. Whichever is much less irritable, we need to target that. First treat that, then followed by rest of the treatments. Next slide. So here, if you get a case of posterior lateral disc bulge, L4, L5, Okay, and sacroiliac joint dysfunctions. Suppose L4, L5 disc bulge, and suppose, for example, if you see an evident L5 nerve root compression, L5 nerve root will be supplying to your piriformis. So, because of L4, L5 disc bulge, because of nerve root compression, your piriformis overfire. Because of piriformis overfiring, there will be a malposition of your sacrum that can cause sacroiliac dysfunctions. So, in these cases, we need to treat a disc, we need to treat joint, we need to treat the joint, and we need to work out on a piriformis muscle. If your sciatic nerve is involved, you need to work, you need to do some neurodynamic testing and need to go for neural mobilizations. Okay, so it's a complex thing. Next. So can we say SI joint is a dysfunction? Okay, so most of the time we see and we say it's an SI joint dysfunction. No. So we should tell improperly. For example, if you tell it's an SI joint dysfunction, you should tell it is an, for example, right anterior innominated rotation dysfunction with upslip and outflow with the sacral mediated dysfunction. And this again, we should tell this is because of post closure or form closure. Next. Next, ignoring the sacroiliac joint in low back pain is costly and misleads the treatment. David Pole, and the statement given by the David Pole from Minneapolis, San Jose, California. Conclusion: including the sacroiliac joint is a part of diagnostic criteria, is a preventive, is a pre-operative patients with a chronic low back pain is likely to be posterior. Thank you. Thank you.
Thank you, Dr. Sumant, for sharing this. Dr. Sumant is a chief physiotherapist in Yashoda Hospitals, Hyderabad, and he is also the academic advisor of Yashoda Institutes of Physiotherapy. Thank you for joining us, and I would like to really call upon our next speaker, Dr. Simranjit Kaur. She is the director and the HOD of Sukrija's Physiotherapy Clinic, and she is going to deliver a talk on cupping therapy in reproductive health. Dr. Simranjit is a certified yoga and Pilates instructor, and she is also a certified dry needling therapist and a kinesio taping practitioner. Over to you, Dr. Simranjit.
Thank you, ma'am, for a wonderful welcome over here, and thank you to all.
Dr. Simranjit, you have muted yourself. Kindly unmute.
I hope I'm audible now.
Yes, you are. You have again muted yourself.
Is it okay now?
Yes, it is better.
Okay. So my topic of today is cupping therapy in reproductive health. Cupping therapy is something which is everybody doesn't know much about it. Okay. So cupping, since I have been a practitioner since from quite many years, from 2005 I'm into this profession, and from 2012 I'm running the clinic of Sukija Physiotherapy Clinic. And as per years, I have been updating my career every now and then. And now I am into reproductive health and gynecological cupping. And gynecological cases, we have been seeing many cases in my clinic. So I am more into practical learning and teaching. So in this, my main motive is to tell everybody that although it is a allied sciences, cupping is in allied sciences, but it's having a very wonderful role in releasing the pains of any lady. Because I have seen many cases of PCOD, infertility, ovulation, vaginismus, many kind of problems. We just now, as the previous topic was there for the pelvis misalignment by Dr. Sumnath, and it was also, this is all things are interrelated. Like we never have pains because of only one dysfunction. I have seen into my practice, there is a multiple of muscle chains are involved. Sometimes anterior chain is involved, sometimes lateral chain is involved, sometimes spiral chain is involved, and reproductive system is a part of that chain as well. We are working on the muscles, we are analyzing the chains, but why to forget the reproductive chain? So similarly, if we work on the fascia release, if myofascial release is giving you relaxation, but with the effort of the physiotherapist involved, a cupping is a really big adjunct. And it is not only for giving a relaxation, it is having multiple benefits. Like with the cupping, we can give cupping as a mode of resistance. Resistance training can be done if we go for opposite type muscle, antagonist cupping. If we go for the agonist cupping, it is giving you assistance, like it is increasing the length of the muscle. And not only this, like different ways of fascia relaxations are there with the cupping. We can use it as a biofeedback tool. A cup can be used as a biofeedback tool while teaching pelvic floor rehabilitation. A cup can be used for promoting lactation to the breastfeeding mother. Okay, the ones who are having nodules or difficulty in releasing the mother's milk, the cupping is a very useful vacuum with which it becomes easy. Okay, a lady without pain, she can go for lactation. And elasticity of the muscles can be improved. The discharge problems of the ladies can be improved with the help of cupping. Cupping is also used with some different liquids, like herbal liquids are prepared for giving herbal cupping, and that is giving you heat and absorption phenomena for the different skin, which is absorbing the anti-inflammatory things. So it is giving you reduction in the inflammation. Sometimes with the blood cupping, that is the wet cupping is useful. Sometimes hijama is useful in treating the PCOD cases. If we see Indian women only, the research shows that 1 in every 5 lady has PCOD. So why not to make the life of a lady easy by making her more flexible, and elasticity components can be added into the different chains which have become tight. So thinking about this, I have started up the relaxation of the muscles. Basically the cup, this is the cup. Okay, this is the general cup, but for the vaginal area, the cups are very small, and the silicone cups are something which are not giving much red marks. Cupping is 3,000-year-old phenomena, and with time it has been changing. But if a physiotherapist learns that cupping, he can use it in very different useful forms, because we know the anatomy, we know the lymphatic drainage, how to give the dynamic cupping to promote the lymphatic drainage, how to give the anatomical lines release so that increase the facial length, which are reduced, which have been tightened, because of which we are not able to give the full relaxation to a lady. And this cup has this is the basic body of the cup, this is the piston, and this is the rim of the cup. If we put the cup and we pull with the gun, it will just elongate our muscle. Okay, if you see closely, it is giving you U shape. Okay, this cup hold is where once we release it with the help of pushing this piston, this will increase the length of the muscle. And this kind of facial release techniques are very easy, and this can be just make this fusion of two things, like one, elasticity. Along with that, we are doing exercises like pelvic rehabilitation exercises, teaching the control of urination, along with the, when the goals are two different goals are mixed, that is the flexibility and strength training, flexibility and any more issues, like in case of PCOD only, many females have the acne problems are there. For the acne problems also, the hijama cupping works well. In PCOD cases, amenorrhea is there. Amenorrhea, because of the cyst formation, what happens is sometimes fallopian tube coiling is also there. To remove that coiling or giving it a elasticity, it will relocate with the help of elastic recoil. And to promote that, we can give the cupping in the different directions. If we give the normal stretch or the facial release, it generally is on the top layer. But if we give the cup in the different directions, it is giving the cohesive forces are working to release that tightness all over the muscle, not only in the upper layer but also in the lower layer once we are giving it a different direction. So since it is a new thing, we must appreciate it and increase our knowledge into this. There are many studies on the in the general journal of the traditional medicine and complementary medicine papers. There have been many papers on wet cupping, hijama cupping, but this area has to be explored more. With my researches on my patients in the OPD, we have seen various ladies recovering from the ovulation pain. The ovulation pain was gone within 7 sessions of the physiotherapy for the abdominal releases, and constipation cases were also recovered in our OPD. Constipation cases, we even have the records of the pre-post and the reviews of the patients on my YouTube channel, Dr. Simran. And we have undergone this all process in such a detail that we even saw that whenever there is a pelvic misalignment, like anterior pelvic tilt is there or posterior pelvic tilt is there, we have to just see to a chain. Like if anterior pelvic tilt is there, what happens? The quadriceps muscles become shortened up. Okay. And once the quadriceps shortening is there, maybe that is the cause of anterior pelvic tilt, because it is interrelated. If we release the quadriceps, the anterior pelvic tilt can get corrected. And if we go and palpate the area of the ovary, like I was also into the visceral osteopathy, I was doing that techniques. And once we combined visceral osteopathy also with the cupping therapy, it was seen that the lady found herself very easy and pain-free, even in the cases of vaginismus. Vaginismus is quite an inflammative disorder, like tightness is there, which is not making the area open for a lady to go for a sexual intercourse. So to open that area, if we give the directions in the anatomical lining and make the lady feel that relaxation along with some herbal cuppings and sitz baths association with them, and this exercises will make them feel more relaxed. Whenever we have to check at what time, what type of cupping has to be used, because it is not the same for every lady, for every problem. We need to go for a proper assessment to check whether anterior pelvic tilt of both sides or one side, if one side shortening is there, postural scoliosis is there. Many times psoas major is the cause of scoliosis, but which is neglected. So if we give a lateral chain release with the help of the cupping, or we can add the QL releases with the help of needle and cupping, it will give a lot of good results in the females who are not able to stand for a minute, but they are able to walk and even go for a stair climbing very soon. And these results were found in less than 10 days. So the lady who was having pain from so long, if we can give some relief to her with small steps of which are acting as an adjunct to the normal physiotherapy. A physiotherapist can make this cupping therapy go into the different forms, and it is also used for nerve flossing in some burning sensation or sciatica pain once we feel that in pregnant ladies also. In pregnant ladies, we have found, because of the overweight, sitting for a longer duration, many times piriformis muscle is under pressure, sacrotuberous ligaments become shortened, coccydynia cases are there. And if this cupping increases the facial length, making her sit easily, making the muscles relaxed, Then it can also reduce the sciatic nerve entanglement. And along with that, we can even use different types of cups for improving the nerve flossing. So nerve flossing techniques can be used, elasticity can be added, heat can be added with the cupping, ice can be added with the cupping for reducing the inflammation, lymphatic drainage can be added, elevation and cupping can be added, exercise and cupping can be added. There are so many things in cupping itself. It is a big huge way to be explored. Once I teach cupping, in those cases, I teach case-oriented cupping as well. Along with that, symptom-oriented cupping as well. You need to know the assessment, like what is our goal, according to which the placement will vary, the distance will vary according to the age, the cups timing is varying, how much pressure you have to cup at which muscle, how much depth of the wet cupping you should go into the body. These all things varies along according to the female, according to the muscle type, according to the body type, according to the other lifestyle changes. Like if person is into sitting for long duration, many times it has been observed in females sitting for a longer duration, knock knees is very common. So with the right type of release with the cupping, if the adductors are the cause, we have to release the adductors. If the internal rotators of the hip are the cause, we have to release that. So how to assess and how to treat is really important. And we should not just follow one protocol to everybody. We have to assess like which muscle, which area, which is giving the shortness and shortening, that area has to be focused with the help of cupping. And in the cups are of various types. Silicon cups are there, fire cups are there, vacuum cups are there, bamboo cups are there, like too many things, moksha cups are there. So we have to see which type of cup, which type of area, what type of result we want. It is not the same for everyone. It can be used for pain relief. It can be used for nerve pain reduction. It can be used for increasing the strength, like bodybuilders. I have been treating bodybuilders, women as well. I was in Miss India competition of the bodybuilders. In that cases, we have seen that due to the over exertion, sometimes people become robotic, always doing anterior exercises more, like biceps curls are done more than the triceps curls. Because of that, they become elbows become bent, they are not able to open the elbows. So we can use those cupping for triceps along with the biceps workout. So if we go for the opposite antagonist cupping and agonist cupping, how it is making a difference. Sometimes for assistance, sometimes it is acting for resistance. Many like Olympics, very famous Olympics winner of swimming expert, like Michael Phillips. If you see those cupping marks were observed, and it was revealed that he practiced with the help of cupping as a resistance training. And then after the cupping, he was a Olympics winner in the swimming competition. So if this can happen in the normal people associating cupping in the sports, then why not in the gynecological field? That is the reason in our OPD, I practiced cupping with in urine incontinence cases, in infertility cases, in PCOS cases. And we have found improvements in all the ladies in which cupping was practiced. They were very happy with the help of cupping. The muscle spasm was also reduced. And I would like to show you some videos of cupping in different ways. Just let me share the screen with you. Is it on? Are you able to see?
Yes, Dr. Simran, it is very much visible.
Okay, so this was a cupping for adductor chain release. Just have a look in different types of cupping. This is the cupping for the back. This was in PCOD case, magnetic cupping. The magnets were also used. The cupping with exercises. We can use bridging exercise. We can use pelvic floor rehabilitation. This is a little fast forward view so that we can complete in short duration. To release the abdominals, this is electronic cupping with the head, to reduce the inflammation. Different stretches are given to release the abdomen. And static cupping, dynamic cupping, silicone cups are used. Exercises with the help of cupping, the trunk rotation exercise with the help of cupping, electronic cupping in the neck. So different types of cupping. This was one of the things which I wanted to show you, that cupping is not only for just to increase the length of the muscle, but it is also for improving the strength, and it is also a tool of biofeedback. Like for example, in breathing exercises, we give a biofeedback spirometer, isn't it? We go for a exhalation, inhalation, and the ball is going up, isn't it? So similar kind of thing with the pelvic floor. We can add cups as a biofeedback tool. We can ask the lady that this cup will go up, this cup will go down, and this kind of pressures and pulls can be associated by a good physiotherapist to give her a move, and it is kind of an assistance tool while teaching the exercises, a resistance tool while teaching, training the muscles. So a nerve flossing tool for pelvic floor area. We can even give some, if we go for a light touch, it stimulates the nerves, isn't it? So similarly, if we go for a flossing cupping, it goes and innervates the nerves. There are too many things to be researched and watched in this parameter, and I hope that every one of you will feel enlightened with this topic and go for some or the other kind of exploration in this field. I'm seeing that this topic is neglected because of three reasons. One is the lack of knowledge, because sometimes we do not know and we do not want to go and explore the different fields. Like we are thinking that the same type of things are coming up. We are into the same profession. It is not in our course or sometime like that. But I think we should update every now and then. If COVID virus has come, we have seen and studied about COVID virus, isn't it? So similarly, if cupping therapy could be an adjunct, we need to add that for relief of the patient. We should not think that it is different from physiotherapy. How a physiotherapy cupping is different from a normal person is that we know the hygiene to be maintained after this and before this, how to drain that cup, the wet cupping, where to drain it, how to maintain that cleanliness in the biofeedback, the waste products has to be given where or not. So this kind of things are anatomy is very clear to a physiotherapist. So we know that where to how to just take that in a right way according to the goal of ours, how to use that cup in a different way. This can be helpful. And the second thing, I can we can even go for more detailed, like some attitude change should be done to accept the new things coming up. It is a sensitive issue that, see, everybody will boost up that cupping. Yes, I have gone for the body cupping, I have gone for the legs cupping, thigh cupping. Sometimes they are, even the film stars and the bodybuilders are showing their cupping marks. But in the reproductive tract, nobody will show it. Okay, so we have to ask the patient, give him the chance, and just make them gain the knowledge about cupping, how this cupping could be useful. And then once we are doing it, patient loves so well that he himself, sometimes females come to me especially that I want a cupping session for my own self. So why people are demanding it? Because it is giving relief. Okay, and how it is giving relief? Because we are using it in a right direction, right form, and right requirements. The assessment of depth of cupping, like how much cupping and goal-oriented cupping, will make it a different and adjunct to the new physiotherapy coming up. So that's what's all from my end. Thank you so much, Dr. Dhara.
very much, Dr. Simran. And you have rightly said it that if there is some upgradation, we should always be updated with the new things which are coming into the scientific, which are coming into the limelight. And the one very important thing which you said, that how can we be different in cupping than the other people? So the best part, the actual part would be the anatomy. You know where to apply, why to apply, and how to apply. So not just to apply, but where, how, and why would definitely play a very important role. And I think that this session might have opened up lot many people's curiosity towards cupping, and they will also take it. They will take a step forward to learn more about the cupping and into the reproductive health especially. So thank you very much once again from all of us for joining us. And
Thank you, ma'am. And I'm always there for any kind of doubts on cupping. You can always contact me because I have been doing it from long duration. Yeah.
Yes, that is very much visible from your face, the passion for cupping. That is visible from your face. Please keep that thing, that spirit live in you, and help millions of silent sufferers.
Thank you so much.
So with the same line, in the same line, let's call upon our next speaker. She is Dr. Garima Biswas, and she's a WOW-IP licensed clinical instructor, and she's going to deliver a talk about infertility. So Dr. Simranjit, she rightly mentioned about the importance of reproductive health. So in the same line, we have Dr. Garima Biswas to deliver a talk about infertility. Dr. Garima is a certified yoga and a Pilates instructor. She is a certified childbirth and a labor educator. She is also an antenatal postnatal therapist, and she has done a lot of work into yoga therapy. So I would really, and she is a women's health physiotherapist as well. Dr. Garima, all over to you.
Yes. Thank you so much, Dara ma'am, for giving such a nice introduction. And I'm blessed to be a part of WOW-IP. Always, I feel a pleasure. So, just a second. Okay. As we all know that earlier physiotherapy was only limited up to the cases of the orthopedic, neurological cases, pediatric cases, but now a different field has emerged, that is the physiotherapy in the women health. And that is a very challenging field, and that is the, as well as that is a very ignoring field at the same time. So my topic is today is the role of physiotherapy in infertility management. So, so firstly, we have to understand the base of infertility. What is the infertility? What is the types of infertility? And what is the main reasons of the infertility? So infertility, when we can say that it is that this couple is infertile, or when we can term as a couple as an infertile couple. So that is that inability to conceive naturally means if a person is trying to conceive if the person is having a sexual intercourse without any kind of protection for at least 1 year, that is a 12 months. Even after that, if the couple is not able to conceive, that is called as the infertility. And infertility is nowadays, it is the 5th highest serious global disability in the woman. And many research says that 1 out of 6 couple are the infertile. That's why we can see that IVF centers are now growing everywhere, and the infertility is very common. So, and what is the type of infertility? So there are 2 types of infertility basically. First is the primary infertility. And what it means, primary infertility means when a couple has never achieved pregnancy, then it is termed as the primary infertility. And secondary infertility means when a couple has achieved at least 1 pregnancy, that is termed as the secondary infertility. So broadly, there are 2 types of the infertility, primary and the secondary. And what is the causes of infertility? In India, normally infertility, we blame that infertility is because of the female, but it is not true. Infertility is because of the 1/3 factor is for the female factor, and 1/3 is for the because of the male, and 1/3 in the 1/3 cases it is unknown, or both factor can be involved. And in broadly, we can say it is because of the hormonal, some kind of hormonal causes like PCOD, PCOS, any kind of hormonal imbalance, in the genetic causes, and the mechanical causes like where like in cases of where there is a pelvic floor involvement, like in cases of the vaginismus, dyspareunia. So that is the causes of the infertility. And what could be the causes of the male infertility? So here we broadly divided into few. So erectile dysfunction, it could be because of premature ejaculation, it could be because of low sperm quantity, it could be because of low sperm quality, infection or the inflammation of the testis, varicocele, undescended testicle, hormonal imbalance, any kind of tubal defect, or the alcohol intake, drug intake, or smoking, etc. That leads to the male infertility. And what about the female infertility? As we earlier discussed, it is because of the because of the hormonal imbalance. So here is the PCOS or the PCOD, premature ovarian failure, and hormonal imbalance, tubal blockage, endometriosis, pelvic adhesion, uterine fibroids, cervical stenosis, malposition uterus, and sometimes because of the overweight or excessive intake of the coffee, excessive intake of the alcohol, and stress. As we all know that the stress is a culprit factor for these kind of cases, and it plays a very important role in case of infertility. So we have to so we don't have to ignore the stress factor also. So because of lack of time, I can't explain each of them. So here I'm explaining few of them. That is the first is the PCOD PCOS, that as Dr. Simranjit also told us that it is the most common condition nowadays. So what is the PCOS? And that is the polycystic ovarian syndrome and the polycystic ovarian disease. And it is a condition that mainly affects the women of the reproductive age. And it is most often diagnosed by the presence of the 2 or 3 following criteria. Either it could be hyperandrogenism, that is the, and secondly, it is the ovulatory dysfunction, and thirdly, it is the polycystic ovaries. As we know, in the case of PCOD, PCOS, there is some fluid-filled snake-like structure, and in these kind of follicles, egg is developed, but this egg is not enough mature to produce or to trigger the ovulation. So that's why we called it as a ovulatory dysfunction, because here is the lack of ovulation, and this lack of ovulation create or it's alter the level of the estrogen, progesterone, follicular stimulating hormone, and the luteinizing hormone. And estrogen, progesterone hormone, because of this lack of ovulation, and these levels are the lower than the usual, and while androgen, that is called as a male hormone, and it is higher than the usual. That's why female of PCOS having symptoms of the acne and chin, hair in the chin, hair in the face, unexpected weight gain, irregular menstrual period. These are the most common sign and the symptoms of the PCOD, PCOS. And now, what about the endometriosis? Endometriosis is a painful disorder in which the innermost layer, that is the endometrium, we know that is the most functional layer of the uterus, and that grow outside the uterus. So whenever this endometrial tissues goes outside the uterus, so it involve ovaries, fallopian tube, and the tissues lining of your pelvis. So it can grow any side of your uterus, either in ovaries, either in the fallopian tubes, or either in the tissues. So what could be the pathophysiology of this endometriosis? As we know, in the cases of endometriosis, because of the influence of the hormone, the endometrial tissues that is located outside the uterus, as I earlier told, that thicken, break down, and bleed each month. But that blood can't exit the body because it is the outside of the uterus, and this blood become trapped. Sometimes it forms a cyst, and this cyst leads to the scar tissues and the adhesion formation, and ultimately leads to the infertility. And sometimes it irritates the surrounding tissues, and that leads to the pain. So endometrial, the female who is having endometrial, she can have complaint of the either infertility, and the pelvic pain is the most common feature in the case of endometriosis. And if we talk about the mechanical infertility or the infertility because of the pelvic floor muscle, so in the cases of the like in the cases of vaginismus, because of this tight pelvic floor muscle, the sexual penetration doesn't happen, and sometimes it leads to chronic pelvic pain and Sometimes chronic pelvic pain, pelvic adhesions, and scarring of tissues also resulting in the pain. That leads to the basically mechanical kind of infertility. And what is the role of the, as a physiotherapist, what is our role in this kind of, in the fertility? So basically, as a physiotherapist, as a women health physiotherapist, our aim is the provide natural, we give a natural solution. We don't give any kind of medication, any kind of treatment. We provide only a natural way to help or cultivate the soil. That is the, and optimize the fertility. And whether the couples are trying to conceive naturally or they are using any kind of assisted reproductive technology, that is the IVF. So our role is to provide a natural way to promote the to for the fertility boosting or to cultivate the soil. That is the our main role as a physiotherapist. And now we as a physiotherapist, we as exercise therapists, so what is the our role, or what can we do in cases of infertility? So firstly, if I talk about in the term of exercises, so what is the effect of exercises on the endocrine system? As we all know, so when we do any kind of exercises, the pituitary gland, which is located in the brain, that releases the growth hormone. And these growth hormone causing the these hormone tells the body to increase the muscle and tissues production. And these muscle and tissue production, because of these thyroid gland send out hormone that regulate the body temperature, heart rate, and the blood pressure, which in turn increases the metabolic rate of the body. So that is the effect of exercise on the endocrine system. And if we go for the weight training, or in the case of heavy weight lifting, so if we talk about the case of strength training or heavy weight lifting, so in these type of cases, exercises leads to the luteinizing hormone, and these luteinizing hormone leads to production of the testosterone, and the thyroid gland stimulate the production of the thyroxine, and these in turn stimulate these thyroxine speed up our metabolism. So because of this increase in the metabolism, the person can able to reduce the weight. So in the case of infertility, our role is also the fertility boosting, weight reduction also, and we can design our protocol in different way. So what is the goal of exercise and motility in the case of infertility? So our aim is help to improve the blood circulation of the reproductive organ, because we know in these type of infertility cases, there are some adhesions, some kind of pelvic tightness, pelvic adhesions develop. Because of this, person is not there is a lack of the blood supply. So in these cases, our aim is to increase the blood supply in specifically the uterus and reproductive organ. And our, as a physiotherapist, our next aim is the weight management, because weight is a issue, because we know what is the consequences of the obesity. And our aim is the eliminations of the toxins, hormone regulation, and most importantly, stress reduction by different kind of relaxation technique and fertility boosting. These are the goals of the exercise and the motilities. And what kind of exercises we can suggest to our patients, or what options we can give to our patients? So here are the few options I am presenting here. First option is the we can ask our patient to go for the 5-day split training. In this, we can make a program according to the week, according to the days. So we can here is the example. So we can ask the patient to Monday go for the chest and triceps exercises. Tuesday, she can go for the back and biceps exercises. Wednesday, she can go for the yoga and pranayam. Thursday, shoulder and arm. Friday, leg and core. And Saturday and Sunday, she can rest, recover, and relax. This is the option 1. And we have in option 2, there is the 3-day split training. And according to this, Monday, Tuesday, this is a roughly designed program. We can change according to person or according to individual needs. So Tuesday, she can go for the yoga and pranayam. Wednesday, full day. Tuesday, Thursday is the low intensity aerobic exercises. Friday is a leg day, and here Saturday is the walking and stretching. That is the simple exercise, that is a simple warm-up type. And option 3rd, there is a 2-day split training. Monday is the upper body training or circuit training, And Tuesday is the yoga and pranayam. Wednesday high intensity interval training, and Thursday is the lower body training or the circuit training. Friday is the Pilates, and Sunday is the walking and the flexibility. So here are the three options I have basically divided into broad category, or we can, this is not a fixed type of or a fixed program. So okay, accordingly, I have to only these kind of program to the patient. We can change according to a person need, according to individual need, according to her weight, according to her BMI. We can change our program completely. And what is the basics of these exercises? So we have to do once or twice a week strength training. Here earlier I explained what is the benefit of the strength training, how it help in the weight loss, how it help in the weight loss. And 30-minute everyday walk is must. So, and core and flexibility exercises is must. We know the relation of TIA and the pelvic floor, and yoga, meditation, pranayam, and relaxation exercises. And as I said that it is customized with a specific need according to person. We have to make the customized exercises or customized protocol. So in the modalities, what we can do, TENS is a very effective method for the pain relief. We can use in the cases of the endometriosis, or in the cases of pelvic pain. TENS is a very good modalities. What we can use. Hot water bag is a very good method again to increase the blood circulation in the abdominal area in the reproductive organ. And IFT, as we all know, it plays a very important role in the kind of in a cases of pelvic floor rehabilitation. In the cases of IFT, it help in the activation of the all muscle fiber. So this modality we can use easily without any contraindication in the case of infertility. And reflexology, as we all know, this is a very old and popular Chinese belief. And what is this motive of this reflexology, or we can say the acupressure points? That is the unblocking the vital energies. In the yoga and in the Ayurveda, it believes that in our body there are various chakras and the various vayus, and whenever there is a blocking of the vayu, or whenever there is a blocking of chakras, it leads to different kind of problem. So our aim is to unblocking this vital energy, blocking this vayus. So we can unblock, and we can unblock this vital energy by the help of the reflexology or the acupressure points. And it also help in the cases of hormonal balance, helping in the fertility boosting. It help in the improved digestion and in overall well-being of a woman. So we have various points for the uterus, fallopian tubes, pituitary gland. By pressing these acupressure points, we can definitely enhance our treatment protocol or enhance our results also. And there are in this topic, herbs play also important role. Whenever we are going for the vaginal steaming, the herbs play a very important role, and they help in the rejuvenate, nourish, and regeneration, and also strengthen and fortify the reproductive system. And what kind of herbs we can use, like the ginger, almonds, flax seeds, satavari, red clover, ashwagandha, and turmeric. These herbs plays anti-inflammatory role and increasing the blood circulation of this reproductive organs. And now what about is the fertility massage. There are various kind of fertility massage, like Mayan massage is very popular nowadays, and we can do in different condition. We have different kind of fertility massage. Like in case of endometriosis, we can do different kind of fertility massage, and we in case of fallopian tube blockage, we have different kind of fertility massage. So it's not a fertility massage is not a single type massage that we can do in every cases. We can do this massage, or we can modify according to the patient to patients. So basically, it's a gentle form of massaging technique that can balance our hormone, and it increases the blood circulation in the pelvic area, and it removes stagnant blood from the reproductive organ. And it, in the cases of the fibroids and the any kind of scar tissues, it's breakdown, and it stimulates the ovulation, and it help in the menstrual pain and improve the egg health. And there are many kind of fertility massage techniques, which include the pulsing, acupressure, trigger point therapy, and the superficial and deep strokes. So these fertility massage, along with the castor oil pack, help play a very important role in the case of infertility. So in case of if we talk about the yoga and what kind of yoga asanas we can do in infertility, so it's a huge topic. If because I'm by heart, if I say by heart I'm a yoga therapist, so it's my topic of interest, but because of limitation of time, I'm just giving a brief idea or name of that only asan which can use or which can do in cases of the PCOS or the infertility. That is the butterfly, Supta Bandh Konasana, and Bhardwajasana, Chakki Chalanasana, Savasana, Padma Sadhana, Sun Salutation, Halasana, Dhanu Rajasana, Bhujangasana, Naukasana, and the Padmasana. Here are these are very effective asanas in case of the infertility. The basic role is the increase the blood production or increase the blood increase or means push the blood or in the particularly uterus and reproductive area. So these are the yoga asanas, like this is cat and camel position and butterfly. Here I mentions only pictures. So these all are asanas play a very important role. And in case of mechanical infertility, when the pelvic floor muscle is tight, in the case of vaginismus, dyspareunia, as we know, in the case of vaginismus, there is no penetration at all. So no sexual intercourse is possible. In the case of dyspareunia, painful penetration is present. So our aim is, as a pelvic floor rehab therapist, is the reducing the pain and relax the pelvic floor muscle and to allow the sexual intercourse in a very easy and painless manner. And here a very new concept emerged in the case of infertility. So that is the low level laser therapy. And for those, this low level laser therapy is important. The mothers who have advanced maternal age, like more than 35 years of age, including those who have poor ovarian function or those who have uterine less uterine lining tissues. So in these cases, this low level laser therapy work very effectively. And in research, it shows that implantation rates were high in cases where the low level therapy was used before or after in the cases of IVF also. And what is the effect of this low level laser therapy? That is the increased production of the cellular ATP, DNA production increased, improved the blood flow, release the endorphins, that is the happy hormone, and decrease the edema, decrease the chronic inflammation, and increase the cartilage and the bone formation, and increase the collagen production, muscle regeneration, and decrease the aging to ovaries, and relax the sympathetic nervous system and promote the parasympathetic nervous system. Parasympathetic nervous system is for the stress release. And so these are all effect of the low level laser therapy. And who can benefit of these therapy? Especially the female who have less egg quality due to the age or low MH level, high FSH level, and woman who is the poor responder, 38 age or the over, and in the case of PCOS, endometriosis, and the recurrent infection of the abdomen, and any kind of history of abdominal surgery. And what could be the treatment schedule of this low level laser therapy? Is the 2 to 3 times a week we can go for at least 1 to 3 months before and after the IVF. So that is the treatment schedule of this. So thank you very much. So here I try to explain the role of physiotherapy in case of infertility in very brief because of the time limitation, but I hope I can convey my message to all of you.
Thank you, Dr. Garima. Thank you very much. You can move your screen. You can remove your presentation. It was indeed a very good presentation on infertility, and I hope people will understand its importance and will also come to know that yes, how as a physiotherapist can they help the patients who are suffering through infertility. I would really like to call upon our next speaker, Dr. Richa Singh, and she is the founder of Perfect Bounce. And she founded Perfect Bounce with a very beautiful vision, that is pain-free world and healthy India. It's actually a very beautiful vision. And Dr. Richa is IAP WC Bangalore State District Head, Bangalore District Head. She is also a dry needling instructor, and she's conducting workshops in Singapore, Philippines, and several other states in India. She has also worked with Olympic players, and she has also received Best Physiotherapist Award in TheraCon 2018, Einstein Award, Women Entrepreneur Award, and she is also an ultra marathon runner. So let's have Dr. Richa to give an insight on the topic of fibromyalgia and impact on emotional imbalance in women's life.
Thank you, Dr. Shah, for the long introduction, and thank you, Dr. Thara Sharma ma'am too, and for the opportunity. And can I share the screen share?
Please start your screen sharing.
Yeah.
Okay. Yes, it has started.
Fine. Yes. Yeah. So my topic is fibromyalgia, impact of the emotional imbalance on the woman life. And this is a kind of huge topic, but I tried to concise in the few minutes which I can wind up. And yeah, so syndrome is mainly like chronic disorder and is characterized by the widespread and the lot of inflammatory musculoskeletal pains. So it's a kind of widespread pain. So initially we do get confused with other pain and aches, because in this condition, all the women, they complain of one or other joint or muscle pain. So we try to be initially with localized treatment and all, but actually they have the whole body inflammation. So that, first of all, initially diagnosis and figuring out it only becomes a challenge. So there are few questions which when we do is exactly the patient's assessment and take the medical history, we need to question them to figure it out, rule out the condition, what is the fibromyalgia, do they have really that joint pain or the muscle pain, or do they have the fibromyalgia exactly. So, and symptoms are usually, it includes the fatigueness, insomnia, morning symptoms. So all these symptoms are kind of, lot of diagnoses are there. So we, very chances of that we get confused with some other diagnosis will come out and they do not get the result, quick result. And prevalence of the fibromyalgia syndrome is estimated at least 2.24% in the general population, and more in the women than the men, because of the both the even tendency to, lot of differences are there in the our physique and hormonal changes and everything. So it's like each and every joint roughly they have the pain in the different times and reasons. So statistics says that it is the common in the middle-aged woman, but can affect patients at of the either sex at any age group and all. So it's effectively almost ratio is 9:1 compared to the male and female, and it increases with the age. Usually age of the mid-30s to the late 50s is the more common age for the females to get in this one. Because in this duration, a lot of changes are there related to their career, home, and everything, and also a lot of balancing things there. So during that, it affects more to the human body. And the world, over 3 to 4% of the population has the fibromyalgia in India, and prevalence is much lower. It's almost 2 to 3%. So almost you can think of almost there are millions of population who need attention, and this is kind of very much of neglected area. First of all, initial diagnosis is only challenging, awareness is not there, and it's kind of tricky things which is still not in the light, and where a lot of people in pain because of the fibromyalgia. And it affects the woman ranging from mid-30s and late 50s. So in the 3 phases, mostly in this fibromyalgia, first acute, moderate, and chronic. So acute is generally they complain of 1 or 2 joint pain on and off. It again subsides with some medication and all. Then they are much more frequency goes higher in the different joint pain or the muscle pain. So they complain of one day upper body somewhere, next day they might have somewhere like shifting pain, they keep continuing. And what as they visit any orthoneuro or any physician, then they always have the challenge, okay, upper back pain must be trapezitis or something. You do get confused with the other diagnosis and all. And the chronic is somewhere where I have seen a patient who is with the daily 900 mg medicine dose is almost in the sedative stage, but still pain is not controlling. So body becomes sensitive, too sensitive over the time period, and they get touch pain and they get sleep disturbance, lot of other things they get. This whole 24/7 they are in pain for one or other reason. So it's like, body, they learn to deal with that one. It's like they think they can never ever come out of the pain. And it's like a pain that's with all these conditions and all. So sometimes when they visit the doctor also, it's difficult for them to explain what sort of pain they are getting. And exactly, we go ahead with something with the upper body, we go with the X-ray and everything and all treatment. So line of treatment goes wrong sometimes. And actually they have more relation with the other deep pains, what we are not able to figure it out when we come to the clinical practice. History of widespread pain for the more than 3 months, which is the diagnostic criteria mostly, and pain in at least 11 of the 18 defined tender points are there, and there's on distal palpation with the force of the thumb, which we can. So what happens, as we are mentioning over there, 11 of the 18 defined tender points. So there is no diagnosis directly, any X-ray, MRI, or something which you can rule out. So what happens? Doctor go ahead with all the checkups, and if something they are not able to rule out with the rheumatoid arthritis or trapezitis or any other thing, then they just figure it out, okay, they declare it as fibromyalgia and you need the counseling and etc. etc. The patient also go in kind of a depression that why I need the counseling for this one and all. So if nothing comes up in the rule out with the X-ray, MRI and all the diagnostic checkups and all, then they just declare it as a fibromyalgia. Most of the time this is the scenario in this condition. The patient also not ready to accept that something like this exists and they are in that page. And so these are the most prominent spots, these red spots, which patients or females do get the pain on and off. And this we get confused with trapezitis, cervicogenic pain, or the radiating pain with the nerve compression. And obviously they go for the X-ray or something, so they must have some degenerative changes. So we think, okay, something wrong with the cervical spine. And then we keep correcting that line. And so it's really difficult initial stage. So they keep getting this frequently pain, how much ever medicine treatment they continue with. And with that, they'll have the chronic severe headaches sometimes, and we just confuse the migraine, can be the migraine, this thing. So what happens with first fibromyalgia, with that associated lot of other things what we get, and we keep ruling out one in patches, we keep doing the treatment. So that's what you do not get the solution of what is the condition they have. So two scales, what we measure it as in this fibromyalgia pains, widespread pain scale and the symptom severity score. So these both are the criteria where we figure it out can be the fibromyalgia to diagnostic. These are the major 18 points for the when we palpate and search. If out of this 18 points, if there is at least 11 points are painful or they complain within a year, they have on and off pain in these junctions. So then initially what happened, we assume that might be D3 and B12 deficiencies. We just suggest with some supplementary dietary supplement, and you can go ahead with that one. So, but if it's still not ruling out, so these are the reasons which, sometimes diagnosis go delayed. So they keep figuring out what is happened exactly and why it's again and again triggering the pain. And women and men different is not only in the, obvious physical attributes and all, but also in their psychological conditions. So the thought process and all is very much of emotional pain and the physical pain, different aspects. So when body is not recovering from the physical pain, there is chances of that emotional pain which holds and is not allowing it. And gradually it becomes kind of autoimmune for the body and resistance to the any sort of medication and everything, which is not ease out their pain. And there are actual differences in the way women and both the men brain structured and everything. So women and men different way in the communication, deal in the relationship, express their feelings. All these things, lot of causes are there, which females holds a lot. And then gradually balancing all these things, work balance and home, everything at the same time. So mostly age of early 30s to the late 50s, they have to deal with all these things in all together. So they deal with a lot of balancing thing, and that time only they keep complaining of one or other pain. Sometimes they can share, sometimes they cannot. And initially, sometimes they grew up in such environment. Okay, you should be very much tolerant. You have to do adjustment and all that. So they do not even share their pain aches, and if something they wants to share, so all these things keep holding emotional pain in the body, and gradually this lead to this condition. And the data says that when mental health affects is like depressive disorders accounts for close to 41.9% disability from the neuropsychiatric disorders among the women compared than the men in 29.3%. So all these things, estimated almost 80% of the, 50 million people are affected by the violence, conflicts, civil wars and all. So a lot of like now, whatever Ukraine, Russia thing is happening and all this thing also over left over the women, most of the things, they have to deal with all those things. And so there are population, different reasons are there for the emotional pain, and that triggers later on to be because they cannot let go few major incidents in the life. And lifetime prevalence rate of the violence against women ranges from the 16% to the 50%. And then bias again, what makes female apparently more vulnerable to all these things? Obviously, hormonal factors related to the reproductive cycle. And today we're talking a lot about already Dr. Samranjit and Dr. Garima has mentioned a lot about it. So that affects in this level too. Again, fibromyalgia is also very much related to all these changes in the body. And the gender disadvantage, physical violence, being widowed or separated, a lot of things. So the way men deals with all these emotions and the way women deals is totally different. And that's the one reason they try to always balancing, and that fight among them only that, keep trying to balance everything and all, and they get in the emotional pain more. And during their lifetime, females have faced various life stresses, including the childbirth, maternal roles, caring and nurturing the old and sick of the family. All this responsibility comes to the end of the day, the lady in the family. And that it happens during that time only, and they do not get time to take care of themselves, and they try to be correct everything else to be perfection. So perfection toward the other things, sometimes they lead to all these reasons. So me time, what is called as, they do not get in the most of the time in the working life. And in addition, women are less empowered due to the lesser opportunities of the education and the respectable employment. So we talk about the tier 1 city and developed country, that is fine, but we have to think about the tier 2, tier 3 city and the rural areas where these opportunities are not there. And moreover, even those who are financially secure fear to the cross social lines, and therefore too are apparently vulnerable. So not necessarily we were empowered, we think of, but there are a lot of social barriers are there which they cannot do. So all these are the reasons they do. Mental health problems related to a lot of things as a business. Their workplace also can be work-related stress and occupational ill health, poor productivity, and the human error they lead to be. So all this that increases their sickness, absence, a high staff turnover, and the poor performance in the organization. So they get conflict daily. They fight with all these things in day-to-day life and all, and that leads to end of the day one or other area pain. Almost daily they go on the bed with some sort of pain. And they think, okay, this is normal stress and can be the next day body. If next day body is getting ready for your work again, that is perfectly fine. Can be really stressed and we do get the pain, it's here and there. That is perfectly fine. But again, if that is again and again, and body is keep giving the alarm and is disturbing your productivity at the workplace or any other things, definitely need to pay attention first to the body. And this is the things happens over there, balancing everything. And working towards a brighter, secure, and stable future for the woman. So there are a lot of companies, especially the developed countries and the MNCs, who are taking care of at the workplace. They're trying to be keep it, less stress for the woman. But yeah, definitely this is not applicable for all the organization, and other organizations should be take care of this thing, because what the expectations is from the men and the women employees totally different. It goes little bit obviously, but company not going to compromise on the productivity. And women also try to always fight with the things, I'm better. So have to be somewhere to understand the body and move on. So how the things what they can let go, they have to let go, either it's related to the workplace or at the balancing the home, both the things, and try to be balance and move on with the things. And so what come to the treatment part? So treatment part, definitely they need first, most of the time patient when they come, they have visited all the possible ortho, neuro, and the rheumatologist, everybody. And then finally, they end up with all these things. And at least 10 doctors when they visit, then they come to the physio. So my line of treatment, first definitely I do a lot of counseling for them, and then physiotherapy. And in physiotherapy, first pain management, definitely we need to do. So when how we have to figure it out. Most of the time it happens, they come with the upper back pain or some joint pain or something else. Like, okay, I'm from 5 years, 10 years, 20 years, I'm getting this one. And then what happens sometimes when they say, okay, this is the time when it started. So I asked one very clear question that by any chance when it has happened to you, is it triggers when you have any sort of stress in your life, either anything? Then if the answer is yes, then second thing I asked, whenever it has started, you were going for some emotional imbalance, like kind of related to family or office or anything, which took time for you to recover and come back to the normal. Might be somebody's death in the family or some major incidents can happen in the family, or a job loss or divorce, anything can happen. So that time is triggers, or the post-delivery, some complication can be happen, and during that they haven't taken care post-delivery just because they are already going through a lot of hormonal changes and all. So these are the time when this triggers and they do not figure it out. They assume, okay, all these things happens because of these are the hormonal changes, and post-delivery, a lot of changes happens to the body. So they assume it as this is very much of generalized panics, and suddenly their life changes and they get busy in a lot of things and they do not take care of the thing. We talk about a lot of postnatal exercise and the Pilates and a lot of supplement, everything to support the exercise and all. But very few, I don't think, not even 1% of women in India, I believe, they do anything of postnatal care, or even working and who are aware of educated population also I'm talking about, not about rural area only. So this happens, and these are the things, negligence gradually lead to such kind of the problems, and their expectation changes in the family, and that doesn't get fulfilled, and they get in the emotional pain. So they get confused with the enjoyment or the thing, and they find after some time, they are like, neglected as something. So all these things are feelings, not necessarily they should feel it, but yeah, they go in that phase and the body takes time to recover. So first, definitely take care of the pain management which is important, and parallelly the counseling pill. But suddenly, if any doctors also advise them to go for the counseling, they take it as, I don't have any psychological problem, why I should be. So, and some sort of massage and all helps, definitely exercises, definitely based on that, what conditions. So generally, if they come in the acute and moderate condition, there are treatment in the physiotherapy with other things, but chronic pain management, when they come with already, I've treated few patients who are since 6 years almost on the steroid dose, and still you're not recovering. But yeah, with the physiotherapy treatment and pain management, the body has recovered a lot. But yeah, they need a lot of follow-up, so that patients from the patient side also is not there. So all these things are the challenges where to get optimize the result. In India, awareness is a lot of lack is there. First of all, I can say awareness is not there among the people and among the doctors also to work directly, because all the branches or the segments of the medicine, what they try to be, whatever their cases they handle, otherwise no one give. So there is no specific hospital or the clinical setup who take care of only fibromyalgia. That is the one challenge where the people do not get to know, and they come with one or other joint pain or back pain. So everybody getting confused, and they keep treating the trapezitis or the low back pain condition, all these things different. So that time, keep adding on their problems. So it's keep increasing. And later on, the challenge is over here that, again, the new learning from the residents, from the physios also to be not to be think next level and work something better. Keep why she's getting a lot of pains and different joints, recurring pain is there. And again, what happen if you think of correcting this at absolute level, and there's no awareness and there's no hospital or segment where you can get only the fibromyalgia patients. So both the way it is not even awareness layman and not even doing anything from the medical setup also. Where one place only they can get everything together, and so they can get the better result outcome over there. Exercises, diet, lifestyle changes, everything they have to be do in the long term to get the because they're getting the very much of body becomes sensitive. So to control that one, gradually it works. It's not a one-day thing. So patient also need to have patience, and there are treatment as Dr. Simranjit has mentioned about the cupping. So yeah, definitely dry needling, cupping, ISTM, myofascial release, chiropractic adjustment, everything can be done. A lot of things you can explore and do. Like combine with all these things based on that what body requires, in what condition they have come, and what all I can mix and match and play with the get the better result. So I love to play with the dry needling more, and definitely get optimize the result, because that's very quick result I get, and that works much more faster than anything else for such cases. But yes, in chronic pain, what happens, dry needling is challenging for them because the body is too sensitive, they cannot take it only. So then I have to work on the other methods, and then I get the optimized. First I stable the body, then I come to that trigger release with the dry needling more. So, and these are the few things what we do. Definitely I combine with they can do any sort of activity what they love to be, they can pick up, and that helps a lot to be working. And again, swimming helps a lot for the sensitivity control, and that is the best exercise for them to overall recovery. And if not swimming pool is available, I suggest them to, if they can have bathtub or something they can have, that also helps a lot, at least weekly once they can do. So that helps a lot. And yoga definitely helps, any form of the Pilates, form of the exercise, whatever light exercises they love to pick up, and one hobby what they can enjoy, that helps a lot in the recovery with the physiotherapy treatment and all. So few patients what we have done this thing and we get the result and all. And as I combine with cupping, needling. So this kind of things what you do. Few male patient also I do get with this one. So what happened? This cupping marks is this thing. So mostly in the chronic when these are the fibromyalgia cupping marks. So post treatment what I've got. So this shows a lot of toxin accumulation. Generally for the female body we do not get this much of cupping marks in any other conditions and all. So it's like that shows there is a lot of toxin accumulation and the recovery is slowed down and because of a lot of medication and everything tried. And as recovery has slowed down overall, so that this cupping helps a lot to be ease out muscles. Then gradually they do get confidence and work. But yeah, with the cupping, I do combine again dry needling, ISTM, myofascial release, chiropractic adjustment, and exercises and a lot of counseling. Counseling plays much more role than anything else in fibromyalgia cases. And definitely, women need to be work on their emotional health and learn to let go. That helps more than. And with this, if you like, this works on the cherry on the cake. So this kind of treatment works a lot for them. Thank you. For any queries, you can contact at this number. Thank you, Dr. Shah. Over to you.
Thank you very much, Dr. Richa. And you can stop your screen sharing.
Okay.
And I'm sure that people might have understood about the fibromyalgia, and they will now not just stop themselves from mixing it with psychological, but they will now try to add on their own roles with the adjunct therapies as already discussed. So
yeah, that was for the physio, but I would like to tell about the women's also, as here all the women mostly are here. So everybody has to first learn, let go thing in the life instead of keeping whatever is here and there. We cannot control each and everything. So best way to try to be, not to be think of the perfection level, go easy in the life. That helps a lot in anything. Few things we can get, few things we won't get. Thank you. Thank you.
And when I shared your topic with Hed sir, he really liked that. He liked the topic. He said that yeah, majority of the cases of fibromyalgia might be untreated because of an improper diagnosis.
It will take for India another 50 years to become at the level where the awareness will be there for family.
Yes.
Very much Thank you so much. Lot is there to explain.
Thank you very much. So with this, I would really like to call upon our next speaker, Dr. Vinoda. So Dr. Vinoda is Dr. Vinoda she's presently working as a clinical physiotherapist, and she's affiliated with Apollo Cradle, KIMS Cuddles, Ankura Hospital, Femicity, Lotus, and many other majority maternity hospitals in Hyderabad. And she's a member of Breastfeeding Promotion Network of India, BPNI. She has pursued several certification courses and got certified in this field. And she is an advanced certified lactation consultant, certified childbirth educator Lamas from 2011, certified hypnobirthing practitioner trained in spinning babies and water birthing techniques, pre and postnatal exercise experts and yoga experts, labor support professionals, and pelvic floor therapist. So let us have her for a talk on round ligament pain during pregnancy and the role of physiotherapy. Again, round ligament pain is something which many of the patients pregnant females might be suffering, but they don't know what to do. So over to you, Dr. Vinoda.
Hi, thank you so much for the warm welcome, Dara. I hope the video is clear.
Yes, the video is quite clear.
I'm audible, right? So
Yeah.
Very glad to connect with you all on this platform. I got to know really very wonderful things and the amazing work you all do, and how diversified after physiotherapy we can all, pursue different careers related to physiotherapy and be professionals in those. And as a physiotherapist itself, the profession itself brings out the best and adds on more life to the person. I think it adds on more quality to the life. And we all work on the biomechanics and the physiology. That is the most interesting part. And we work in adjunct to restore the body back to the basic biomechanics, or we help to make the biomechanics better for the person along with other interventions, or after the interventions are done. And our life usually becomes, or our role as a physiotherapist becomes even more challenging when the biomechanics and physiology in the body keeps changing. That means especially when you are working with pregnant women, she is undergoing a lot of biomechanical changes in her body. There is a saying that Dr. Dara, I didn't share my screen, I guess.
In your shared, you can start your screen sharing, Dr. Vinoda, as your PPT has not been accessed by me. Yeah, it's done.
Okay, yeah. So, today we're going to talk about round ligament pain, but the pregnancy aches, there is a saying that the pregnancy aches and pains are common and nothing can be done about it, but this is not true. Women's bodies are really amazing. From maybe you consider from menstruation to pregnancy to birthing and then postpartum and menopause.
Sorry to interrupt, but you can keep it on the slide sharing mode.
Slide share, 1 second. Right.
Better.
So through all these stages, women's bodies are going through a lot of changes. Their bodies are really amazing. Our bodies are amazing. And there is, if you just understand the physiology and biomechanics, we will be able to address these issues which are going around in these stages very much better. So during menstruation, what happens to the body? In the uterus usually moves forward and compresses. There is a compression pressure, cramps occur to push out the blood from the uterus out. So if you just understand the physiology, it will be easier for you to give them a better treatment. And what happens during pregnancy? During pregnancy, there is a pregnancy waddle. We usually call it as, this is the pelvis here. And during pregnancy, what happens? There is a pregnancy waddle. We all walk with a wide base. The mom walks like a penguin. So there is loosening of the joints in the pelvis, and there is a downward pressure from the growing belly. So firstly, there is loosening over here in the pelvic, all the joints, and on top of it, there is pressure of the growing belly. So what happens when the pressure increases? The pelvis widens up little more. Wider pelvis will have a wider stance. So that is the explanation we can have for a wider stance or the pregnancy waddle. So you can try to walk with a narrow stance and try, but that hurts and you may lose balance as well. So today we will be discussing about the round ligament a little more in detail, round ligament pain in pregnancy and our role as a physiotherapist. So these are the different ligaments that are involved in and around the uterus: the broad ligament, the round ligament, the ovarian ligament, the cardinal ligament, the uterosacral ligament, all these ligaments. So what do you actually call a little bit into the anatomy if we go? What is a tendon actually? A tendon is a fibrous tissue which will connect a muscle to a bone. And what is a ligament? It usually connects a bone and a bone. But here, the round ligament is slightly different. Round ligament connects the organ to the bone, organ to the organ. So its role is slightly different. So let me introduce the round ligament properly to you. So this is the round ligament. Usually the round ligament of the uterus, it starts as a broad, flattened kind of thing in front of the uterus, here, and it is attached superior-laterally. It usually starts from the superior part of the uterus here, and it goes down towards the lateral part, comes down through the femoral triangle over there, through the inguinal canal, and then few fibers over to the pubic rami, and then it goes into the mons pubis, the ipsilateral side, labia majora. So this is how the orientation of the round ligament is in the uterus and the pelvis as such. There are two round ligaments, and these are about 10 to 12 centimeters in length. So there are broad ligament actually encompasses this round ligament and the fallopian tubes, the arteries, the veins, the lymphatics and all. During pregnancy, what happens to this? Let us have a closer look. It is this round ligament is not like the cruciate ligament of the knee or any other ligament. It is usually having some smooth muscle fibers in it, and that is the reason it can actually go into spasm. So it can expand. Have a look here. This is the pelvis, and I have made a small arrangement with the balloon, the uterus. Just give me a minute. So I messed it up just a minute. Right. So what is happening here is when the mom is in the pre-pregnancy stage, I mean before pregnancy, this is the level of the uterus till here, and this is the length of the round ligaments on either side. As the mother becomes pregnant and the first trimester, there is a slight stretch on the round ligaments, and during the second trimester it is the maximum. So this kind of stretch on the round ligament puts lot of pressure, and that can be the reason for the mom to have pain in that area. And also we know that there is small change in the pelvis regarding the range of motion. The range of motion in the pelvis slightly increases due to the prostaglandin and the relaxin hormones that are present during pregnancy. So usually the range of motion is affected because of that laxity in the ligaments, and the pelvis makes some postural adaptations, and part of it along with the weight gain in pregnancy and the center of gravity moving forward, usually there is an anterior tilt in the pelvis. So imagine the round ligament being stretched to the maximum, and also there is an anterior tilt. There is a high risk for the round ligament to be overstretched or maybe going into spasm. So these kind of things actually cause pain in the round ligament. So they can stretch, they can adapt, but sometimes, this pain can be mild, but sometimes it can be, lasting for long, and it can be on both sides sometimes. So you will have to address this kind of round ligament pain in pregnancy. And because it passes through the inguinal triangle canal and the femoral triangle, there is a high chance that there is impingement over there, and it might compress the femoral artery and the nerve, and that is why there might be pain radiating towards the anterior of the thigh or the in front of the leg muscle. So these are the different reasons why there could be pain, and we will slowly let you know how this kind of pain can be treated and what do we usually do. And sometimes the reason for this pain in the inguinal region can be because of the venous blood flow which the round ligament has. There might be not draining properly because the increase in weight of the uterus is not allowing the venous flow, and pooling of the blood might happen and may result in different varicosities over there. And this appears like a bag of worms in the ultrasound and MRI scans in the diagnostic procedures. They can usually see it. So there is a huge difference, but every mom will not be having to a great extent. Some moms are affected and some are having mild pain. So I've heard, I think Dr. Garima saying that each person should be treated different. This is very true because there is a vast difference in the adaptations every person goes through whenever there is a change in the body. And when the pregnancy changes are happening, the mom might have adopted in a different way. So we need a thorough evaluation, and a proper treatment according to her needs should be given individually. So do not start off with any treatment without proper evaluation, and one treatment does not fit all. So let us understand that every person, every mother, every pregnant mom needs to be treated in a different way. So this is the same thing I am going to show here in the pictures. So this is the round ligament, which is in the beginning, and then when it is stretched to the maximum. So the pain is there, and there is a deep, sharp stabbing and stretching pain almost near the groin area. See how much it has expanded, right? So, and the anterior pelvic tilt. So what are the aggravating factors, and what does this round ligament pain feel like? What is the treatment plan, and what are the red flags? Women often have this pain in the second trimester. Most commonly, the pain is there for most women during pregnancy, and pain is more often on the right side due to the clockwise rotation of the uterus. So there is usually more strain on the right side because of the rotation of the uterus. Sometimes the pain is there on both sides of the groin. This pain is usually described as aches, cramps, stabbing, sharp and pulling kind of sensation. And this pain usually lasts for a few seconds, but sometimes can last for hours too. What are the aggravating factors? The pain is usually worse when there is a sudden movement, something like coughing, sneezing, your round ligament already, which is, overstretched and strained. When there is a sudden cough, laughing or sneezing or sudden movements, this is going to aggravate the pain. And you can see the mom holding, her lower part of the belly and, feeling that. It might be difficult for her to roll in the bed, and climbing the stairs might be very difficult. So what is the treatment plan that we can go about? So the most important thing is postural correction, resting in smart positions, avoiding lifting heavy weights, avoid standing for long periods of time during pregnancy, and we'll have to teach them ergonomics, how to roll in the bed properly, how to come from a sitting to standing position, standing to sitting position, all these things. And when she coughs and sneezes, how to place her hand under the baby bump for support, and lots of stretching exercises. We should ask her to take time to change positions and do it in a slow manner. And, we can advise her to bend or flex her hips so that there is little less strain. And obviously warm packs can be applied. And research shows that water exercises and aerobics show great impact. And there can be specific care also that is needed for women. So self-massage techniques can be taught. We'll have to show them where they can do the massage, and spinning babies techniques can be applied. So as the round ligament goes into spasm, there is a change in the orientation of the uterus also, and it is impacting the room for the baby, and baby might be not be in the optimal fetal position. Baby might come into another position, or head might be tilted to one position. So pelvic alignment is the most important thing here. If there is pain, not just treating the pain and how we have to affect how to relieve the pain and how to align the pelvis back. Otherwise, if this pain is persisting for long and mom is thinking it's okay, I'll just bear through it, it's a common thing. That is not true, because it is affecting the room for the baby, and the baby's head might be tilted, or baby might be slowly turning to breech and moving away from the optimal fetal position. So the different techniques like forward leaning inversion, 3 sisters of balance, open knee chest positions, all these can be tried. Kinesiotaping can be done, and we can encourage the moms to use abdominal belts, and pregnancy supportive clothing can be used. So what are the red flags? When should you think, when you suggest the mom that she needs to see, or she needs to keep these things in mind, that whenever there is a bleeding, she needs to report back to her physician, not to us. And then whenever she feels that the pain is not subsiding, so it might be contractions, which might mean preterm labor. There she might be having chills, fever, so vaginal discharge. All these are not good signs. along with groin pain. If all these are there, then definitely they will have to come and meet the physician. And if there is persistent pain, but sometimes this could be misdiagnosed, or it could be actually inguinal hernia or appendicitis, or it could be placental abruption. So while assessing also, as the physiotherapy part, we should also rule out the lumbar spine pain, the sacroiliac joint pain, and the symphysis pubic pain. All these things should be ruled out. So differential diagnosis also should be made. And sometimes this can be complicated because of the ectopic pregnancy, acute abdomen pain, ovarian torsion, renal calculi, gallbladder diseases. So other diagnostic tools help in diagnosing, and we should always recommend them to come for a follow-up care, and documentation should be done, and the return of care should be addressed as scheduled for the gestation and as indicated by the test results, and with the onset of the warning signs. It should always be a collaborative practice, considering the consultation or referral to the obs-gynec surveys or abdominal pain inconsistent with round ligament pain should be really addressed quickly. There might be abnormal test results, so they should be considered. And for diagnosis or treatment outside our scope, as physiotherapists, we must be keeping that as a note. So this is another picture which shows the round ligament. So the treatment plan, as I have mentioned, we have to teach them the ergonomics, how to shift positions to take the pressure off the strained ligaments. So she can be advised to move, though she's sitting in the same position, she can just move a little bit, and then she can use some supports like stools when she's sitting, support her back. She can do some movements, so the ligaments have some time to adjust by doing it in a very slow and gentle way, and rest as often as she can, and flex the muscles in the hips before sneezing, or applying the hand near the groin and the lower baby bump. And of course, she might have started some painkillers as well. And we can advise her to have a belly band to take off some weight, and apply some warm compress to the lower abdomen. And we can give her a gentle massage on the affected area as well. So the red flags, if there are red flags, she must see the gynecologist or her obstetrician. And flu-like symptoms along with ligament pain definitely needs to be reported. So what are the exercises, and what is the prescribed exercises that the moms can do is the cat and camel exercise, and relaxation as part of pregnancy, because of this pain constantly, she might not be very much relaxed. So if we can teach her some methods to relax her entire body, that might give her a little relief. And the way she is lying down, where the pillows need to be kept, how the body needs to be aligned, should be taught to her. And we must advise her not to stand for long periods of time, and pay attention to the posture, and advise her to drink a lot of fluids, and avoiding this confusion and pain with the actual labor pain. So the diagnosis should be very good. How should she manage and change positions should be instructed. So moving slowly should be instructed. Gentle stretching should be encouraged. So side bends, this stretch targets the obliques and the latissimus dorsi muscle. And hip flexor stretch, this stretch targets the anterior thigh and hip compartments. Pancake stretch, this stretch targets the inner thigh and the hip joints. Kneeling adductor stretch, this stretch targets again the adductors and inner thigh. Like a pigeon pose can be done. And most importantly, Usually there is more anterior tilt as the months advance, especially in second and third trimester. So we have to advise her to correct her posture. Too much of anterior tilt which is there should be corrected, and she must be encouraged to lift her knee and do some exercises like twisting her knees from the one pose to the other. Runner's pose can be encouraged, and she can even use a soft ball on the sides and sleep over it. That will also help her to stretch the ligament on the other side and the muscles on the other side, because there might be tenderness in the surrounding muscles also. It's not like we are giving exercises only for the ligament. We are using the exercises to stretch the muscles. There might be rebound pain, there might be referred pain. So all these things should be treated as well. Yoga also helps a lot, especially the gate pose sequence helps a lot with this round ligament pain. So this is side bending in the gate pose, and then pelvic circles can actually help in sitting position they can do. And flexing one leg like half malasana can help. Breathing and giving warmth by touch, that's a really wonderful feeling. A warm touch gives a lot of relief. Again, stretching onto the side, stretching slightly backwards, and then almost the runner's pose, slightly modified. Again, a gate pose, and then sitting over a bolster actually helps, to stretch the hip flexor a little bit. If you're sitting and the knees are a little lower, the hips are a little higher, and you can even lean back. And according to the comfort of the mother, you can suggest if she can go back a little more and lie down. If she can, you can encourage that. And then bending forwards, like a child pose, will definitely help. Twisting. We can also teach her self-massage. So where should she do the self-massage? So to find this area, we'll just have to trace a line from your belly button diagonally down towards your leg, and then another one from the front of your hip bone size diagonally towards the other leg. So the area where these two lines intersect is generally where the round ligaments are there. And to massage, you can usually use a broad contact with your hands, and you can put some gentle pressure towards your stomach, and they should not become very tender after the massage. They must be able to get some relief. And this is the area I'm telling. So one inclined line from the belly towards the leg, and the other one from the hip bone anterior part towards the other leg. So the point where it meets, so usually over there. So this is the area. And suppose there is a tightness on one side. What do we have to do? We can stretch the tight side and inhale into the tight area. Exhale, release. You can use a pillow, or you can use a peanut ball to do this. You even do ball stretches. Stretch the tight side, by moving on to the opposite side in kneeling down position.
Doctor,
Pardon?
Me?
Hello?
Yes, ma'am. Can you please conclude a bit faster? Because
Sure.
another two speakers has been waiting.
Sure. Okay, fine.
Thank you, ma'am.
So this is another technique called kinesiotaping, and this is the spinning babies techniques. So thank you very much.
Thank you very much. Dr. Vinoda, you can stop your screen sharing. Dr. Vinoda, you can please stop your screen sharing. We will not, yeah. So thank you, Dr. Vinoda, for a wonderful talk on round ligament pain. And going ahead with the same flow of pregnancy. The next we have is Dr. Shalinta, and Dr. Shalinta Tyagi. She is a women's health practice. She is a women's health physiotherapist, and she is WOW-IPRI licensed clinical instructor as well. She is a certified childbirth educator from Lamas and Hypnobirthing Institute and lactation counselor from BPNI. She has worked with most of the leading mothers and childcare hospitals in Gurgaon from last 16 years, and she has been a lactation educator for nurses in North India on behalf of Medela and Danone India. She has been taking lamas and lactation classes for expectant parents and preparing them for a healthy pregnancy, healthy experience of birth and breastfeeding. She has worked as visiting faculty obstetrics and gynecology in SGT University, Gurgaon. Presently, she is associated with Cloud9 Hospital, Gurgaon as a consultant women's health physiotherapist. So I warmly welcome you, Dr. Shalinta. Happy to have you again. And please give us an insight on the role of physiotherapy during childbirth and lactation.
Thank you, Dara. Thank you so much for this, wonderful intro of mine. And I have been actually throughout since this conference has started. I have been listening to all the speakers and the immense knowledge they all have. This is a very good platform that at least we come to know. So I thank IAP India and Women's Cell for organizing it with Khyati College and giving us all speakers this opportunity to share their own experience and knowledge over here, which can reach to other physiotherapists who are looking forward, and especially when they look forward what exactly they would like to do after they complete their bachelor's. So this is one area which is exploring more of the opportunities for them. So, and before starting, I would definitely like to thank WOW team and Dr. Haith for recognizing what I have been doing, because it was last 16 years that I was actually helping mothers in obstetric. But through this platform, through the courses and whatever the recognition that I have got, I am actually truly blessed to be part of this WOW team and the vision of Dr. Haith. So the topic that is being given to me today is, of something which it's close to my heart, and I can go on talking onto that, for long hours. But there is very less time that is being decided by, the speakers here in the conference. Hello. Is it, can you all see this?
Ma'am, your video is able,
yeah.
we are able to see, and yeah, we can
Yeah,
see
yeah.
this.
Sorry, I think it got, there was some issue with the slides. I'll just start with it. So the topic that I have for today is the role of physiotherapy in childbirth and lactating mothers. So, even I used to wonder, and maybe, many of you would be thinking, as a physiotherapist, what would be our role in childbirth and lactation? So, when I started with my work, it was only, when we have to do with the, physiotherapy for obstetric women, it used to be more of, you have to teach them antenatal exercises, or you have to just teach them the postnatal, exercises once they deliver. But when I was closely started working, and when I got myself certified as a childbirth educator, and then finally, got an interest to do masters in obstetrics and gynecology, I really, got to know that there is so much role that we can actually play for an obstetric woman during childbirth and lactation as well. So it is not related to only during the antenatal period, but it is at the time of birthing the baby, and also when they are breastfeeding. So when we have to actually help a woman with the childbirth, right? So if we want a woman to help with the birth preparation, so there are two times that we would be doing. One is, yes, we can be doing, giving them antenatal education. And secondly would be at the time during the childbirth, actually during the labor process. So when we say we can help them in antenatal education or the birth preparation session, that means we will be helping them throughout, though with the antenatal exercises, plus especially there would be some exercises that can be discussed with them related to more of, increasing the pelvic flexibility, because somewhere everyone in the back of the mind, they do have this thing that we want to go for a normal delivery. So for the normal delivery, already like, as Dr. Vinoda also shared and other speakers also were discussing about the ligament stretch and all. So there is a laxity in the ligaments. Already the ligaments are working towards the stretching and flexing capacity, plus the exercises, plus the movements that we are going to discuss with them, especially like full squat, or we can also help them, with the butterfly position, suggesting them to do the duck walking supported by the partners and the lunges. All these positions and the exercises are going to help them make more flexibility at the pelvic area. So that is one area that we can discuss with them when we want to, share the knowledge of birth preparation. Second is the breathing techniques. Breathing techniques are very, very important. As we all understand, there is a coordination of our breathing and the pelvic floor muscles relaxation. So they have a coordination of, the relaxation and how the, we are kind of breathing at that moment, especially if they are breathing at the time of first stage of the labor. That is going to be a different breathing technique as compared to when they would be breathing in the second stage of labor. So both the breathing techniques are going to be different, and they have to understand why I am breathing in such particular pattern in first stage of labor, and what would be the way that I should breathe during the second stage of labor, so that it becomes easier for the baby to come out, the muscles to relax, the pelvic floor muscles to relax to their maximum capacity, and then the push or the urge that they have during that second stage will be more beneficial. So this coordination needs to be discussed in the birth preparation session, and we can also help them to understand a bit of it. We won't suggest them to actually do the efforts of pushing at that moment, but make them understand with the breathing techniques what is the effect that they feel, how they feel the relaxation or the contraction of the pelvic floor muscles when they are trying to do the breathing in that particular way. And then the third important thing is the perineal massage. So when we have the perineal massage is something which is, being asked by me, asked, various women, pregnant mothers, they are coming and asking me now that what is this perineal massage? This has become very common these days to understand what exactly we have to do and what is perineal massage, how it benefits. So this perineal massage is something that can be started from 34th week. So once they complete the 34th week, they can start with this perineal massage once in a day for 10 minutes. And this is more to increase the flexibility around the perineum. So our superficial pelvic floor muscles would be actually kind of stretched more. So this can be done by the pregnant mother herself, or the partner can also do this perineal massage, and they should be guided how to, perform the massage in a way that increases the flexibility, it increases the stretching capacity of the perineum, and which can actually lead to no episiotomy or very small episiotomy cut. So why do episiotomy cut is being given is so that they cut the lateral fibers of the muscles so that baby can come out easily. If the muscles are more flexible at that area, so there would be less chances of tears, and there would be more easily the baby can come out. So this one particular perineal massage is very good to be discussed with them, and also if it can be done and helped by the partner also, or you can also try and explain them that how to actually do the perineal massage during childbirth. Now if we get a chance as a physiotherapist to assist a mother during childbirth, that is something I have assisted, and I have found, and even the topic of my, thesis work was related to that. I worked on to understand what would be the, how walking around, how the positions, how the movements are going to benefit a woman at the time of, during the first stage of labor. How does it impact it? And it was found that a laboring woman felt less pain as compared to the one, who was walking, who was actually lying down fully at during the entire labor period. So the one who was walking around and who used to keep on changing the positions, she was much benefited. And even the time, the labor time was decreased. So they didn't had long labors, whether, it was an induction or it was a spontaneous labor. So in both the cases, the response was very good when these techniques were used. So one is, yes, the positions and movements. So when we are, we suggest a woman to keep walking or to stand or to do, pelvic tilts or to do, sit in a squatting position. So all these positions are definitely going to help with the effect of gravity. So after every contraction, these kind of positions will help the baby to come down more, descend down more, and also the dilation process is fastened. So that is how the positions and movements are beneficial. Even in the movements, what happens at times, the baby's head is somewhere, slightly tilted, it's not the always in an optimal position. So when we are moving around, when in the form of lunges or walking or rocking, so these movements will again help for the baby to come down into the optimal position. So positioning and movement is something which should be encouraged during childbirth. If everything is going fine, there is no any kind of risk associated, the mother's BP and other factors are all fine, she should be supported to move around. Plus the massage therapy is very, very, it gives a very relaxing impact onto a laboring woman, and she can actually progress her labor very faster. So for every mother, it is going to be a different place where she is going to feel the pain or due to the contractions. For some, it can be back pain. For some, it can be at the knees. For some, it can be thighs. For some, it can be ankles. So wherever they feel that they have the pain, they can be given the massage onto that area. Also, TENS can be applied. So if the TENS, it is one of the physiotherapy modality that we use, and it is safer to be used on pregnant women during pregnancy also, and at the time of labor also. Only that we have to see that we are not placing TENS somewhere where the baby's head or the heart is close by. So applying TENS onto the back is something which can be very easily used, and it can also be taught to them if they have a portable one, if they want to use by themselves, that can also be done. Cryotherapy and the thermal therapy. So depending upon a woman's liking, it can be either she want to use hot water or a cold water compress, and many women these days, they are using water immersion as a very relaxing technique. So either they go and sit under the shower in a way that whatever the water is coming, that would be actually coming onto the area where they are feeling the pain, whether it is back or it is, the knees or ankles. So they dip their ankles into water, or they are sitting in a way that the water comes onto their back, which makes them, relax at that moment. And also, some women actually immerse themselves fully. So I also being certified as a water work practitioner, I have assisted women and I have seen them benefiting much, they're very relaxed when they are inside the water, and in the birthing pool. And many women, when they are birthing inside the pool, also the chances of perineal tears are very, very less. So water is helping them to relax. At the same time, the area around the perineum, it becomes so soft, and the stretching is very easily being done. and the perineal tears are very less. So there is very least chances of episiotomy if they give birth to the baby inside the water. So that is one of the ways of actually using water as a relaxing tool. And being a physiotherapist there, you know that what is the role of water when we are using it as a cryotherapy or as a thermal therapy. Here again, there would be some women who would like as a hot pack to be relaxing, and some would be very uncomfortable with the hot pack and they would like to go for a cryotherapy in that form. So whatever they like, we can actually help them out with that. Relaxation techniques, see, the progressive relaxation techniques can be used, and plus other positions that can be given in between sideline positions, or they can be actually made comfortable with the number of pillows so that they are more relaxed in between the contractions, because contractions are something which are not going to be in a continuous way. There would be time in between the contractions for her to relax. So we can also help her out with different positions to relax in between, to take a small power nap so that she can be ready with more strength for the next contraction that is coming up. And as I was saying, breathing in the first stage of the labor and breathing in the second stage of the labor. So breathing in the first stage of the labor, that means breathing during the contractions. So whenever a contraction is coming, breathing is going to help her with relaxation, right? Plus the oxygen supply. She will feel the pain intensity to be very less. And that is what is being said, that she should just kind of continue breathing. She should not hold her breath when the contraction is coming. So whenever the contraction is coming, she can actually divide it into between, waist level long breathing or the chest level breathing. So when the contraction starts, the waist level breathing can be done. When it is at the peak, the chest level breathing. And again, when the contraction fades away, she can also go back into the waist level breathing. And this, again, there should be some freedom to be given to the mother so that she can come out with her own patterns of breathing. It should not be that we are teaching her one particular pattern, because she may actually come out with her own way at that moment, depending upon the pain and depending upon how much intensity of pain she is feeling. And if she is given the freedom to breathe out, to sigh out loud, so she can actually come out and get relief in a much better way. The only thing that we should promote her is, if she any moment tries to hold her breath, we should always ask her to look into our eyes, start breathing with her, right? You can say that, see, I'm breathing, you also start breathing with me. That is what is something which is important at that moment, that she should be breathing and not holding her breath. Second stage breathing. Here, the second stage breathing or the push breathing, it is being said that, whenever we are breathing out, our pelvic floor muscles, they are, kind of contracting. But here in the second stage, when we are doing it, the breathing as a push breathing, with the exhalation, it should be always that a command should go at the same time for the pelvic floor muscles to relax. And that is being found with the jaw open. It is said that whenever we, there is a coordination between the jaw and the rest of the muscles to relax. So when she would be suggested to breathe in through the nose and breathe out through the mouth, at the same time, she should give a command to all other muscles to relax. Only the uterus is the one which is going to keep contracting for that 1 minute of the labor push contraction phase. So this kind of breathing, if she can coordinate, it will be much easier for the pelvic floor muscles to relax and for the baby to come out. That is what needs to be suggested and made her understand that it is not that holding her jaw back and tightening and pushing, that won't be much, effective, but it is when she opens her mouth out. It is as good as, when we are, we make a good sigh. So when we make that, we are opening our mouth and we are actually giving that information down there to relax completely. So this is what we are going to suggest them at the time of, for the preparation of childbirth. So she can, the massage can be given wherever we want, on the belly, on the back, ankles, can be used, water and hot and cold packs. Now coming for the lactating mothers. So during breastfeeding, so what could be the role as a physiotherapist for the breastfeeding? So very first important thing that I learned was that for a successful breastfeeding, it is very, very important for a woman to be in a very good posture. If her posture is not correct, she may land up with the sore nipples, she may land up with the cracked nipples, bleeding nipples, engorgement, mastitis, baby not gaining weight, cranky baby, jaundice to the baby, you name a problem and it is related with the posture. So for us as physiotherapists, it is very, very important to make her understand what a good posture for breastfeeding is. She should be well supported. Her back should be straight, but that doesn't mean that she has to put pressure onto her C-section or the episiotomy stitches when she is feeding. She can go into a laid back position where still her back is straight, well supported, shoulders are relaxed, and the baby onto her instead of she bending over onto the baby. Very, very important, the posture. Then is the engorgement or the mastitis. That is something which we can support her. And keeping in mind about the anatomy of the breast, where all our tissue mass for the lactating mothers, we have the areolas and all those things. So we have to make sure that we are not pressing onto that area. And for the engorgement and mastitis, the most important thing is that we should suggest them to keep feeding. Plus, we have to also make them understand about the massage and the positioning of the hand. So why does engorgement take place? So engorgement takes place when they are actually not holding the, they're either pressing too tight the breast. If they're pressing too tight, they might be pressing the milk ducts. And if the milk ducts are being blocked either by the positioning of the hand or either by, if they are wearing something very tight sling or a tight bra, that can be, that can make the muscle, the tissues to be blocked onto that area and milk gets stasis over there. So this is how the position should be. Usually, the scissoring that is being done, that should not be done. Scissoring should not be allowed for mothers, and it should be more of a C hold or a U hold, keeping in mind about the tissues for the lactation and the massage. So if any woman is complaining of the engorgement, we need to tell her about the proper massaging techniques, how she has to do the massage onto her breast, and how she has to position the baby for the feeding. So this massage and the feeding should be started with the warm compress. So a slight warm compress, not the very hot one, and then the massage, feeding the baby or pumping the milk out, and then finally with the cold pack. That is how we are going to help her, and we should encourage her to more and more express her milk. If it is not, still she is not able to benefit with it, we can also give her the ultrasound massage can also be given. We can use our ultrasound therapy for her to increase the blood circulation onto that area. Plus the positions, as I was discussing, that she should be more of in a relaxed position in different kind of holds like cradle hold, cross cradle, football hold, and the sideline position. In all the positions, the baby should be close enough to her. She should be more relaxed and not bending onto the baby and baby coming onto her. So this is what is, related to the engorgement and mastitis. Even in mastitis, this is something which, if the milk doesn't come into the circulation, the bacterial growth can take place and it may lead to mastitis. So the, treatment part and the management is that we should encourage her more with the proper massage techniques and expression of the milk, which is initiated by a warm compress and ended up by a cold compress. Carpal tunnel syndrome is something which is very commonly found because of the way they are holding the baby at the time of feeding. And usually it is being seen, from the second, third month when the baby is growing and the weight of the baby is increasing. So we should always suggest them that they should be actually, properly holding the baby. And if we have to give them, so this thing, any kind of ultrasound therapy or splints and all can be given to ease off the carpal tunnel syndrome. And during breastfeeding, also there is, involution at the uterus. So every time, whenever she sits and she is feeding, she may feel that there are certain contractions that she's feeling around in the uterus. So these contractions can, she may feel that this is something to be worried about, or she is, she takes it as a very painful thing. So we have to make her understand about this thing, that this is something which is normal to happen. And plus the back care. So we should always, not only at the time of breastfeeding, it should be other positions whenever she's, changing the, baby's nappy. So what kind of advice do we need to give? Also, if we have to, kind of help her out with, if she's, baby massage, baby bath, and all those techniques, we can help her out with the back care. Plus, during breastfeeding, there is one more, issue that starts with is the vaginal laxity. Because of the estrogen deficits, she will still feel, the muscles have not tightened that much as they were earlier. And some of them may even feel dyspareunia. So there is a laxity, plus there is a dyspareunia, which is actually a combination that I see most of the times. And it could be because of, that they have not been doing the intercourse now. There was a gap. And also now, because of either the episiotomy stitches, or they have, psychologically, they have this thing in mind that it is going to hurt me or it is going to pain me. So they have this kind of problems. So vaginal laxity is something which is very common to happen. The extent may differ from woman to woman depending upon her exercises, or she was, how active she was during antenatal. She has an idea about the pelvic floor exercises, but the weight of the baby, and if she had, normal delivery, she may even feel slightly more laxity because of the episiotomy. So we have to maintain during this period itself, during the breastfeeding period, which we usually say that 6 months is the exclusive breastfeeding period where we all promote the breastfeeding to happen. This should be the time we should encourage her with the perineal exercises also. So we should be helping her out with, if she's coming to us, we do need to examine properly, about her perineum, about the stitches that are being healed. If she is coming to us with a C-section scar, and during this period, breastfeeding period, we should also take care of her C-section scar, that, well, it is, well taken care of, well healed. There is no pus formation. There are no, redness or nodules over that area. And then further, we can actually help her out with the exercise part onto this, so that they can actually make this pelvic area more stronger. So we, physiotherapists, can actually help a postnatal mother to, during the time of breastfeeding also. Not only that we have to actually focus only onto the postnatal exercises or postnatal weight loss, but during breastfeeding, it is very, very important, because it kinds of motivates her. She feels herself more worthy, that I am able to, breastfeed my baby. And mostly not able to breastfeed is being seen that, she was not, there was some pain while breastfeeding, or there was no support from the family for the breastfeeding. So as physios, we can promote this thing, and with our vision of, making this silent suffering to end, we can actually do a lot of work as physiotherapists in childbirth and lactation. So with this, I end my discussion over here.
Thank you very much, Dr. Shalinta. It's always great to have a word from you. And so for today, we have our next speaker, Dr. Nidhi Vadhva Desai. Dr. Nidhi is, she's also a women's health physiotherapist, and she has done her PGDC in women's health from the University of Melbourne, Australia. She had done her childbirth educator and exercise prescriptionist from Victoria University, Australia. pregnancy and post-delivery fitness expert. She's a lactation consultant, and she's extremely passionate about her work. And currently, she's working with 3 gynecologists and also as a part-time lecturer at a physiotherapy college. And apart from all this, she's doing apart from running her own fitness studio, and she's solely dedicated to women. And on the top of that, she's a mother of 2 lovely children. So let us welcome her on her. Let us welcome her for the topic to deliver on role of physiotherapy in antenatal exercises and Pilates. Over to you, Dr. Nadine.
Thank you so much, Dr. Dara, for the lovely introduction. And good evening to everyone, to all the panelists and to all the participants as well. I'm very honored and very glad that I'm part of this conference as one of the speakers. And I would love to share whatever I can in the 20 minutes allotted to me. And thank you to Khyati Institute and Khyati College for organizing this with WOW IPRE. And it's a great platform where we can share our knowledge, our experience, and how we are working in this field, bringing new innovations in the field of antenatal physiotherapy. Every few months, every few weeks, every few months, we upgrade our knowledge, and it's these kind of platforms give us a space, give us a way to talk about that and give it back to our fellow physios so that they can start incorporating and they can learn more about these methods. I will start sharing the screen. All right, so as we are learning today about the benefits of antenatal physiotherapy. So the reason why it is so essential, especially in current lifestyle and today's time and era, that people do exercise during pregnancy, is because just like earlier times where people used to be so active and they used to do everything on their own, there was not much need of specific exercising. That their bodies adapted to pregnancy and the changes that happen during pregnancy very nicely and very smoothly. However, in today's time and world, there are working women, we have domestic help, there could be possibility that they are into a sedentary work and a sedentary lifestyle. Hence the need of having a structured, a proper prescribed exercise program is very essential in current time. So, and also during these 40 weeks of pregnancy, the way a woman's body changes is beyond the scope. I mean, if you think of it as a life, in the whole lifetime of a woman, these 40 weeks of changes that happen are at a scale which is beyond the scope of change otherwise if they were not pregnant, right? So the physical and physiological changes are at a scale that do not happen otherwise in such a short period in the time of your life. And some of these changes stay permanently in the body even after postpartum. And major changes are seen in hormone regulation, cardiovascular system, respiratory system, and musculoskeletal system. A lot of more, but these are what we majorly look at. So before I tell you more about how exercise benefits, I want you to understand why exercising is so essential and what really is a part of antenatal exercises. So we are going to only look at a few important things because we have to cover a lot of things. The physiological changes that we see in pregnancy in the cardiovascular system, which is very essential for us to know in terms of planning their exercises. The heart naturally becomes more efficient. There is an increase in the blood volume, about 35 to 45% increase in the plasma volume, which results into hemodilution, which increases your cardiac output, and there is an increased load on the heart because there is more venous return and there is more stroke volume as well. And the heart rate goes up by 10 to 20 beats per minute and by 50% by the end of first trimester, which is very significant. Now, these changes all start within the first 7 to 8 weeks of pregnancy. So you have to consider from that point till the end of pregnancy, what amount of changes would take place in the entire 40 weeks. Next is, if we look at the respiratory system, there is an increased level of progesterone, which causes upper respiratory tract congestion, which is the reason why very early in pregnancy, even when the uterus and the baby is not so big, even then the mothers face the issue of shortness of breath. They feel tired and fatigued because of this shortness of breath, which is caused by progesterone. Pregnant women hence breathe very deep, and because they're trying to maintain sufficient oxygen supply for themselves. There is an increase in blood volume, which increases the venous return, and hence the load on the pulmonary system is also heavier than normal. In late pregnancy, uterus starts pressing right up and under the diaphragm, which makes it even harder for them to breathe. So again, there is a compensation for the breathing part. And this is one of the reasons why we start breathing exercises from day one of our prenatal class, from day one. There are certain things that we do as a prevention, and breathing, relaxation, pelvic floor exercise, these are all part of our classes from day one, whether they start at week 13, whether they start at week 30 or they start at week 37. We look into these from day one of the class. Some women also feel that there is a rib pain, and that the reason is because the ribs flare laterally and anteroposteriorly, both to accommodate the changes that are happening in the abdominal cavity, also to accommodate the uterus. Now let's quickly look at the changes that happen at the hormonal level, which affect the physiology of a pregnant woman. So we are looking at temperature changes, which are again caused by increasing levels of progesterone in the body. So by default, by the presence of progesterone in the body, the temperature, the core temperature of a pregnant woman is higher by 0.5 degrees Celsius. And the metabolic rate also goes up by 15 to 20% at rest. Now this point, that the metabolic rate goes up by 15 to 20%, this gives us a baseline to start our aerobic and cardio activity for this mother. This is the reason why we stay at low to moderate intensity of exercises, because the resting metabolic rate is also high, right? So we can use it to our benefit when we are giving and prescribing the exercises. Next is laxity of joints. Progesterone and relaxin together cause chemical changes in the composition of joint ligaments. And because of that, the soft tissue structures and the ligaments, and to an extent some tendons, also become soft and relaxed. Relaxin also creates an unstable ring around all the joints. It does not, ideally it is supposed to act on your pelvic girdle, but it's a hormone, and it is circulating in the blood, and it affects almost all the joints. And if not taken care of, the small aches and pains that come, the pregnancy-induced discomforts that mothers have during pregnancy will be inflated. And this is one of the reasons why we start strength training. We focus more on strength training of the parts which are more affected by relaxin and progesterone, and we stretch the other parts in preparation of labor and childbirth. So relaxin also softens your structures such as pelvic floor, and the weight of the uterus also compromises the integrity of your pelvic floor functions. So again, as a preventive, as a part of preventive physiotherapy, we start pelvic floor training and rehab, irrespective whether they have incontinence or not. We start the training and giving rehab to pelvic floor muscles again from day one of the class. Next is musculoskeletal changes. So there is an increase in body weight, which is obvious, which is a physical sign which is seen. There is weight gain during pregnancy. There is shift in the center of gravity. The center of gravity shifts anteriorly because of the growing uterus in the front. There is decrease in joint stability. DRAM, which is your diastasis recti abdominis muscle, which means the muscle starts, your rectus abdominis muscle starts separating at the level of linea alba, at umbilicus above and below also sometimes. There is pelvic floor dysfunction, and of course there is weight gain that we've already talked about. Now let's talk about what is a part of antenatal exercises. So we know what tool can be used in terms of benefiting a particular discomfort that arises due to pregnancy. So a lot of people think when people approach me for pregnancy exercise, that the common misconception is that we will be doing prenatal yoga only. However, that is not the fact. Antenatal exercises have a long list of things that you can do. An antenatal class, or a prenatal class as we call it, it comprises of a lot of things which are done differently. There is a flow to the class, there is a structure to the class, and each and every class is planned. As Dr. Vinoda also said, the treatments are subjective. Even though they're working out in a group class, there will be subjective attention given to the particular needs of a particular person. One thumb rule does not apply to all. One kind of class does not suffice for everyone. So hence we use different tools and we use different techniques and exercises to incorporate in our classes, which means we have our yoga, we have prenatal Pilates, we have cardio, meaning aerobics. Sometimes it becomes very strange for people to know that how can you do aerobics during your pregnancy, but yes, you can. You have your principles, if you follow your FIT protocol, your frequency, intensity, time and type protocol, you can definitely do everything within the limits of pregnancy protocols. And believe me or not, it is by far one of the best tools I find to keep the mothers not only active, flexible, their stamina goes up, their endurance is higher compared to those who are not doing cardio workout during their pregnancy. Another tool is strength training, which we do with the use of weights or the body weight itself. We do flexibility training. Postural correction is, of course, one of the most imperative parts of our classes. We do gym ball workouts. Then there is labor and childbirth class and counseling. There is lactation counseling, as Dr. Chalinta said. These are very important parts of a prenatal class where a mother is overall prepared for childbirth. She's given the information about labor to lower her anxiety, ways to make her labor go shorter. Positioning, everything is given. Lactation counseling is very important during prenatal, because as soon as she delivers, as soon as the childbirth happens, lactation is a part of her life from 0 hour of her postpartum period. Diet and nutrition is something that we give them guidance on, and postpartum counseling is a part of our physiotherapy classes. Now let's look at the overall benefits that we get from exercising, and then we discuss some individual. Of course, it is out of scope to discuss a lot of things, but we will discuss some major pregnancy discomforts and how we can help them and how benefit the mothers to prevent those discomforts or to train them to not have those discomforts. So let's look at the overall benefits first. Now, with the workout, when you do this kind of a flow, so let me first tell you how a typical antenatal class goes. So just like any other exercise class, there is a flow to the class. First we have a warm-up, then we have the workout, then we have the cool down, then we have the stretching part, and then we have the relaxation and pelvic floor exercises that we do. So this is a typical flow. Now some things keep changing, which is the warm-up, cool down, stretching, pelvic floor, and the relaxation part is always there in the class. In between the workout part, we keep changing. We focus on different parts of the body on different days. And when we do this kind of a structured workout where we address to each and every part of the body, the benefits are immense. And that's what I'm going to discuss now, what benefits we are looking at. There is increased fitness and endurance, which means there is less fatigue, which is one of the major discomforts of pregnancy. They almost all working out, mothers who are exercising during pregnancy regularly, their fatigue levels go low as soon as they start working out. Strength of leg, abdominal muscles and pelvic floor muscle increases, which means during labor, it will be much easier for them to push the baby out. And the postpartum recovery also will be much quicker. There is an increased coordination and increased level of coordination, balance and flexibility, which gets affected because of weight gain and the shift of COG and because of softening of the ligamentous structures. There is decreased constipation, which means there are decreased chances of prolapse and incontinence. There is an improvement in the posture, which means either you can prevent or you can completely treat low back pain in pregnant women, and low back pain is almost present in all pregnant women. At least at some point of their pregnancy, they will complain of pain in the low back pain, in the low back area. It also means that your curvature of the spine, when you're teaching them how to maintain a neutral spine, so a lot of concepts have changed in the last few years related to biomechanics and Pilates. A lot of concepts have changed. I will discuss them in a due course of time. But currently, the latest evidence suggests that instead of maintaining posterior pelvic tilt, which will relieve the strain of low back muscles, the ideal scenario is to maintain a neutral alignment of the spine and improve the posture, which is a great way to maintain their integrity of their low back muscles and also the core muscles. Besides that, there is an increase in self-image and self-esteem and body image. That is very important to the person who is working out. Think of a pregnant woman who gains about 10 to 15 kgs or more during these 40 weeks of pregnancy. Her self-esteem and the way her body is changing, working out, exercising, makes her feel that she is doing something good for herself, for her body, and for her baby. It gives her a sense of productiveness, and she feels like an invested mother, which is very important for their mental health. Very, very important. There is a lot of stress relief. Now, we all know that exercising relieves dopamine and serotonin, which are extremely essential for anybody to elevate their mood, right? And exercising is a natural way to release these hormones, and these chemicals really help in relieving the stress. One of the most important benefits is weight gain control. With the current lifestyle and with the current scenario with the eating habits, late pregnancies, we are seeing a high number of women who are gaining a lot of weight, and they're gaining weight out of the range of the weight that they should be gaining, which is different for everyone. Again, there is no particular number of kilograms that one can gain. It depends on their pre-pregnancy weight. However, we are seeing that because of excessive weight gain, there are other issues that develop, such as gestational diabetes, even though they were not they did not have a pre-diabetic history or predisposing factors that led them to gestational diabetes. But we are seeing that very frequently now. I would say that I'm seeing gestational diabetes in at least 3 or 4 women out of 10 that I'm treating. The number of gestational diabetes has gone that high. Also, we are seeing a lot of cases of PIH, which is pregnancy-induced hypertension. And after 12 years of practice, I've come to one conclusion, that people who are exercising are definitely preventing a lot of these issues. And it is not just about prevention, it is also about maintaining a healthy heart, healthy blood sugar levels, healthy blood pressure levels during a pregnancy, to avoid a lot of other pregnancy related complications, right? So we've seen a great reduction and even regulation. Even people who have gestational diabetes or have PIH and they work out, we find that the regulation of blood sugar levels and blood pressure levels are very well maintained when they are exercising at least 3 or 4 days a week during pregnancy. Fit people burn more calories than unfit people, which is a universal rule, and that leads to less fat deposition in the body. So yes, exercising is something that is imperative in today's lifestyle and should be incorporated in one or the other way while the person is pregnant. also a group class is very essential. Now things are getting back to normal. Now we've already resumed our physical classes along with the virtual classes. The only thing that I was missing in the virtual classes was that group feeling that we had when we had these sessions. I'm sure a lot of the panelists who conduct prenatal classes can correlate to this feeling that when all these mothers get together and work out together, there's a different feeling of belonging to a community. They don't feel alone in this journey. And this really helps to manage their mental health levels. They talk, they discuss about their problems, we solve them. They feel happy when they're doing their classes, and it's a great feeling to be a part of a group class. So it really helps them to develop that community feeling that they are part of something and they're not alone in this journey. Now let's look at some major discomforts that are present during pregnancy and how exercises can help. So first being low back pain. It is one of the most common discomforts during pregnancy, and almost 100% of women at some point in their pregnancy will have low back pain due to the biomechanical changes and other physical changes that are happening during pregnancy. Now the correct exercise forms such as prenatal Pilates, core cylinder bracing, canister breathing, also abdominal bracing correctly will start maintaining the integrity of their core and will prevent diastasis recti. And when we can prevent diastasis recti, we are directly reducing the load on the low back extensor muscles. And when we reduce the load on lower back extensor muscles, we are automatically balancing the spine, because the front of the spine and the back of the spine and the whole so earlier there used to be a lot of importance about the anterior aspect of the spine and posterior aspect of the spine, but now the concept has completely changed. We are now looking at core as an entire canister, as something that is encircling around the spine, and we try to co-contract all these muscles together to maintain the integrity of the spine. Right, so exercise classes which focus on low back pain, stretching, rotational movements of the spine, all of these will help when we are looking at low back pain. The next, I'm going to go a little quickly because we're short of time. So SPD, which is symphysis pubis dysfunction, or pubic symphysis dysfunction as we call it. This also is one of the results of relaxin being present in the body. So there is an excruciating amount of pain at the level of pubic symphysis. So we give them preventive exercises so that they can altogether prevent. We give preventive measures in terms of how they should move, turn, sit, stand, positioning, coming out of the bed, going to the bed, getting in the car, getting out of the car. Just like how we do for round ligament pain, we similarly do this for pubic symphysis also. And we try and avoid the pregnant waddle. We incorporate certain relaxation techniques. We use gym balls. We use a lot of exercises, anterior and posterior pelvic tilting. And this on the right side that you see is a abdominal spider. This is kinesiology taping that we use to lift the pressure off the pubic symphysis area. And this spider taping lifts the weight off, and the mother feels much relieved in terms of pain. Also, when we're looking at low back pain, we want to make sure, and even SPD, we want to make sure that they learn how to maintain a correct posture. So if you see this image here, there's an exaggerated lordotic curve, which with the help of co-contraction of your muscles can be reduced and neutral alignment can be achieved. If I show you again, this is how it looks. Now, next is management of shortness of breath, which is again there, and it remains till at least 38 or 39 weeks when the fundus drops and the baby moves down. Till then, there is a lot of shortness of breath. And this is one of the reasons why a mother is tired and fatigued all the time. So we incorporate, like I said, we do aerobic workout. We give them 10 to 12 minutes of cardio workout at low to moderate intensity. With proper choreographed steps. We give them deep breathing exercises, which deep breathing meaning When we are involuntarily breathing, our breath rate is somewhere around 14 to 16 breaths per minute. We try and bring it down to half, which is 7 to 9 breaths per minute. Breathing in from the nose, out from the mouth is something that we help incorporate, not just during the classes, but also when we start labor preparation. These breathing techniques help a lot. Mouth breathing, deep breathing, accelerated breathing, sighing while breathing out, all of this helps and maintains them to breathe nicely, gently, even during their labor. Also, when we are looking at other discomforts, diastasis recti is one of them. About 52% of all women who are pregnant will probably have diastasis recti at the level of umbilicus, and some of them also have above and below. Correct amount of prenatal Pilates can prevent, not only prevent, even the postpartum rehab is very quick and very fast in such women. So we not only try and prevent diastasis recti, we also try to manage the integrity and the strength of the entire core. All right, so also we focus on strength training. Strength training is something we give them with the help of body weight and external weights. It really helps them maintain the strength of all muscles. We do a lot of upper body strengthening. We do upper back strengthening because that helps them. Upper body strengthening and upper back strengthening helps them in the postpartum period when they're sitting and feeding the baby for very long, holding the baby to burp, lifting the baby. So they need that strength, and they also need that flexibility in their upper body to manage postpartum. So it is a very essential part of our exercise program because it helps them deal with a lot of issues while pregnant and postpartum. Even for the lower body, we incorporate a lot of lunges, squats, and a lot of strengthening exercises to start with. And flexibility is obviously a major part of prenatal exercises because whatever you strengthen also needs to be flexible. Strength does not mean tightness. Strength means ability to contract and contract strongly, and flexibility is a part where this strong muscle can also relax. Just like we train our pelvic floor muscle not just to contract, but also we teach the pelvic floor muscles to relax. Similarly, all musculoskeletal muscles of our musculoskeletal system need to learn how to contract and should have sufficient flexibility to maintain a good joint integrity and avoid the small aches and pains. In nutshell, yes, I just need 2 more minutes. I'll be done.
Thank you.
Yeah. So when we're looking at other major discomforts which are pregnancy induced, these are the following things that we can prevent and help with the exercises, starting with hemorrhoids, constipation and gas, insomnia, carpal tunnel syndrome, heartburn and reflux, cramps, ankle edema, round ligament pain, morning sickness, heaviness in the pelvis, sore feet. These are all general. There are much more. There is a long list, but to conclude in short, these are the things that we can help with the antenatal class, with the structured class, and we can give them ease and make it a comfortable journey for them throughout. In group classes, we also have counseling sessions, one-on-one or in group. We talk about labor, we prepare them for childbirth. We have lactation classes. We teach them how to do perineal massage so that they have minimal tearing or episiotomies can be avoided. We teach them about each stage of labor and breathing through that labor. And we also give them guidelines about baby care, which means how to massage the baby, take care of the baby. Everything is a part. It's a holistic class. It's not something that you will only do in form of exercise or in terms of teaching a particular thing. But all in all, an exercise class which is structured with a flow will always have a lot of benefits to give. And I've seen that in my 12 years of practice in this field with women. People who did work out and people who did not work out, their recovery period, their going back to normal is so much better in the mothers who did exercise. Their labors were smoother, their lactation phase went smoothly. So we see a lot of benefits in that way also. So that's all, and thank you so much for listening to me, and thank you, Dr. Dhara. I'll stop the screen share now.
Thank you very much for your wonderful talk on and sharing us and importance of sharing us the insight on the importance of antenatal exercises and Pilates. So thank you very much once again, Dr. Nidhi. Thank you, Khyati College of Physiotherapy, Khyati Institute of Physiotherapy, IAP and IAPWC and IAP Digital team for being with us since the whole day. And I'm so much thankful to Hate Sir for bringing these topics up in limelight when it is really the beginning of the war again. It is really like we are fighting a war against a silent suffering, and the silent suffering will not be silent anymore. So the vision what Sir has seen and the mission with which he has started this, it's very much pleasure to see that coming out to be true. Thank you, Hate Sir, for giving all of us this strength and courage to speak up and talk about these topics which were underserved, though they were important. So once again, thanks all of you, and we will be continuing a session for tomorrow. We all will join by 1 o'clock, and for tomorrow also the session will be 1 to 6. Thank you. Bye-bye. Have a nice evening.